Okay, so I'm delighted to announce that our chair for this morning will be Mohi Keita, who is a regional advisor in infectious hazards preparedness for the Regional Office for Africa, or AFRO, as known to many of us. So Mohi will be leading us through the agenda for this morning, and I would like you to give him a warm welcome as I hand over to him now. Thank you, Mohi.
Thank you so much, Haki. Thanks, everyone. Once again, welcome to this second session. I think the first day was a great success, and I hope today will not be different. Yeah. So this second session, I would say maybe the first part of this second day session, which I'm in charge of moderating, will focus on yellow fever risk analysis and the resurgence of yellow fever outbreak and opportunities to address. Okay, for us or for those who are working in the emergency, risk analysis is very important as emergency preparedness journey start with risk analysis. And as you know, today's session will also be giving the opportunity to partners to address some few words. So I'm delighted to call on Aurelia Nguyen for her presentation, but this presentation will be on video. So over to you for the presentation, Aurelia Nguyen.
Just give us 1 second while we get some sound for you. Aman?
Gavi's multiple types of support, including preventive vaccination. Good morning, and my warmest greetings to everyone in Addis Ababa and to the many participants joining online from all over the world. Regretfully, I can't join you in person this year, but I am grateful for the opportunity to addressing you today on behalf of Gavi as a key partner of the I strategy. We are now less than 3 years from the end of the strategy, and we have made great strides towards our goal of eliminating yellow fever epidemics. Gavi's multiple types of support, including preventive vaccination, outbreak response activities, and support for diagnostics, have helped countries adapt to increased risks. In this strategic period alone, from 2021 to 2025, we expect to invest $475 million to immunize 263 million people against yellow fever through routine and preventive campaigns. This is down to the ongoing dedication and commitment of everyone engaged in yellow fever activities across the world. We have also made significant progress towards the faster confirmation of yellow fever epidemics through increased laboratory capacity and diagnostics procurement. Gavi's support for yellow fever diagnostic testing capacity in Africa has reduced the time needed to confirm cases by 63%, thereby promoting faster decision-making and response, and has helped to improve countries' ability to target the use of the vaccine. There are many successes to celebrate since I's inception in 2017, which I believe can be attributed to our synergistic collaboration as a global network of partners. The I partnership has also helped us to continue our important work through the challenges we have faced, including the COVID-19 pandemic, and we will remain key It will remain key to support countries through increased risks, such as those associated to climate change. This annual meeting is a critical opportunity for us to address the potential risk to the progress achieved and the existing challenges to our work and that we have ahead. For example, there is a worrying resurgence of yellow fever outbreaks, particularly in countries with a history of vaccination campaigns. Work has already started to understand options to close immunity gaps, while sustaining in parallel the effort to improve routine immunization systems and achieve high population coverage with yellow fever vaccines. This must remain a priority so that the gains achieved through the eye strategy are sustained in the coming years. Yellow fever routine coverage in countries that are at risk is still below the desired levels. It is at 44%. Efforts to improve this would require strong commitment from countries and the engagement of all the eye partners. When we come together like this, we are able to take stock of how far we have come and what we need to do now to reach our goals. Gavi is proud to be part of this successful partnership and of the progress achieved, and we look forward to the outcomes of this meeting to foster our collaboration and increase the impact of our common work. I am confident as we discuss the future that greater achievements are on their way. Have a great meeting. Thank you. Good morning, and my warmest greetings to everyone in Addis Ababa and to the many participants.
Can you stop the video? Okay. Thank you. Thanks to Gavi for all their present and future support for the implementation of the eye strategy. I'm now going to call on Erin Staples for her presentation on risk assessment working group update. Erin is risk analysis. Erin is the risk analysis working group chair. She is a medical epidemiologist working at the US CDC. Erin, you have the floor.
Thank you. Sorry, there's a download issue due to internet speed. And that was my fault as I got the presentation late. It's my honor to speak to you again today in my capacity as the chair of the working group. We've had some routine and regular meetings now, and I just want to provide some of the highlights from the last year of the work that we've been doing. And some of this will be very familiar because some of the slides were shared previously. So the next slide, just to talk about the annual updates to the risk in African countries. Next slide. Just to remind everybody, we have as a risk group developed a tool that was specifically designed to be used in the 27 high-risk countries for yellow fever in Africa. We had the methodology approved by the working group and also presented it at our annual meeting in October of 2020. The tool, to remind people, focuses on key variables to define endemic and epidemic yellow fever risk. And essentially, it's somewhat simple in the sense that it awards points for activity or factors that would increase the risk, and more weight or points are given for more recent activities. And we broke down it into endemic risk, so looking at confirmed human disease cases, and we wanted to use Addis africanus, but we did not have good coverage from each country, as well as non-human primates. So we used land cover as a surrogate for knowing where the risk might be. In terms of epidemic risk, that really gets at how big an outbreak can get and could there be an outbreak. So looking at when was the last case, is there activity in areas around the area or the country we're looking at? What's known about the presence of Aedes aegypti, the urban vector for it, as well as population density. The higher the population density, the larger the urban centers, the more likely you are to have a large explosive outbreak. And the last thing we use is infrastructure and capacity. So, and we use a uniform index. And while it would be great to use more specific, and several countries have more specific information that could represent risk, we want to be able to compare one country to the next using the exact same type of data, and that's why we've used some surrogates in the national risk assessment. And then finally, we also include yellow fever vaccination activities, and they're given negative points. So we take away risk points based on the coverage of vaccination through the EPI program, as well as preventive and reactive campaigns that have been conducted. And then we do update this mid-year, usually after the WUNC estimates come out. So it's usually in early July that we update that. And it's followed by a discussion by PMG. And it is one of the variables that are considered when looking at vaccine allocation for that year. There are several other variables that are considered in terms of countries' ability to absorb the vaccine, to conduct the campaigns, additional information, but this is just one of those elements. Next slide. So just to highlight some of the key changes, and we look over the last year, but again, we are looking mid-year to mid-year, which captures the seasons pretty well, which tend to occur around the new year. In terms of endemic risk, there were 14 countries that had reported some confirmed yellow fever cases since we conducted the last risk assessment. The ones that had a notable increase or it impacted their score were Niger, Mali, and Togo. And Togo mostly because they hadn't reported cases for a while, and by reporting a case that changed their omega score that we use in the endemicity risk. In terms of epidemic risk, we continue to work every year to update the presence of Aedes aegypti. There are more and more publications or more data that comes available, so that was increased in several countries. There were a few countries that had done and had updated population estimates and densities, and then we also had, as already mentioned, the increased yellow fever activity in several areas led to a contiguous score, meaning a country got a point because the neighboring country had scored a case. And then for mitigation, there was stable EPI coverage, but out of the 27 countries, 22 countries still have coverage less than 80%. So they are not reaching optimal a number of points that could be deducted. Congo, DRC, and Nigeria had completed their preventive mass vaccination campaigns, at least one phase of it, or if not all of it. And Sudan completed their catch-up campaign. And then finally, there were reactive campaigns conducted in 6 countries. But overall, those reactive campaigns are very focal. And when we do an estimate, we're looking at the proportion of the population that's covered. And it's usually too small of the proportion to impact the scores significantly. So the next slide was actually shown briefly for you yesterday, thanks to my Afro colleagues. But this is what the updated scores look like in June of 2023. We still continue with our highest risk countries being Nigeria, DRC, and Cameroon, followed by Ghana, Uganda, Guinea, Cote d'Ivoire, and Ethiopia in terms of having the highest risk scores overall. 17 countries out of the 27 increased their risk score compared to the assessment we did 1 year prior. But the 6 countries were able to decrease their risk score. That included the Central African Republic due to their campaigns, DRC, the same with their campaigns, Congo, campaign, Ghana, and Kenya, and Sudan. And Kenya was, after having activity, they did not have any activity reporting during the time frame that we used. Next slide. Because it's very hard to compare one raw score of, if someone gets 42, is that meaningfully different than 41? We end up doing a risk ranking. So those that have the highest score get the highest risk, or in this case would be number 1 in terms of the risk. So our 4 highest ranked countries in terms of yellow fever risk have remained the same from the prior outbreak, prior assessment to this assessment, and that included Cameroon, DRC, Ghana, and Nigeria. And already mentioned, we had 5 countries that increased their rank score compared to the year before: Benin, Ethiopia, Liberia, Niger, Sudan, South Sudan, and Togo. So that's what we did and presented, and that was included in the discussions for the vaccine allocation. Moving on to the next slide, which I'll just transition into the subnational risk assessment. You've heard it mentioned, particularly here in Ethiopia for the context. So the subnational risk assessment is really meant to assess yellow fever risk in a country, comparing one area to the other to facilitate a phased, planned mass vaccination campaigns. It is not meant to predict where there's going to be a case. It's meant to say, based on all the information that are available, this area is most likely to be, or is actually considered to have the highest risk, and probably should be targeted earlier in the phase campaign. There's also considerations that go into the phase campaign, like logistics. You're not going to target one area in one location and then another extreme area when in fact maybe the third area is next to another. There's other rationale that goes into figuring out how to submit the phase, but this tool provides some objective evidence to assess the risk in different regions of the country. It was created using many of the inputs of the national risk assessment tool, but it does provide flexibility because we're not comparing Ethiopia, for instance, to South Sudan or Uganda. We are comparing within a country where the types of data that might be available that might be more of a direct measure of yellow fever risk are available, but they have to be available in all regions. If a country's only done a assessment of Aedes aegypti in one location, but has no information about other locations, that's not necessarily fair, because you'll give more points to an area that potentially have done something in other areas that have not. So we do have that flexibility and have used that, but there's 4 key steps to completing a subnational risk assessment. And the first one, which was very successful here in Ethiopia, was establishing a work group of country representatives, Ministry of Health, both from the epidemiologic as well as the vaccination perspective. But we also involve colleagues from animal health to look at non-human primates. We also involve people involved in urban distributions and having better population data and census. Also included, of course, are regional and headquarter staff from WHO and UNICEF, and at least one risk analysis work group member who mostly provides guidance and direction, but doesn't necessarily provide the data. The data in the discussion is really generated by the individuals in the work group, particularly the country representatives. Then the next step after establishing the work group is really figuring out which regions of the countries are going to be compared during the risk assessment. If you look at different countries, you'll realize the first administration level can be very small or very large. Here in Ethiopia, those areas are quite large, into the fact that we had to break some of the first administration level of like Umaria district. We had to break it into 2 to provide reasonable sort of assessments on how to compare one region to the next. And if you compare regions that are too small, then you're going to have a lot of low-level risk and no differentiation. So that is an active discussion. After that, then we get into the variables and the direct measures that could be available to assess yellow fever risk in the country, to be able to compare one region to the other. And then finally, a report is generated describing the actions and the finding of the work group, so that could be then reiterated, shared with partners, and updated as necessary. Next slide. So where we're at with the risk assessment is essentially we have put together a draft document after perfecting the methodology and the associated tools, including some of the adaptations that we've done. We've worked with Uganda, Ethiopia, Chad, and Niger to do their assessments, and each country chose slightly different variables for some of that, but they were all kind of measuring the same thing. We've also created a document describing the subnational risk assessment. We had a risk analysis work group meeting that's currently with the members to review, to finalize, and then we'll be providing that to the Secretariat for anyone's use. And then we'll be able to share that with any countries that might be interested in doing a risk assessment, at least using this sort of approach or tool. And this tool may not be good for everyone. This really, again, for phase campaigns versus a predictive tool. Next slide. The other thing our work group does, sort of related to several of our members, is providing information or updating information about the risk. So I'll ask for the next slide, please. So 2 publications that have come from work group members, which the first, once we get the slides back up, comes from, we put together a perspective on fractional dosing of yellow fever. That's often a question that we get in terms of what could we use fractional dosing? Could we increase that? So there has been a lot of publications, thankfully, since the use of fractional doses in an emergency situation, including Epicentra. Our Medicine Sans Frontières has done some very good studies with our colleagues in Kenya, as well as Senegal to look, and Uganda to look at fractional dosing in a more systematic way. There was a fractional dose publication, if we get the slides up again, maybe, that is available. If not, the slides will be shared, that wanted to highlight. The next is just highlighting, there you go, that's the slide with the paper, and it shows a nice timeline for the fractional dose, what data were available, when the outbreaks were that drove the need, and all of the subsequent studies that have come out relative to it. We also put out a follow-up of the 5-year fractional dose use. So as many of you recall, we ran out of vaccination doses, or at least depleted the stockpile several times during the outbreak response in Angola and neighboring areas of DRC, as well as concurrent outbreaks in Uganda. So fractional dosings were used in Kinshasa as a preemptive campaign to stop the spread. Were able to, thankfully, due to Gavi funding, follow up at 5 years after vaccination. Well, it's probably hard to see, there are figures in the paper, it's more to highlight it, but there is, of course, a natural decline you would expect to see, but most individuals still had what would be considered detectable or potentially protective levels of antibodies 5 years following the fractional dose campaign. So the data are available in that. Then the last slide, in terms of, just wanted to note some of the ongoing and current activities of our work group. As already mentioned, we're finalizing the subnational risk assessment document and the developing associated sort of SOPs that kind of would help a country with operationalizing this. And we're going to continue to assist with subnational risk assessments. I think there are ongoing discussions whether there will be a risk assessment done, a subnational risk assessment done in Kenya, for instance. We will update the scores again in July of 2024 for PMG discussions and vaccine allocation. And we'll continue to liaise with our colleagues in the PAHO region regarding their risk for their need for risk assessments. Several of their countries have already done their independence, so there's less of a clear need, and we've focused on providing assistance to AFRO and also to EMRO in previous years. And then we've drafted a white paper on the risk, we're working on drafting a white paper on the risk of yellow fever to Asia. This is a question that the Secretariat receives from colleagues in thinking about the future of yellow fever. So from the subject matter expertise that exists on the working group, we are doing a white paper on the risk in Asia, and we've just completed the literature review, and hopefully we'll be pulling that together for consideration and probably presentation at the next annual partners meeting. And then we also will be conducting a risk ranking of urban centers in terms of which ones might be at most risk for larger yellow fever outbreaks, probably using very similar metrics that we've established for the national and subnational, but taking other considerations into effect to do the ranking of urban centers. And then there are a few ongoing studies. Dr. Wittenberry mentioned several of them yesterday that we're working with PAHO. We have done a survey among healthcare providers in several countries to assess barriers or why people may not be getting doses of yellow fever vaccine. We have completed the testing and are working on the analysis of long-term immunogenicity among children who received yellow fever vaccine with measles-containing vaccine or separate from measles-containing vaccine 4 to 7 years previously in Argentina. And then we also have, mostly through Eric Mosel's work and others around the table here, a fractional dose study in children in Uganda, which, in addition to the Epicentra data, which was published looking at 1/5 and a full dose, this will also include a half a dose of the vaccine in younger children as a potential way to expand expand doses of yellow fever vaccine that could be available in the case of an emergency. Next slide. This is just a list of all of our work group members, as well as our observers and some of the Secretariat staff that have been involved in our discussions. So we do have many names that you'll recognize. The asterisks are just the original work group members that continue on the working group at this time. And with that, I'd like to end and turn it back to our chair. Thank you.
Thank you very much, Dr. Erin, for this update. Continuing on with the subject of yellow fever risk analysis, I would like to call on Dr. Chiri Kodama and Katie Getrop for the presentation on understanding yellow fever epidemics risk in the moderate to low risk countries. Dr. Churi, let me just try to introduce them because, Dr. Churi Kodama is a medical doctor working for WHO Regional Office for Eastern Mediterranean. And Katie Getrop is a member of the Risk Analysis Working Group, lecturer in epidemiology of vaccine preventable diseases at the Department of Infectious Disease Epidemiology in Imperial College London. I would like also to point out that 1 year ago, I was working with Dr. Chori in the same team and in the same work stream. Before joining AFRO, Dr. Chori and Katie, the floor is yours if you are online.
Yeah, thank you. Thank you very much, Dr. Mori. Do you hear me?
Yeah, we can hear you. Over.
Okay, thank you very much. I'm not sure if the presentation is ready. Shall I share my screen from my end?
We have your presentation on screen. I hope you can see it, Curie. Can you see your presentation on screen?
Yes, I can see that clearly, yes.
Okay, so just ask us to move on when you need to. Thanks.
Okay, thank you very much. So thank you very much. Good morning again. This is Chiyori Kodama. I'm calling in from WHO EMLO, Eastern Mediterranean Regional Office. And we oversee 22 countries in the Middle East and also northern part of Africa. And as Dr. Mori nicely introduced myself, I'm serving for WHO Health Emergencies Program here in Cairo for WHO EMLO. So today I'm going to take you through the understanding yellow fever epidemic risk in moderate to risk, the low risk countries in EMR. Next slide, please. I don't know if you're seeing the presentation in the right format. Somehow I see that it's a little bit blurry. Hello?
Yeah, it's okay. We can read it.
Okay.
Go ahead, Dr. Churi.
Okay. So the EMLO and the I strategy, we actually have a long history with working with the I strategy. So EMLO is an integral partner to the I strategy with a range of high and moderate risk countries. And the region has seen an uptick in arboviral disease outbreaks, and also the yellow fever is a priority. And Sudan, actually, that's the sole and the only high-risk country classified for yellow fever in the region, and also the only one member for the I strategy. And they have taken great steps toward assuring population immunity in the face of marked challenges from other outbreaks to the political changes. And also, as you know, that since last year in May, the country is going through the conflict situation, but despite all those challenges, the country has made a great advancement in the recent years. The region has yellow fever moderate risk countries with shared borders to countries that are high risk and also with recent outbreaks. So there is eagerness very strong eagerness in the region to improve understanding of risks and also take steps to prepare and prevent yellow fever spread. Next slide, please. So we have the increasing threat of alloviral diseases in the region. So as you can see that Sudan is the only country that has confirmed the yellow fever presence and outbreaks. But however, the presence of vectors and also the presence of other alloviral diseases has spread across the region, as you can see. Next slide. And of course, as everybody knows that the mosquitoes, they don't respect the borders. So when we are sharing borders with those high-risk African countries for yellow fevers, that we highly suspect those other the African countries and also some of the countries such as Yemen that has heavy cross-border movement with African countries and also some of the yellow fever epidemic countries in African continent must be under the high threat. So we actually have the changing distribution of the vector, the Addis species. I'm going to explain that in the next slide, especially in previously Addis naive countries, and also the consequences of climate change leading to high rainfall, humidity, and the increasing temperatures, and the flood affecting multiple countries. And the fragile health system, political and financial instabilities, and the complex humanitarian crisis, and the high population movements, and also lastly, the recent yellow fever epidemics in neighboring countries in African continent, which has even increased our alert level to the potential importation or already presence of yellow fever in those emerald countries. Next slide. So this is the data we conducted the WHO regional alloviral survey, and actually when Dr. Mori was here with us, we conducted this survey, and the data collection period was between 2015 until 2021, but we took 2 years since 2021 to until last year to collect the data and also the verification of data with each the country government and also the stakeholders. So this is the confirmed evidence, and as you can see that except those the 4 countries that non-reported at this time, those 18 country and member states in our region, they have confirmed either Aedes aegypti or Aedes albopictus or both. And even those, the 4 countries, Kuwait, Libya, Qatar, UAE, that did not reported at this time, one of the countries has reported the outbreak of dengue last year and also confirmed the presence of Aedes aegypti among those non-reported at that time countries. So as you can see that we are under the increasing threat of yellow fever. Next slide. So this is a bit old data, the yellow fever risk classification in Africa from 2016. And thank you so much for the yellow fever, the risk classification presentation just earlier before this. So if you have done the recent risk classification for those previously confirmed as potential or moderate risk countries, among the emerald countries, it will be appreciated to maybe you can give us an update more on that. But so as of the data from 2016, those the emerald countries in African continent. So Libya, there was no evidence, Tunisia, no evidence, Morocco, no evidence, and Egypt, potential risk, and Djibouti, potential risk, and Somalia, moderate risk, and Sudan classified as high risk. And again, Sudan is the only country that under the I strategy member states. So the risk, there is we assume that so those classified risks could be underestimated due to the lack of country capacity in identification of yellow fever cases. So next slide. So those so at that time, what those potential risk countries. So what we had the multiple discussion with HQ and also the risk assessment group, that what the potential risk countries or moderate risk countries can do is that so these are the general recommendation. However, it's very hard to implement in those fragile and conflict affected and vulnerable countries. So the major strategy, the recommendations those countries can take is that the strengthening surveillance and laboratory to monitor trends in human populations and also the detect the potential introduction early, and implement IHR strictly to prevent importation and intervene quickly in case of epidemic amplification following the introduction. However, so as you can see, those Somalia JEE score in 2017 and the Djibouti JEE score in 2018. And also, we also classified Yemen as a potential risk country, considering the high population movement and also the geographical cross-setting to those African countries. But all of them, their JEE score is 1 or 2. So considering the time and the feasibility, what of course, we continue working on strengthening those surveillance and laboratory and the IHR implementation. However, maybe while working on those strengthening the country capacities, maybe the risk of yellow fever is already there or could be already happening. It's just due to their limited the country, the confirmation and detection capacity, it may not have been found. Next slide. So it's not that we are just waiting and then continue to see if those countries start observing yellow fever cases. So we continuously working on strengthening surveillance system and enhanced integrated vector management activities and also the scaling up of laboratory diagnostic capacities. But however, there are so many challenges remain: inadequate entomological surveillance, and the lack of laboratory diagnostic supply, and the continuous flooding and natural disasters. And maybe this is the major elements: conflict and security threats, and the lack of resources. And following the recent yellow fever outbreaks in Ethiopia, Kenya, and also the neighboring countries in African continent, Djibouti and Somalia, they raised their alert level. And actually, the countries, they requested small prepositioning of yellow fever vaccines, but at the time we are unable to deploy due to the lack of established epidemiological data and the risks. And also during the 2020 to 2022, the COVID-19 has disrupted the yellow fever response activities during this period, as we have observed in many countries. Next slide. So why we requested this yellow fever risk mapping, this prediction model to the Imperial College London, is that we are observing increasing threat of yellow fever introduction to EMR and the urgent need to implement the eye strategy in potential or moderate risk countries, and the challenge is to implement a general preparedness strategy or recommendation in potential and moderate risk countries. And the COVID-19 has halted the yellow fever preparedness and response activities during this period, and need to establish evidence to accelerate yellow fever preparedness for potential and moderate risk countries. And the current yellow fever risk classification is more designed for the countries with already established yellow fever events or the clear the data. So that's why we discussed with headquarters, and then we requested to conduct the risk mapping of yellow fever outbreak in Djibouti, Somalia, and also Yemen. So those countries are currently classified as moderate, potential, or unspecified risk for yellow fever. The next slide. So I think that's the last one. We hand over the floor to Imperial College London. Thank you.
Thank you, but the presentation was not yet finished. So yeah. Thank you, Dr. Choi. How about you, Kate?
Thank you. So I think there's some slides, but let me know if I can share the slides from my side for the presentation.
Okay.
Katie, feel free to share the slides from your side.
Great. So are the slides visible your side?
Yes, they are. Thank you.
Great. Thank you. I'm Dr. Katie Gaythorpe, and thanks for the opportunity to present this analysis on behalf of the team at Imperial. And I think some of the introduction has been really well covered by Dr. Kadama, so I can speed on to the analysis. So over the course of this presentation, I'm mainly going to focus on the results of the analysis, but I am going to include an overview of some of the methods that we used, including some links to either a preprint detailing some of the background estimation that we employed, or a publicly available tool that we've used as part of the movement model. But I'll come back to that in a moment. And of course, happy to take any questions on the methods or the results. So as Dr. Kadama said, we were aiming to look at the risk of yellow fever occurrence in Djibouti, Somalia, and Yemen, which are currently either moderate potential or unspecified risk of yellow fever. And we defined risk in this analysis in two ways. So firstly, we considered the risk of importation or introduction of a yellow fever case to a new area. But we also considered that if a case was introduced, what's the probability that an outbreak propagates from that case? And we linked those two metrics of risk together. So just giving an overview of the methods and focusing on the diagram, hopefully you can perhaps see my cursor, but otherwise. Over on the right-hand side, we've got this diagram of our methods and how they come together. Each of the squares represent a region or a province or a district, a subnational unit of a country. The larger blue square highlights the current endemic region or an endemic country. So our methodology starts by using previously established estimates of the underlying environmental suitability of yellow fever. So to inform this, we used environmental covariates such as temperature, the types of vegetation, the non-human primate species richness, and we linked that with yellow fever occurrence by using information on seroprevalence of yellow fever, case notifications, death notifications. So we start with an underlying environmental suitability, and that gives us an estimate of transmission intensity given the environmental covariates like temperature. If we look along the top of our diagram, we use this underlying environmental suitability or this transmission intensity to give us start locations for theoretical outbreaks. So we seed start locations as potential start points for an outbreak occurring in the endemic areas. Once we have those start locations, we then look at what the risk is of an infected person traveling to a new area while still infectious. And that gives us our risk of introduction. So I'll come back to the method on that as well. If we look at the bottom kind of thread of the methods, we also start again with our underlying environmental suitability, which gives us our transmission intensity. And we use this to estimate an underlying outbreak risk. So given what we have estimated in terms of transmission intensity, what's the probability that an outbreak will occur in a new region? And then the final part is to bring these two threads of analysis together. So we've got the risk of introduction to new areas. So what's the chance that someone's going to move? Apologies. I'll go back. What's the chance that someone's going to move into a new area whilst infectious? And then we've got the underlying outbreak risk. So what's the probability that a new introduction of a case will start an outbreak? So just to summarize these results, and then I'll go into more detail in each component. Over on the left-hand side is what we estimate in terms of the underlying environmental suitability. So this is a map of what we estimate in terms of a force of infection, so in transmission intensity across the region. And as I mentioned, this is based on environmental factors such as temperature, the types of vegetation, and things like non-human primate species richness. We use that to seed start locations in countries neighbouring Djibouti and Somalia. And then those start locations, we simulate forward whether we expect movement of an infectious person from one of these theoretical outbreaks into Djibouti and Somalia. On the bottom row, again, we use the underlying environmental suitability, the transmission intensity, to simulate potential outbreaks in regions across Djibouti, Somalia, and Yemen, and look at what the probability of an outbreak occurring is given what we know about the environmental conditions. And then finally, we pull these two threads of analysis together. So looking in a bit more detail, firstly, on the risk of introduction. So in the top right-hand corner, we've got our starting locations. So we sampled 50 starting locations proportional to that underlying environmental suitability. And some places could be sampled more than once if they were particularly suitable for yellow fever. For each starting location, we simulated the model 10 times to capture some of the uncertainty. And then across all of these 500 simulations, we looked at what the mean risk was across regions in Djibouti and Somalia, and also how many times regions in Djibouti and Somalia were highlighted with any risk. So whilst we found that most of the risk is still centered in the countries where we seeded the starting locations, we still found that across all of our simulations, there were recurrent regions that were highlighted as having some risk of introduction. And I should mention here that this uses a model of human movement, which is assuming land-based movement. So this is based on a radiation model of human movement. Final point to note, this tool is available online, should you wish to have a look at some of the methods behind it. So taking also the underlying environmental suitability or our transmission intensity, we simulated for regions in Djibouti, Somalia, and Yemen 1,000 times to see whether an outbreak would occur in those regions. So for this analysis, we took one single infection introduced into each region and then looked over the course of a year for 1,000 simulations to see what the probability of an outbreak occurring was. And this really ends up being a function of that underlying environmental suitability, but there's areas that are particularly highlighted as having high outbreak potential, including areas of Western Yemen and kind of Western Somalia. And this is assuming that there's no existing yellow fever reservoir. However, we have conducted this analysis with that assumption as well. Generally, the risk increases across all regions in that scenario. So finally, we linked those two threads of analysis together. So this is capturing both the risk that a case may be introduced if we've got an outbreak in a neighbouring country, with the underlying risk that if a case is introduced, it will propagate an outbreak. So here we see border regions particularly highlighted, and particularly in the West, partly because of that chance of introduction, but also the environmental conditions are more suitable in these particular areas. So I just want to pause on some conclusions. So overall, we've highlighted some areas that may be slightly more vulnerable or more higher relative risk of introduction of yellow fever, but also the chance of propagation of an outbreak should a case be introduced. And we highlight Western Yemen has suitable environmental conditions for a yellow fever outbreak to propagate. There's a few limitations, and I've already mentioned one or two. Firstly, when we consider the risk of introduction of a yellow fever case, we're considering this based on a radiation model of human movement. We are currently working to include available movement data, but it's not available in the same format for all countries. The estimates of underlying transmission intensity based on the environmental conditions are generally estimated from endemic areas. So we use information on seroprevalence, case notifications, death notifications, and therefore we're extrapolating to newly at risk areas. Of course, data scarcity and surveillance variation may affect these results. Generally, they'd make them more uncertain. And we also don't consider cross-reactivity with other outbreaks that might have occurred, although we do capture immunity due to vaccination and prior infection with yellow fever within this analysis. So many thanks for your time, and happy to take any questions on this analysis or otherwise. Thank you.
Thank you so much. Thank you so much, Dr. Chiori and Dr. Katie, for taking us through the yellow fever risk in WHO EMR region. We understood that Somalia and Djibouti may be vulnerable to yellow fever introduction, and Yemen is has a suitable environmental situation for yellow fever outbreaks. So now we are going to open the floor for discussion regarding the two presentation. So the floor is open for those who want to ask a question regarding Erin's presentation and the Chiori and the Katie presentation. The floor is open. Please raise your hand. Okay.
Well, thank you all for your presentations. Maybe just a follow-up question for Erin. In terms of the subnational risk assessment, are the variables very different from the national risk assessment? Because in the measles program, we have something of a national level, but I think countries are using that in the subnational context. So wanted to kind of follow up on that, but also, does this help with the decision making around the age and selective versus non-selective approaches also?
Maybe we'll take all the question, on one round, then we'll give the opportunity to the speakers to respond. Yeah. Please, maybe introduce yourself.
Okay, thank you. My name is Mohammed Omar from UNICEF Isaro. The question is for Erin. For the national risk ranking, are you considering only the high-risk countries, or you are considering other countries which are maybe classified as moderate or low risk? Thank you.
Okay. Yeah, good.
Good morning. My name is Maurice Demanu. I'm the regional laboratory coordinator for yellow fever. My question is to Chiori. I would like to know the measures taken to continue yellow fever surveillance and diagnostic in the context of political instability in Sudan. For instance, the National Public Health Laboratory is now occupied by the military, and the domestic transport of samples is very, very challenging. Thank you.
Thank you, Maurice. Yeah, Joe.
Thanks. Thanks, Chair. Thanks, Chair. Also thanks to the presenters. I capture a question here on the chat on the Zoom. And I think this question serves to the three presenters. No, and the question is, what do you think would be the main challenge in terms of the public health response of the introduction of yellow fever cases in areas with low risk of transmission?
Okay, well noted. Any additional question? Yeah, Diana?
Thank you. More than a question, is a comment. So we are also doing some risk mapping for other Aedes aegypti-borne diseases like dengue, Zika, and chikungunya, which focus more on urban settings. So please feel free to use that when you are trying to assess the risk of urbanization and all the potential risk of transmission in urban areas for yellow fever. We also use temperature suitability, precipitation, the NDVI, the human and habitat index, the predicted suitability for Aedes aegypti, Aedes albopictus, proportion of urban land. So that is available, but I will probably show it tomorrow in the update of the Arboretus initiative. But for the yellow fever team to be aware that this is being done, so we don't need to reinvent the wheel. We can coordinate and work together.
Thank you so much. Thank you, Diana, for your comments. So if there is no additional question, okay.
Thank you. My name is Amsalu from UNICEF Ethiopia. My question is for the last presenters,
Dr. Kitty?
Dr. Choti and Katie.
Okay.
Yeah.
Okay.
In their conclusion, I think they have said that Western Djibouti, Western Somalia, and Western Yemen are vulnerable for yellow fever outbreaks. I was wondering why, if the Western Yemen is vulnerable, why not Eastern Djibouti and other parts as well? And how do they stratify the vulnerability on those areas? Thank you.
Thank you. Lawrence?
Thank you very much to all the presenters. It was excellent work and very interesting. The first question relates to the risk analysis presentation, but it's actually addressed to the Afro advisors, both emergency and immunization. So some of the through the work of the risk analysis working group, the sort of highest risk countries were identified, highest risk for yellow fever. And my question to you both is, how is this integrated in your work planning in terms of preparedness, but also in terms of efforts around routine immunization strengthening? And a follow-up question to that actually relates to what was presented at the last annual partners meeting around the revamping of the emergency programs in Afro and the development of the flagship programs. At that time, there was a presentation of the STAR assessment, in which countries identify which are the top priorities infectious hazards. And then my question to you is, how does this sort of self-assessment of top infectious hazard priorities relates to the results of the risk assessment? And then I have another question. It's linked to the presentation of Emo, and I first want to really appreciate Curie's engagement, who's been at the forefront of our implementation in moderate to potential risk countries since the beginning. So really appreciative of that. Thanks, Curie, and thanks also, Cathy, for supporting the work in those settings that are not at high risk. I think it's really curious. Your leadership is really an example of what can be done in terms of understanding yellow fever potential, but also working on the preparedness activities in case of introduction of yellow fever, in case of potential amplification. So thanks for that. And my question is really, what's next at your level? And it's somewhat related to also what Maurice questions. I know from having worked in the MENAFRIGRAC project, some of the Afro's capacity were used to support EMERALD, especially Sudan at the time, but also some other countries. So my question is, curious, as you work towards enhancing yellow fever outbreak preparedness in those regions. Could there be collaboration with AFRO and the capacity? I mean, we do have a regional lab coordinators. They are expertise in yellow fever in the region. And the last point I wanted to make is in response to what you mentioned, and we had discussed at the time around Djibouti and Somalia wanting to pre-position yellow fever vaccines. But I do want to highlight, and we'll talk about this later on, but the ICG mechanisms is available for all in all countries around the world to provide vaccines in emergency settings, and they can be made available through the partnership in a very rapid fashion. So to overcome the situation where there's no positioning of yellow fever vaccine, which is actually not the case. We do not pre-position yellow fever vaccines for response. Thank you again. Over.
Thank you. Yeah, over to you, Erin. Then we'll give the opportunity to those who are online.
I'm going to ask to see if my slides can be brought back up again to answer the very first question in terms of the differences between the national and subnational tools. If you can go to slide 17.
Okay, just give us a second, Erin, because we
Okay.
loaded up the next presentation. So
Yeah.
1 second.
So essentially the points that are awarded and the breakdown of that is exactly identical between the national and subnational in terms of there's more points given for endemic risk, than compared to epidemic risk, and the mitigation scores are the same. So the points that are actually allocated are the same. But as already mentioned, with the subnational tool, we have more flexibility. If again, move ahead to slide 17. Maybe. I didn't think this was going to
Sorry,
work.
you just have to give us a second.
Yeah.
Also, the connection is super slow today, unfortunately.
But there is more flexibility to talk with the work group that's established to determine what is the best measure and the availability of data. So go to slide 18, for instance. It's after there you go, one more slide. So for instance, we use an omega score between the national and the subnational, which is looking at the time, how many cases have occurred in the series of the cases that have occurred. But when we move to the subnational, what we don't have at the national, again, to compare Ethiopia to Uganda, we need to have the same amount of data, because if we start awarding points to one country because they have data, that's artificially elevating risk because another country doesn't have data. So within a country, we can start to bring back variables that are more direct measures of risk. So as noted, we use land cover on the national, which is looking at, which would be a surrogate for non-human primate as well as non-Aedes aegypti, or specifically Aedes africanus or Bromelii species that could be present, and we start bringing those variables back in. So we can bring in non-human primate data, and we can bring back in Aedes aegypti, one more time, Aedes africanus data back into it, though again, many of the places don't have it, so we might use land cover. So we have more flexibility. The same is true when we go to the next slide. We bring in migration, because countries tend to have different migration data, but having a uniform source of migration data wasn't always available. The data for the specific, and also for infrastructure scores, we've used a different infrastructure score for each of the countries based on their availability of how they think their public health infrastructure could be best rated. And that infrastructure score is really a representation. Can they detect a case of yellow fever, and how long will it take to respond? Because that's going to drive that outbreak risk. So it's in general very similar, but can be more tailored to the country. So it provides more flexibility, and hopefully in many cases a more direct measure of the risk between the areas of the country. So that was the first question. The second question, I think, was the ability to look at or use this tool specifically for moderate risk or low risk. And one of the things that actually predated or kind of led to the presentation by Kati and Kiori was the fact that they had asked us to use the tool. But the tool, as you can see, is very much driven, if you go to the next slide, for instance, is driven on the occurrence of yellow fever. And moderate risk countries by default don't have a history of yellow fever. They might have had a sero survey once that suggested it, but they don't have a lot of information about what, you know, that is. So half the points are not even available to award. So it is not a great tool for looking at that, though we did, in the case of EMRO, utilize Aedes aegypti presence, population density, urbanization, migration, infrastructure, because all of those things would go to the epidemic risk. But we really, and we use land cover, but we can't use all of the variables. So we did adapt it, but it is not necessarily, the tools were created to look at sort of cumulative risk of yellow fever based on what we know has occurred in a country, not a predictive tool. And that is when we reached out to Imperial College, because Kathy is part of our work group, and said, this is really more of a predictive tool, which requires more complicated models to look at the movement and the likelihood of where a case occurs and where it might show up. So that was, you know, the sort of transition, and that can be done. There's many different ways to assess risk and many different tools. But again, the main tool is just to look at the cumulative risk to be able to make some determinations for vaccination priorities. And the last one I'll answer, and then I'll turn it over to my colleagues, was the main challenges. Yeah. For lower risk countries, I think the main challenge is detection, in my personal opinion. Under the I strategy, we've improved the laboratory infrastructure. We now have a very competent laboratory in East Africa that can provide confirmation. So if a case was to occur in Somalia, well, it will take time to get the sample to Uganda. It can be tested. But someone has to think, is this yellow fever? And that is always the obstacle. That was an obstacle for Zika virus disease when it first, appeared in Brazil. That's always an obstacle. Someone has to be clever and think that it could be yellow fever.
Thank you so much, Erin. I think your last point is very important. So I'm now going and give the floor to Chiori, then to Katie. But please be very short in your response to the different questions. Then we'll go back to the room for the question addressed to Afro. Yeah, Chiori, the floor is yours.
Yeah, thank you. Thank you very much. Did you hear me? But somehow
Yeah.
I have trouble with my sound system, and I can
We
barely
can hear you. We can hear you.
Okay, that's good. That's good.
Go ahead.
So yeah, thank you so much, Erin, for very nicely addressing all the limitations and also what the risk assessment can do. And you actually very nicely answered my questions as well. So in response to somebody addressed the question about Sudan, as rightly mentioned that the currently CPHL is occupied by the armed force, very unfortunately. So the confirmation and also the assessment and also, of course, the collection of samples and also the vaccination rollout, it has been all disrupted. It has been all terminated. So instead, we are rolling out the mobile clinics, except the whole North Kordofan, that the mobile clinic that is equipped with the available vaccines and also the antenatal care and the essential medicines and also the cholera response. So that has the multidisciplinary functions, but also the vaccination, in order to implement the vaccination program, we have to also secure the cold chain and where everything is disrupted. So it has been a big major challenge, and it's very unfortunate that despite the fact that in the past years Sudan was the only country that who joined the I strategy and who successfully rolled out the I strategy yellow fever vaccination program. But I think today or tomorrow that the Sudan country office is going to give you the update, so you will hear more from them. And also, thank you, Lawrence, that yes, we are actively working with the yellow fever, the laboratory working group, the cross-regional the working group. And Amaru Barakat is taking the lead in this area. And we have confirmed that we have discussed with Afro team that the cross-regional, the transfer of sample of potential yellow fever, it's very difficult due to lots of the background context. So instead, those the risk potential or moderate risk countries, they're more moving to the more complex PCR in country. So it's actually one of the gains we made through COVID. So the laboratory diagnostic capacity, it's gradual, but it's progressing. So my question is that really thanks to the Imperial College London. So what is the interpretation of this risk mapping result? So now they have classified the Djibouti and the Somalia and the Yemen as a potential has a potential of yellow fever outbreaks. So what is the interpretation by the I strategy group? What's the next move? How can we move forward? And also, I understand that those the risk countries for the yellow fever outbreaks, they are all eligible to request for the yellow fever vaccines, but it's not really crystal clear how we can join the team of yellow fever strategy. So if we can clearly address the next way forward, the next steps by the I strategy group, that will be highly appreciated by EMLO. Thank you. Over to you.
Thank you so much, Dr. Choi, for your answers and your question to I strategy. Now I'm now going to give the floor to Katie. Katie, please be very short. Over to you.
Okay, thank you. I think the main question for me was why Western Yemen was highlighted and how we were stratifying. So we use some of the environmental covariates that have been mentioned for other risk mapping exercises. And that also includes population density. And I think that's one of the key drivers of why Western Yemen is highlighted in that particular analysis. The population density also is a input to our radiation model of human movement, thinking that people are more likely to travel to larger population centers. So that also affects our risk of introduction or risk of importation analysis as well. I will leave it there unless it's helpful to answer any other questions. Thank you.
Thank you so much, Katie. You want to respond to Chiri's question, or maybe we can respond, okay, later? Okay, so I think there was a question for Afro. I will maybe try to give a brief answer, and I will give the floor to my colleague to complement. Yeah, regarding the risk assessment of yellow fever in Afro region. So I should point out that, the I strategy risk assessment methodology is completely different from, for example, what we are using in some countries, STAR tools. And STAR, because STAR is like strategic tools for assessing risk. And in this methodology, we are, accompanying countries themselves to identify. It's not, for example, this assessment is not done by WHO or other partners, but done by the country themselves. And in the workshop, they used to invite different representatives from different sectors, of course, taking into consideration One Health approach. So, based on their own assessment and their understanding of their country context, they classify the risk of yellow fever. Some of them have listed yellow fever in their 6 top major hazard, but others did not consider yellow fever as the 6 among the 6 top hazard. But this is not something different, because the two methodologies are completely different. And what we are doing in STAR, because of the resource constraint, and we wanted to have a multi-hazard plan, which will include, the major hazard and a contingency plan for each specific hazard. So for I strategy, we are following the situation case by case, and we are supporting our member state in the investigation based on, of course, our strategy risk assessment. You see, so these two are different. And regarding the flagship project that are being implemented in Afro region, I should mention that we have three in emergency preparedness and response cluster. Of course, we are implementing three flagship projects. One is focusing on preparedness. It's called PROS. One is focusing on surveillance system. It's called TAS, and the third is focusing on emergency response. It's called SURGE. So these three flagship projects aiming at strengthening our member state capacity to detect earlier, to respond in timely manner. And even in Afro region, in our EPR cluster, we have already adopted a 717 approach. So it's 7 days for detecting, 1 day for reporting or notifying, and 7 days to respond to any outbreak. We are not yet there, but this is one of our goals in the region. And you know, some resources were mobilized to support these three flagship projects, and they were also used to strengthen the capacity of member states in surveillance, including yellow fever, because our approach is not one disease, but it's all diseases, all epidemic-prone diseases, including yellow fever. Of course, so that's why I can say that some of these resources are being used to support eye strategy implementation in the countries. I will stop there. Maybe I will give the floor to Ado and William if they want to quickly say something. Yeah, Ado, quickly, and William, if you want to supplement, please.
Yeah. Thank you, Maury. So the question was how we are using the eye risk analysis for the ranking of countries to make sure that we support routine immunization strengthening, especially in those countries that are considered as high risk. One thing is the fact that if you look at the list of those countries, most of them are also those that we are categorizing as priority countries, for example, for big catch-up, where we have a large number of zero-dose children, a large number of unimmunized children. So it's actually going together with the ranking in eye strategy. So these countries have been prioritized for like targeted support, be it in terms of human resource capacity, or even in terms of additional resources to be provided to those countries for strengthening routine immunization. One of the areas that we are working on, as I said it yesterday, is to make sure that when they're developing their national immunization strategy, yellow fever agenda is put as one of the top priorities in their plans, in their resources mobilization plans. The other thing we are doing is the big catch-up initiative. So these countries, especially with the waiver that we got from Gavi for these priority countries to implement the big catch-up initiative. So yellow fever is out of the vaccines that these countries could request for and make sure that they catch up children, or especially up to 5 years, that missed vaccination, especially in the last 2 or 3 years. We are also working, and this is in terms of the advocacy, making sure that the Addis Ababa Declaration on Immunization Commitment that member states committed themselves like 5 or 6 years ago. There are a lot of efforts at the management level to make sure that these commitments are brought up at the agenda of African Union summit or any other convening, so that heads of state and heads of government are reminded of their commitments to mobilize resources and to make sure that they commit themselves to this engagement. Thank you.
Thank you so much, Dr. Ado. I'm now going to give the floor to Lawrence for a quick answer. Yeah, over to you.
Thank you, Chair. And it's really a rapid response and a proposition to Curie. Just to say, we will need to understand, particularly in discussion with the risk analysis working group, what complementary approaches would be needed in Western Yemen. But I think the clear message in situation where we do not have yellow fever as endemic is really around being able to detect a potential introduction, respond to an amplification, and limit importation. So it's really around surveillance, lab, and IHR. But as Erin rightly pointed out, is also changing the mindset and make sure that there is awareness on of the potential risk. So that the response and the proposition, if you like, we can continue to discuss over the next couple of days, because we do have the opportunity of a gathering here in Addis, and that we propose some concrete steps and actions that we can detail in the last presentation of the meeting at the close on day 3 on the future of I, and that could be around I implementation and activities that need to be conducted in those moderate to lower risk countries. Thanks.
Thank you so much, Lawrence, for your quick and a very short answer. So now moving to the next item, the resurgence of yellow fever outbreak and opportunities to address. I would like to call on Lawrence, who is not longer needed to be presented in the I strategy meeting. So Lawrence, you have the floor to present on yellow fever outbreak resurgence and catch-up intervention. Over to you.
Thank you. And I will actually be presenting on also on behalf of Charles Chewidonge, so the regional advisor for immunization in Afro, because it's been we've been really thinking this through together. Is steering the efforts around catch-up interventions in Afro, and has been instrumental to ensure that we will have feedback from the regional immunization technical advisory group in Afro, RITAG. Next slide, please. I believe we're a bit short on time, so I'll try to go quickly. Just an overview. You know this really well. I just want to flag that the catch-up vaccination or catch-up interventions have been in the I strategy since the beginning. They was approved by SAGE in 2016, but we didn't have a approval from the Gavi board at the time, because the focus was really very much on resuming the preventive mass vaccination campaigns. But also importantly, there was no implementation specifics developed at the time. So in the efforts around defining catch-up interventions to address the resurgence of the yellow fever outbreaks in countries with history of preventive campaigns, we solicited advice from SAGE, from RITAG, and I would speak about it. We're also soliciting guidance from the I Vaccine Delivery Working Group, with a vision to develop a PPC paper for the May meeting and seek Gavi support for vaccines and operational costs. Next slide, please. And we're fortunate to have discussed that yesterday already, so I won't go through it. Moving on to the next. We'll now focus on the specifics of these outbreaks, the characteristics of these outbreaks that have resurged in the country with history of campaigns. And as you see reflected here, the yellow fever outbreaks have resurged on average from 10 to 13 years after preventive campaigns had been completed, due to the gradual accumulation of susceptibles. And as you see in some countries, there were several recurring outbreak years. Next slide, please. And here we see that most of the affected countries have challenged health system, and some of them are with us here in Addis. Challenge health systems, insecurity, conflicts that are also relates to some of the very important points that Curie made about the FCV settings in an earlier presentation. But these settings have obvious implications in terms of routine immunization performance and the efficiency of the routine immunization strengthening approaches. So in 10 of the 12 countries which completed the preventive campaigns under the Yellow Fever Initiative, again, which started from 2005 to 2014, there are coverages that the average yellow fever routine coverages are below the 80% threshold that's necessary to limit amplification. And most of these countries have experienced recent yellow fever virus circulation or amplification. And I just want to point out that some of the what we call tier 3 priority countries here in terms of routine have also experienced amplifications, albeit they have national averages that are above 80%, but obviously these are national averages and they do mask subnational disparities. Importantly, the low yellow fever coverages here are mostly due to broader health or immunization system issues, with the yellow fever specific issues reflected mostly through the yellow fever MCV1 gap, which exists in 6 of the 27 yellow fever high-risk countries, i.e. around a bit more than 20% of them. I also want to highlight that efforts to characterize these gaps are ongoing through the vaccine delivery working group and UNICEF work in particular. And I think it's really important to flag that we are working to characterize and address this gap because the proposed catch-up interventions are envisioned as a complement to the ongoing efforts to increase routine immunization and country ownership of the yellow fever routine immunization, and they're not envisioned as a substitute. Next slide, please. And this is a critical one because the yellow fever outbreaks have affected children and adults with 11% of the cases under 5 years, 22% of the cases between 5 and 50 years, and 45% between 20 and 45 years. And as you see, there's a drop in both the incidence and the fatalities after 45 years, as around 10% of the cases are above that age. And an important figure here is that 80% of the cases are between 5 and 45 years old, which is also the age group where most of the deaths were recorded, with an overall case fatality ratio of 11%. So in view of the time elapsed since the campaign completion has completed, the cases up to 10 to 15 years old are likely children missed by routine immunization, of which about a third are eligible for the big catch-up, and all the periodic intensification of routine immunization effort, the PIRIs, and the cases above 15 years old are likely to have been missed by the preventive mass vaccination campaigns in the first place. Next slide, please. And another key feature of these outbreaks is that mobile populations and vulnerable communities were predominantly affected. This includes seasonal workers, such as minors, mobile populations, refugees, the returnees, the IDPs, nomadic populations, etc. But they were identified during the outbreak investigations and also protected during the response. Next slide, please. And actually, the next slide is something we talked a little bit about earlier yesterday, is that in addition to the outbreak response, there have been targeted, really specific interventions implemented. And this include the ongoing development of the tool for immunity gaps analysis, for root cause analysis, and to understand the reasons for outbreak response delay. We'll hear all about this today. They were piloted in Guinea, in Cameroon. There was a desk exercise in Gabon, and that was in response to the country's demand. I think it's a critical point. And the same effort will be completed in Central African Republic next month. So these countries, and I'm thinking of the example of Guinea in particular, they've expressed the need for catch-up interventions beyond the big catch-up, so above the 5-year-old, as a complement, and they've also sought guidance and support for this. And here again, tying to the discussions on the risk analysis, it's important to flag that this annual risk ranking could potentially be used as to guide the prioritizations around the catch-up interventions. And I also want to flag that as broader support done to the countries faced with resurgence of yellow fever outbreaks, we're also working towards strengthening surveillance and developing guidelines and tools accordingly. And again, linked to the conversations we've had with EMRO and that were flagged in the earlier discussions as well, it's really critical if we want to be able to implement those interventions that we engage with the humanitarian community to ensure deliveries of those immunization services, but also other services, health and non-health alike. And in the example of Sudan, I think was a strong one. It's the interventions of Maurice was around how to support the lab in Sudan. But I remember in earlier discussions flagging that we do have colleagues from the humanitarian communities who are deploying in those settings and for extending time, and they could help with those interventions. They have specific networks and capacity. Next slide, please. So the next slide will be on the initial vaccination estimate that we have through the piloting of the yellow fever immunity gaps in select countries, as mentioned, as well as using WINEC estimates and humanitarian and migration data. We have, an estimated of around 59 million people susceptible to yellow fever in countries which completed preventive mass vaccination campaigns under the Yellow Fever Initiative and the Year 1 of I, including around 12 million of vulnerable populations such as migrants and refugees. So the current analysis provides estimates of susceptibles for 3 age groups that are represented here, under 5 to 15, and above 15s. And we're working on the opportunity to provide estimates by more granular age groups, and that could be done, using the examples of other diseases such as measles and the measles immunity profiles. But importantly, through the age distribution of the cases, we do have an indirect reflections of the age profiles of the susceptibles, obviously. So next slide, please. Now we'll be discussing a little bit of the policy and understanding what exists. So there is an overall catch-up policy, but there is no dedicated strategy for yellow fever catch-up interventions at this stage. And the emphasis will be needed on the opportunity to seek synergies and integration with existing efforts. This is not a unilateral effort. This should be done in concert with others, and measles in particular. And importantly, the I strategy currently lacks mechanisms for supply allocation. We've discussed how we allocate vaccines based on risk. We don't have that for catch-up interventions. We don't have financial support mechanisms as well. And I want to flag the big catch-up here. It's been discussed. It's a clear opportunity that can be leveraged and a complement. But if you've seen the age distribution of the cases, that will have a limited impact on the current situations. Linked to the age, but also linked to the fact that some of the affected countries are middle-income countries that cannot benefit from Gavi supports. And again, I also want to reiterate the country's demand, which I think is an important factor. Next slide. It's really actually to reiterate that the vaccine, yellow fever vaccine, is safe and effective, that it's important to always consider the risk-benefit ratios, and interventions are planned and designed. But I wanted to insist that the rate of severe adverse effects following immunization increases with in older adults, and especially around the 60. So really not at the sort of 45 year sort of cutoff that we are considering at the moment. Next slide, please. So it's really an overview of what we know thus far, who needs protection. Well, that would be children missed by routines in the implementation of the campaigns. It would be also the zero-dose communities, the populations missed in the initial preventive campaigns. The interventions will be needed in the countries who implemented the campaigns 13 to 15 years ago, and that are also countries with challenged health systems. We've sought advice from SAGE on this, and that would be reflected on the next slide. We do not have formal records yet, but I provide an overview. It was mostly a go-ahead for catch-up interventions with recommendation to go through 45 years old, and opportunities for countries to go up to 60 years should the local epidemiology detect so. We also had a recommendation from RIOTAG. They're being finalized, but I'm happy to present them. We have some records. So they do recommend also implementing those catch-up campaigns based on epidemiology and risk for the countries that I've mentioned. They do encourage as well flexible and pragmatic implementation approaches to rapidly fill these immunity gaps in at-risk populations. And again, here, a strong emphasis on integrating and integration as possible, noting that there is a WHO integration guidance in place. Next slide, please. And that would be the last. It's on really there's some more specifics provided by RIOTAG to guide decision-making and prioritization using the annual country risk ranking to inform prioritizations. That interventions should be triggered when coverages are below 80% at district and sub-district levels and in specific communities. So really, we're looking at tailored, targeted approaches. They also insist that in addition to this campaign, there be continuations to the other vaccination and yellow fever risk mitigation pillars, be it through the rapid containment of outbreaks, being through improved surveillance, etc. So I think that the bulk or overview of the RIOTAG feedback with another final emphasis on the integrations and with other vaccines, but also using the health campaigns effectiveness coalition framework that Santosh will talk to you about, or to us about soon. And last point I think is important because these interventions will also target adults is the importance to develop again targeted communication strategy to address vaccine hesitancy as we've seen during COVID and vaccination in adults. Thank you very much for the opportunity to debrief.
Thank you very much, Lawrence, once again for this update on catch-up. Catch-up have always been, key in achieving high strategic objective. So I would like now to call on Nolwenn Conan for her presentation on root cause analysis of yellow fever resurgence method and lessons learned. This is a remote presentation. Nolwenn, are you online?
Yes, good morning. I am online. Can you hear me?
Okay. Yeah, we can hear you. Over to you.
So I'm going to share my screen and you will tell me if you can see it.
Yeah, we can see it.
Okay. So good morning, everyone. So I'm Nolwenn Conan, and I'm a consultant working in the TDR department at WHO. That is a special program of WHO for the research and training in tropical diseases. And today I'm going to present you the method that is used for conducting a root cause analysis of a resurgence of yellow fever cases. And also, I'm going to present the lesson that we have learned when we piloted this analysis in two countries that are Guinea and Cameroon. So we have seen in the previous presentation that there has been in the past years a resurgence of yellow fever cases in African countries that previously implemented preventive mass vaccination campaigns. So it was essential for the partners to gain a better understanding of the reasons for this resurgence. And in order to do so, the High Secretary of WHO has requested the support of the TDR department to develop a toolkit that countries could use to identify the root causes of yellow fever cases resurgence. So first, I'm going to show you, I'm going to speak about the toolkit. So the toolkit for the root cause analysis consists on different documents. So first, we have an operational guidance. This guidance describes the method used for conducting the analysis with the different steps to follow to identify the root causes, and I will explain that later. It also describes how to collect the information, so either through a document review or interview or an observation, and at which stage to collect that information. We have also in this toolkit standardized collection tools that allow the collection of information that are required to identify the root causes of the yellow fever outbreak. So those tools are semi-structured questionnaires and structured questionnaires that are used at different levels, at central level and at district level and health center level, where the yellow fever case was notified. We have also in this toolkit a set of slides. First, that we use during the preparatory phase to present the method and the timelines of the analysis. And also a set of slides that we use during the dissemination phase to present the result. And finally, in the toolkit, we have a generic template for reporting the findings. So to conduct the analysis, we use the method that is inspired from the method described in the 2021 WHO measles outbreak guidelines that you may know, that use a stepwise approach. We use a mixed method to collect the data. First, on the yellow fever cases that occur since the introduction of the yellow fever vaccine in the routine immunization program and the mass vaccination campaigns implemented in the country. And then we look at the chain of the causality. So I will explain this part later. Also to mention that the root cause analysis is conducted during a recent outbreak in the country. So to conduct the root cause analysis, we have 3 phases. So in the first phase, we call also preparatory phase, we conduct a document review that allows to collect the information. So on the present and past outbreaks and mass vaccination campaigns, and also on the first level causes that may have led to the outbreak. So the documents are identified and collected through committee meetings over 3 weeks with the MOH, the High Secretariat, WHO Afro, and WHO Country Office. And this phase is also important to prepare the agenda of the field visit and to identify the key informants that will be interviewed at that time. We have a second phase, that is a field visit, where that is over 10 days, where we review vaccination and surveillance records, and we interview not only health workers involved in the vaccination and surveillance program, but also entomologists and people working with wildlife, forest, environment, etc. And then we have a third phase that occurs over 6 weeks. We have first in the dissemination phase a restitution of preliminary findings during an on-site workshop that is conducted at the end of the field visit with the MOH, the WHO country members, the High Secretariat, and all the persons who are contacted during the analysis, either through interview or by sharing information on yellow fever. Then we have a first version of the results that are reported, put in a report, and so we share with the MOH and WHO countries for a review. And then we have an online workshop that is organized with the previously mentioned stakeholder to present the final results. And during these sessions, the participants discuss point by point the root causes found during the analysis that allows to identify corrective action to be taken with the priorities. And then after this online meeting, the report is amended according to the outputs of the online workshop. And the report is shared with the partners for further revision. So now I'm going to show you to speak about the stepwise approach of the root cause analysis. So first, we describe the yellow fever cases that occur since the introduction of the yellow fever vaccine in the routine immunization program, with a specific focus on the outbreak under analysis to identify the cohort the most affected. We also collect information on the mass campaigns, so either reactive or preventive, that have been implemented in the area to see, and we look at the vaccination coverage result if one was implemented. So all of this information helps to provide an initial understanding of how and why the outbreak occurred. And then we determine the chain of causality that led to the yellow fever outbreak. So the first level causes, or also called the most immediate causes of the yellow fever outbreaks, include immunity gaps and gaps in the surveillance and response, and increased exposure in an under-vaccinated population. So any or all of those first level causes have second level causes that are then considered individually. So for instance, immunity gap, why we have an immunity gap? Is it because of a failure to vaccinate if the cases were not vaccinated against yellow fever? Or is it because of a vaccine failure if one or several cases during the outbreak were vaccinated against yellow fever? If the outbreak have several confirmed cases, we look also if the amplification is due to a surveillance gap and what could be the reason. They may be due to an inadequate or untimely gap in the case detection, or an inadequate or untimely gap in the case notification, and so on. And finally, to assess if increased exposure have led to the yellow fever outbreak, we explore the entomological, non-human primates, and anthropogenic factors. So once those second level factors are identified, further investigations are conducted into lower level causes through a series of why questions. And the answer of each why questions leads to another why question until we arrive to the root causes. The conduct of the root cause analysis gave also the opportunity to evaluate the reasons for delay in the vaccination response in the country where the outbreak occurred. So here I present the method that is used to look at those reasons for delay. So first, we take the time interval between the onset of the symptoms of the index case and the start of the vaccination response. Then we identify and list the steps present in this interval, and we calculate the time intervals of these steps, thanks to a documents review. So for instance, what is the time interval between the onset of the symptoms of the index case and the first contact with the health facility? What is the time interval between the first contact with the health facility and blood sampling for confirmation? And so on. And so once we have all time intervals calculated, we identify the steps where the delays occurred. Then we interview the key informants in charge of those steps to understand the reasons why the delay occurs. So as mentioned before, we piloted the root cause analysis and reasons for delays in the vaccination response in 2 countries that are Guinea and Cameroon. And also we designed a questionnaire that to have feedback from countries on the feasibility and the relevance of the root cause analysis. And so the questionnaire was sent to Guinea, we received feedback, and we will be sent also soon to Cameroon. So the first lesson learned of conducting the analysis is a focus on the yellow fever with the involvement of all the different actors who don't work only in the vaccination and surveillance program, but also in the field of vectorial control, wildlife, environment, and also at different levels, like central level, district level, health center level. And the different workshops that are implemented for presenting the results are also the One Health approach for the yellow fever disease, and create a dynamic interactions between the different departments involved in the analysis. And regarding the evaluation of the reasons for delaying the vaccination response, it's also to focus on the different administrative mechanisms that are involved to request a vaccine and that could delay the response. We have also learned in this pilot phase that the data availability is important to conduct the analysis, and sometimes those data are not available. Either because they don't exist. For instance, the post-vaccination campaigns are not systematically conducted after the implementation of the mass vaccination campaign of yellow fever. So we have only the result of administrative vaccination coverage. And also the vaccination coverage results are not systematically presented stratified by sex and age groups. Those data also can be sometimes are not available because information are lost due to a turnover in the strategic position or an archiving issue. And there is also a risk of recall bias, specifically when the yellow fever cases of the outbreaks should have been or were vaccinated several years ago. We can have also sometimes conflicting information in the documents, which makes the analysis difficult. Also, we have seen the root cause analysis takes place over several weeks, and there can be competing agenda in the countries that delay the conduct of the analysis. And finally, we have seen that there were very few cases or one case of yellow fever in investigated outbreak that may have to be taken into consideration in the future when conducting the root cause analysis. So this slide shows the different steps that we used and we are going to use to have the final product that is expected by the end of June this year. So we started the development of the toolkit in April last year. Then we have different phases of revision along the development of the toolkit, and we are currently in one of those phases where we revise the toolkit with different persons and groups involved in the process, like the high risk analysis working group, the high vaccinatory working group, and the immunization, vaccine and biological department of the WHO. And actually, we will meet tomorrow with the high risk analysis working group to discuss about the toolkit. And we will continue in this revision phase after we will also work with the other group in the future to revise the toolkit. The third revision phase will take place after the conduct of the analysis in the Central African Republic, that is in April. So what are the next steps? So as I mentioned, we will go to Central African Republic in April for the field phase. So actually, we started the preliminary phase last week. We started the call with the MOH and WHO country office. Oh, sorry, I didn't click. And then we will have our final revision, the final revision of the toolkit in May, June. And so what we need to define is what is the role of this toolkit in the future. For instance, should it be used systematically when a resurgence is occurring, and who should use it? So as I mentioned through this presentation, the elaboration of the toolkit is a collaborative work with a lot of people involved. So I wanted to thank everyone who contributed to this work. Thank you very much for listening.
Thank you. Thank you very much, Norwin, for informing us about the root cause analysis method and lessons learned. So this time, I'm calling on a country that has experienced this root cause analysis. I therefore call Nestor Leno Numa to present on Guinea's experience of root cause analysis, outbreak response delays, and evaluation of susceptible. This presentation will be made in French. You have the floor, Dr. Nestor. Sorry.
Ok, merci beaucoup, Dr. Maury, pour la parole et bonjour à tout le monde. Et comme le disait, moi, je suis le Dr. Nestor, je suis le responsable suivi évaluation recherche du programme élargi de vaccination de la Guinée. Avant d'entamer cette présentation, permettez-moi de dire merci à l'équipe du secrétariat de la stratégie AI, également aux consultants qu'ils ont utilisés pour cette évaluation. Je vais parler ici de Norwen qui vient de faire la présentation, mais également de Pamela qui nous ont accompagnés dans ce processus. Donc, j'avoue que moi, je suis un peu nouveau au PEV, à peine un an, mais cet exercice m'a permis de comprendre davantage vraiment les mécanismes non seulement de surveillance, mais aussi de riposte contre cette maladie. Donc, ceci m'amène à formuler la recommandation de voir dans quelle mesure, vous savez que dans les programmes élargis de vaccination, il y a beaucoup de choses à faire, il y a beaucoup de maladies à surveiller, à riposter. Donc, de voir dans quelle mesure, de temps en temps, on peut mettre le focus sur des maladies prioritaires en renforçant les capacités des programmes dans le domaine vraiment de la surveillance et de la riposte. Moi, Dr. Norwen a présenté la méthodologie. Je pense que elle a été très détaillante et moi, je vais vous présenter les résultats auxquels nous avons abouti. Et principalement, cet exercice consistait à comprendre vraiment les causes profondes de la survenue des cas d'épidémie des fièvres jaunes en Guinée. Donc, sur ce, nous avons abordé les résultats sur 3 aspects. Le premier aspect est l'analyse du délai, comme elle l'a dit. Le second aspect, l'analyse des causes profondes. Et le troisième aspect, l'analyse du gap immunitaire. Slide. OK. Et par rapport à l'analyse du délai de la réponse, il faut noter que nous avons mis l'accent sur le cas de fièvre jaune qui a été détecté dans la préfecture de Koundara, c'est une préfecture de la Guinée. Et depuis l'apparition des premières symptomatologies, c'est le cas index le 1er octobre 2020, c'est 75 jours plus tard que le résultat positif du laboratoire de référence de Dakar a été rendu à la Guinée. Donc, on note vraiment des gaps en matière de réponse rapide, notamment, c'est le délai entre l'apparition des symptômes et également le contact du cas index avec SLAD. OK. L'apparition des symptômes et le contact du cas index avec la formation sanitaire, c'est 6 jours plus tard. Mais ce qu'il faut retenir ici comme principal constat, c'est qu'il y a eu un délai énorme, 31 jours, entre le contact du cas index avec la formation sanitaire. C'est 31 jours plus tard que le prélèvement a été fait pour envoyer l'échantillon pour le diagnostic. Et nous avons également noté un retard énorme entre le résultat rendu de laboratoire de référence au niveau national et la réception de l'échantillon au niveau du laboratoire de référence de Dakar. Et c'est plus tard, le 15 décembre 2020, que le résultat positif a été rendu à la Guinée à travers le laboratoire de référence de Dakar. Slide. Suivant. OK. Nous avons aussi noté un retard entre la confirmation du cas, mais aussi l'envoi de la requête au niveau du secrétariat de ICG. Ceci a pris environ 15 jours. Donc, nous avons jugé que ce délai n'est pas acceptable. Mais ceci peut être expliqué par vraiment la complexité administrative pour l'élaboration des requêtes qui se passe à des différents niveaux de la pyramide sanitaire. Premièrement, le niveau formation sanitaire, le niveau du sanitaire élabore d'abord la requête qui doit être validée non seulement par le niveau régional, mais également par le niveau central. Lorsque la requête est validée par le niveau central, je vais parler ici du programme élargi de vaccination, il faudrait encore l'approbation du ministère de la Santé avant que la requête ne soit transmise aux partenaires qui doivent financer donc cette réponse. Suivant. Lorsque la décision a été prise par le secrétariat de ICG pour allouer des vaccins, nous avons constaté qu'il y a eu un retard entre cette décision et le déclenchement de la campagne de vaccination riposté contre cette épidémie. Ce délai était de 44 jours, mais nous avons noté surtout un retard énorme entre le transfert des fonds au niveau de la Banque centrale par les partenaires qui devaient financer, mais aussi le début de la campagne, ceci a pris 22 jours. Mais de façon spécifique, nous avons noté une lourdeur administrative au niveau du pays. Et c'est 7 jours après la validation de la requête par l'OMS, le bureau pays de l'OMS, que les fonds ont été virés au niveau de la Banque centrale de la République de Guinée. Et c'est après ça que les fonds doivent être virés dans le compte du programme élargi de vaccination, puis au niveau district qui doit organiser la réponse au niveau local. Suivant. Cette analyse nous a permis de catégoriser donc, les domaines de faiblesse en 3 groupes. Le premier groupe, c'est le temps écoulé entre l'apparition des symptômes et la confirmation du cas. Le premier constat, c'est qu'il y a un problème de diagnostic différentiel parce que le cas y est un contact, on peut supposer, précoce avec la formation sanitaire, mais probablement les médecins ou bien les infirmiers se sont mis à traiter ces cas comme étant un cas de paludisme. Ça, c'est une hypothèse. Donc, c'est plus tard que le prélèvement a été fait pour la confirmation du cas de la fièvre jaune. Donc, pour ceci, nous avons proposé, comme je l'ai dit à l'entame de ma présentation, nous avons proposé des actions correctives, notamment mettre à jour la définition des cas de fièvre jaune, mais aussi établir deux types de SOP simplifiés relatives à la prise en charge des cas suspects, ceci pour les centres de santé, mais également pour les postes de santé. Il faudrait aussi renforcer les capacités des agents de santé, que ce soit des agents de l'État ou des bénévoles. Il faut vraiment renforcer les capacités sur la définition des cas et la prise en charge des cas suspects, mais aussi renforcer la disponibilité des kits de prélèvement à tous les niveaux de la pyramide sanitaire. Nous avons aussi suggéré au secrétariat de AI de préparer un guide spécifique de formation en ligne sur la prise en charge des cas de fièvre jaune. Ceci pourrait permettre aux acteurs de niveau terrain de renforcer de façon continue leurs capacités dans la riposte contre cette maladie. Et nous avons aussi noté un retard, comme je l'ai dit, entre le résultat disponible au niveau central, mais aussi la rétro-information au niveau district. Donc, pour ceci, lorsque les informations seront disponibles au niveau national, nous avons suggéré qu'il y ait déjà des discussions entre le laboratoire national de la fièvre jaune et l'OMS pour voir dans quelle mesure on peut mener un certain nombre d'actions. Et nous avons aussi suggéré de renforcer vraiment l'information sanitaire au niveau des pays parce que c'est ce qui peut nous permettre d'avoir des actions un peu plus promptes. Le deuxième domaine porte sur le temps écoulé entre la confirmation du cas et l'allocation des vaccins. Et nous avons vu qu'il y a eu un retard. Ceci, nous avons suggéré que lorsque vraiment il y a des cas suspects de fièvre jaune, le pays doit contacter rapidement le point focal afro et l'épidémiologie du secrétariat de AI pour discuter sur vraiment l'analyse situationnelle, mais aussi voir est-ce que nous avons besoin d'organiser ou pas une campagne, mais aussi d'évaluer de façon systématique, voir dans quelle mesure on peut bénéficier d'une assistance technique pour le remplissage de la demande de vaccins et contacter, si besoin est, le point focal afro pour effectuer vraiment la demande sur l'assistance technique. Mais aussi, ceci ne doit pas empêcher l'avancement sur le remplissage de la demande des vaccins, même si l'épidémie de la fièvre jaune n'a pas été encore officiellement déclarée, mais suivre également vraiment les recommandations fournies par l'OMS sur les démarches à suivre concernant la demande de vaccins.
Next slide, please. Collègue.
Next
slide, please. No, go back.
Go back. OK. Ah, je suis
I think there is one slide missing. I think so.
No, one.
C'est la même chose que tu as.
Oui, c'est vrai. Il fait le bac, il doit retourner, il doit aller en avance.
Please, go back. No. Go to the table. Yes, but maybe you can continue because I think there are some differences. Il continue encore? Okay, go ahead. Next slide.
Okay.
C'est bon?
Okay.
Hein?
Continue.
Next. Okay, fine.
Bon, je disais par rapport au délai de confirmation des résultats, nous avons suggéré lorsque les cas suspects sont détectés, de contacter rapidement le point focal afro et l'épidémiologie du secrétariat afin de discuter sur l'analyse situationnelle de l'épidémiologie, mais voir dans quelle mesure aussi discuter sur est-ce qu'on a besoin d'organiser ou pas la campagne, mais aussi faire une évaluation, voir est-ce que le pays a besoin d'une assistance technique pour le remplissage de la demande de vaccins et contacter si possible le point focal afro pour effectuer la demande d'assistance technique. Et ceci ne doit pas vraiment empêcher l'avancement sur le remplissage de la demande de vaccins, même si l'épidémie n'est pas encore officiellement déclarée, mais également continuer à s'assurer que vraiment l'investigation des cas a été faite rapidement, ceci pour favoriser la demande des vaccins de façon rapide. Mais également suivre les recommandations fournies par l'OMS sur les démarches à suivre concernant vraiment la demande des vaccins. Suivant.
Next slide.
Oui. Bon, je pense qu'ici, on a mis l'accent sur vraiment l'amélioration du système d'information sanitaire et qui va faciliter le partage d'informations et la prise des actions dans les délais vraiment acceptables. Suivant. Comme je le disais, par rapport à l'analyse des causes profondes liées à l'apparition des flambées d'épidémie, et suivant. Cette méthodologie a été tout à l'heure bien détaillée par notre collègue Dr Nolwen. Donc, essentiellement, ça commence par l'analyse situationnelle qui nous permet de décrire vraiment l'épidémie, mais aussi faire les caps en termes de vaccination, surveillance, mais aussi l'exposition. On ne va pas revenir sur ça. Suivant. OK. Par rapport à la description de l'épidémie, il faut noter qu'en Guinée, on a eu des épidémies pour plusieurs années, en 2004, en 2006, 2005, également en 2010, 2021 et 2023. Mais il faut noter que de 2020 à 2023, les cas de fièvre jaune que nous avons notifiés dans le pays sont presque tous jeunes, c'est-à-dire un âge inférieur à 15 ans. Mais il faut noter que les campagnes de vaccination contre la fièvre jaune ont eu lieu avant la naissance de ces cas. Donc, ce qui peut vraiment suspecter les omissions en termes de vaccination, mais aussi les échecs au niveau de la vaccination. Suivant. Ça est suivant. Il faut afficher le next. OK. Donc, ceci, je pense que ça a été aussi expliqué, c'est de voir les caps en termes de vaccination, notamment liés à l'échec vaccinal, mais aussi les activités de vaccination. Nous pouvons noter qu'au niveau de la prestation de services, nous avons vraiment un manque de connaissances des prestataires, mais aussi la faible disponibilité des personnels, parce que la majeure partie du personnel impliqué dans la vaccination est constitué de bénévoles qui ne sont pas motivés, mais aussi les problèmes en matière d'organisation des séances de vaccination qui sont parfois annulées ou bien retardées. Et ceci est dû aux problèmes de motivation, mais aussi le manque de budget et de supervision. Suivant. 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 OK. Et je pense que ça aussi, ça a été expliqué, hein, c'est-à-dire les caps en matière de surveillance épidémiologique, il y a des lacunes en termes de détection des cas, des lacunes en termes d'analyse et l'interprétation des données, mais aussi l'augmentation de la population forestière qui est exposée donc à cette maladie. Suivant. Suivant. OK. En résumé, qu'est-ce qu'on retient que les deux dernières situations épidémiologiques n'ont touché que des jeunes de moins de 15 ans en milieu rural, mais aussi la vaccination de routine comporte de nombreuses faiblesses, notamment l'organisation des séances de vaccination, le personnel qui est en sous-effectif et en majorité des bénévoles, les difficultés d'accès aux soins existants pour une partie de la population, des lacunes en matière d'information des populations sur les vaccins, mais aussi les délais dans la confirmation des cas, mais également l'augmentation de la présence de la population en milieu forestier, rapportée dans les deux districts sanitaires qui ont fait l'objet donc d'évaluation, ce qui peut donc suggérer une augmentation de la transmission sylvatique. Suivant. Qu'est-ce que nous avons suggéré en termes de prise de décision, réaliser systématiquement après chaque campagne vraiment une enquête par grappe sur la couverture vaccinale, mais aussi réaliser le dénombrement des cibles de vaccination en impliquant les relais communautaires. Nous avons également suggéré de continuer à sensibiliser les vaccinataires à ouvrir des flacons, même si les enfants ne sont pas nombreux lors des séances de vaccination, mais également développer des interventions pour des populations spécifiques liées à cette maladie. Suivant. Et nous avons également suggéré d'effectuer un inventaire exhaustif du nombre de personnels bénévoles travaillant dans les centres de ou bien les postes de santé, ceci pour orienter la planification, mais aussi renforcer les capacités de tous les agents de santé, qu'ils soient des bénévoles ou bien des agents de l'État, sur vraiment sur la prise en charge, mais aussi le diagnostic, mais aussi mettre en place un peu de formateurs au niveau préfectoral et renforcer la supervision formative. Suivant. Et nous avons aussi suggéré de faire l'inventaire des outils pour renforcer la communication, mais également développer un guide de formation sur des messages clés qui peuvent être utilisés par des agents communautaires pour sensibiliser la population. Et nous avons également proposé de réaliser une enquête CAP sur les connaissances de pratique au sein de la communauté en matière de fièvre jaune. Suivant. Par rapport au gap immunitaire, un peu suivant. Nous avons noté que globalement, il y a vraiment une faible couverture sur la base des données estimées, mais aussi il y a des écarts entre les estimations du pays, mais aussi les estimations faites par nos partenaires. Suivant. Et suivant.
Next slide.
Cette carte nous montre vraiment les districts où il y a un déficit immunitaire en termes de couverture vaccinale, les districts où il y a une faible couverture, où il y a un déficit immunitaire sont en rouge, ceux qui sont en jaune, le déficit est moins, ceux qui sont en vert, on suppose que c'est plus ou moins acceptable. Suivant. Ceci nous montre vraiment les localités où il y a un risque élevé vraiment de l'apparition des épidémies de fièvre jaune sur la base de l'analyse du gap immunitaire. Ceux-ci sont en rouge. Les jaunes, c'est le même constat, le risque est moins et vert, le risque est très faible. Donc, voici ce qui met fin donc, à notre présentation. Je voudrais vraiment dire merci à l'équipe du secrétariat AI qui nous a accompagnés dans la conception de ces slides. Je vous remercie.
Thank you very much, Dr. Nestor, for sharing this country experience. Since we are running behind the schedule, I will give the priority to Norwen for those who want to ask a question, address it to Norwen. So for the rest, as the two presenters are here in the room, I think we will continue discussing during the coffee break time. So questions for Norwen? Yeah.
Yes, a quick question for Norwen. First, I wanted to thank her for all the work that she did, and I know it's not finished because, as she said, the tool is under review. But I wanted to ask her if she could, Norwen, if you could just briefly say if you found similar findings in terms of underlying causes of yellow fever resurgence in Cameroon and Guinea.
Okay, thanks. Yeah. The floor is yours.
Do we answer straight or I wait for the questions? Sorry.
No, please let us collect all the questions before giving you the opportunity to respond in one round. Okay.
I don't see the room, so I have just the screen of I have just a slide sharing, so I don't see the.
But can you hear us?
Voilà, I see you now.
Can you hear us?
I can hear you, yeah.
Okay. You have the floor.
Merci à Dr. Mori, merci à Norwen et merci aussi à Dr. Nestor qui a présenté pour les résultats de l'analyse des causes profondes de la résurgence des épidémies de fièvre jaune en Guinée. Je n'ai pas de question pour Norwen. Je voulais juste dire que cette étude nous a permis, en tout cas en tant que bureau pays, de se rendre compte des gaps qu'ils ont trouvés en termes de réactivité du pays face aux épidémies de fièvre jaune. Nous avons substantiellement amélioré nos interventions quant aux épidémies avec l'équipe d'Afro, que Williams, Dr. Blaise et Gertrude qui ne sont pas ici, parce qu'après cette épidémie, après cette analyse, on a enregistré 3 cas dans 3 districts différents. Et cela a permis de nous auto-évaluer. Aujourd'hui, le premier district a reçu les fonds. On a aussi reçu les vaccins. Et donc, le secrétariat a été ici prêt pour nous aider à rapidement mobiliser les ressources.
Thank you.
Okay.
Thank you very much. Yeah, thank you for your comment. This is well noted. And any other questions for Norwen? Yeah, go ahead.
Thanks. My question.
Introduce yourself, please.
Yes, Sergon is my name from WHO Kenya. I just wanted to gather more details regarding vaccine failure, the details of the assessments done for that, and whether it's practical for every other country to do, especially where laboratory is required. Thank you.
Okay, so we will stop there now and give the opportunity to Norwen to respond to this question. Then we will go to the coffee break. Over to you, Norwen.
Okay, thank you. Thank you for the questions. So for the first question, and see if there was similarities between the two pilots that we implemented. In terms of the root causes, it will be mainly the difficulties of having vaccination coverage the difficulty to implement a vaccination strategy according of the results of the vaccination coverage. So it's more about vaccination implementation strategy to use. We found similarity though in the reasons for delay. And in both of countries, there was delays between the results in the national laboratory that was released by the national laboratory, and the time when they sent the samples to the regional office. So that was for the similarities. For the vaccine failure, I try to just see if there is another one that popped up my mind. For the vaccine failure, what we do is we look the observation mainly. So to see, we look at the cold chain and we go at a different level. So either central and also in the districts and the health center level, in the health center, sorry, where the index cases was notified. And we look at all the surveillance records, monitoring sheets, etc. So the things with the difficulty is if the person, of course, if the person was vaccinated a long time ago, is to have these papers available. Is what I mentioned actually during the presentation, is to have availability of data that can make it so difficult.
Thank you so much, Norwen. I think you have already responded to all the questions. As we are now moving to the end of this, the first part of this session, I'm going to give the floor to Raki, who want to give some information before the coffee. From the participant online. The question is for Norwen. Okay, so please, Corinne, please go ahead. If the question is for Norwen.
Thank you very much. No, it's not a question really for Norwen. I'm working at TDR as well with Norwen.
Okay.
Just a quick comment, because I think that at the last slide of Norwen there was this question on what are we going to do with this tool, how it is position, who should use it. We have experience of other tools where we have trained a pool of consultants on the tool, and that can be people from the country who help the other country to do similar work. So what is the strategy that we want to do when this tool will be finalized in June? Are we going to disseminate it? What is the strategy to use it? So this is just a question I'm posing for you to discuss, but I think it's very important that
the question is for strategies or for Norwen?
Yeah, no, it's not for Norwen. It's for the audience. If in your discussion, if you have the time to think about what are we doing with this tool and how we position it, I think it's very important.
Okay, thank you so much. I think you have gained some energy after the coffee break. We will continue with the resurgence of yellow fever outbreak and the opportunities to address. This time I'm calling on Dr. Kolawole Salami for his presentation on immunity gaps analysis. I just wanted to point out that I met Dr. Kolawole in Gambia in 2010. In 2010. Yeah, exactly, at the MRC. So since this date, we are in touch and we are collaborating. I'm happy to give the floor to Kolawole for his presentation. Over to you, Dr. Kolawole.
Thank you very much, Dr. Keita, and good afternoon, everybody, and welcome to this session of the meeting. So I will be discussing measuring immunity gaps for yellow fever. Next slide. Okay, I can see this. Sorry.
Can you please close this box?
Just click on close if it's possible.
Put it on close, then enable editing and put it on presentation mode. Exactly. Okay, fine.
Okay. Yeah. So thank you very much. I don't intend to bore you all with this slide because I'm sure you've seen it multiple times. But the key takeaway from this is that the first objective of the I strategy, which is to protect at-risk population, is one of the key strategies. And that apart from PMVC and routine immunization, we are making a case for catch-up vaccination as an additional tool, and that we believe that catch-up campaigns are a reasonable risk mitigation measure to close immunity gaps in high-risk areas. Why do we think so? Next slide. Yeah, so we think so because despite the gains that have been made in PMVCs and ongoing routine immunization, we've reached more than 300 million people on the continent. Yet some countries still continue to experience yellow fever outbreaks. And we've noticed a peculiarity about these outbreaks, and that's the fact that they are occurring in scenarios in which there is significant immunity gaps, and those include countries with weak routine immunization, where a lot of adults have been missed with PMVC campaigns. This population dynamics is usually affect migrant people or mobile population or people living in hard to reach areas like in conflict setting or geographically hard to reach areas. So because of this, we need to be able to adequately quantify and characterize this kind of populations, and this is the reason why we need to do to assess immunity gaps so that we will know the unvaccinated people in those populations. And the key finding of the immunity gap analysis will now guide us to develop tailored catch-up vaccination strategies to reach these underserved and susceptible populations. Next slide. Okay, so the main objective of the immunity gap analysis is to estimate the yellow fever vaccination immunity gap and to develop a national yellow fever catch-up vaccination plan based on this. And specifically is to estimate the unvaccinated population who are susceptible at both national and national level, as well as to be able to identify those unprotected population group that are at the highest risk of yellow fever among these susceptible populations. Next slide. Okay, so to achieve this, we developed an Excel-based tool, and the tool has two parts. The first part of the tool is to analyze the yellow fever immunity gap at the national and subnational level, but there is a second part of the tool which considers additional factors that can increase the likelihood of a yellow fever immunity gap in communities. And I want to reiterate that there is no serological surveillance or serological data involved in this estimation. And this is important because during the vaccine delivery working group meeting yesterday, it came up a number of times on why we are not using serological surveillance as an additional tool to estimate immunity gap in communities. Now, the countries that we are going to select to apply this immunity gap have to fulfill the 3 criteria. They have to be countries that have previously had PMVCs. They have to be countries that have introduced yellow fever vaccine into routine immunization schedule. And they have to have a recent experience of yellow fever outbreaks. Next slide. Please slow down. One too fast. No, for the transition. Okay. Thank you. Okay. So who are these tools intended for? That would be key stakeholders at the national and sub-national levels. And this includes EPI managers, includes EPI M&E officers, Ministry of Health officials, as well as other relevant immunization key stakeholders at the country levels. Next slide. Okay, so how do we use this tool to calculate the immunity gap? So what we normally do is that we take the total population of a country, and then we also take the total population of the number of people that have been vaccinated against yellow fever in the countries, either through preventive mass vaccination campaign, reactive mass vaccination campaign, or routine immunization. And then we'll deduct the total number from the total number of people in the country to arrive at the number of people that have not been vaccinated for yellow fever. Now, to disaggregate this total population by age groups, we have 2 approaches. So the first one is that we could use administrative country population data, which is aggregated by age. If we have that available, we'll use that to obtain the estimate at national and district level. But if that is not available, we could use the proportion of percentages of demographic age distribution. So for example, if we are analyzing the country and the information we have is that 43% of the people in the country are under 5, and the country's population is say 100 million, then that means we know that 43 million are actually children that are under 5. So we could use this too. So the result of our analysis, we usually interpret it 2 ways. So the first one is if at the end of the analysis we find out that the immunity gap is less than or equal to 20%, which means the coverage is at least 80%, which is good, then we'll say the immunity gap is mild in this particular country. But if it's higher than 20 and up to 40, we can say it's a moderate immunity gap. And if its immunity gap is more than 40, then that is severe. And then we also can do a priority ranking of the moderate and the severe immunity gaps based on the presence or absence of additional factors, which I'll be talking about soon. Next slide. So where do we get the data that we use for this immunity gap analysis? We usually use data from the Ministry of Health Population Estimates whenever they are available. We like using them, but if they are not available, we will use other available sources of data, the World Bank estimates, sometimes the CIA fact sheet. Also, for the vaccination coverage, we find WUNIC to be the most reliable. And then, but we can also use the administrative yellow fever coverage from Ministry of Health immunization data, other surveillance data such as demographic DHS data, immunization coverage data, or post-vaccination campaign reports. Next slide. Okay, so I've talked about the variables. So this just further explain how we do the calculation. So we get the total number of children that are vaccinated through routine immunization, and the PM and total number of people, including adults this time around, that have vaccinated through PMVC, and the total number reached with a reactive vaccination campaign. So we had this together, as I've talked earlier. And then because we have evidence from the literature that about 5% of the people that receive yellow fever vaccine never seroconvert or develop protective immunity. So we multiply this total fever by 0.05 to obtain the 5%, and then we deduct this 5% from this total population. So the final sum will now be divided by the total population and multiplied by 100, and this will give us the percentage of susceptible in the country. Next slide. Yes, so like I said, I've talked about the first part of the tool. The second part of the tool, we made some assumptions, which I will be talking about a little bit more soon. But the key aspect of it is that we did literature review and we identified some key factors that are like the drivers of yellow fever virus circulation in communities. And we found out that in the community where you have seen a case in the last 12 months, or where there is a conflict or insecurity, or that shares border with another country, or where you have significant presence of forest workers, or when you have mobile populations like IDP and refugees, or in a geographic very hard to reach areas. So this actually contributes to the low immunity in communities. So we allocated score based on what we think is the likely impact of these factors on driving the immunity. So depending on how a country scores, it will be then ranked to high, medium, or low. Next slide. So we applied the immunity gap tool to 14 countries that fulfill the criteria I mentioned earlier. Doing that, we arrive at the figure of 59 million susceptible in all of these 14 countries. And out of that 59 million susceptible, about 12.2 million actually belong to special populations. And those are refugees, migrants, and IDPs, and among others. And these 59 million susceptibles actually translate to 66 million doses if we factor in the wastage factor for interventions. Yeah, next slide. Now going to subnational level at countries. This also show that the tool is also useful even at subnational level. So we are going to give the example of Central African Republic, where we applied the tool from our office in Geneva. And you find out that in Central African Republic, there are very wide variations across the districts. For example, a district like Kambula only has about 2,000 people not vaccinated. But another district like Pekua has 100 times more people that are not vaccinated. So this will enable targeted intervention to that district that has this very poor immunity level in the future catch-up intervention campaign, which is what exactly this tool is meant to achieve. Next slide. So we didn't just sit in our office in Geneva to do all of these calculations. So we also went to the countries. So we went to Cameroon and we went to Guinea, and then we tried to use data that is available in country to calculate the immunity gap, and then compare it to what we got when we did our analysis in our office in Geneva. And we discovered that there are actually quite similarities. We are not widely off the mark. For example, in Guinea, the total population of susceptible when we did our analysis in the office was 5.4 million. But when we went to the country, it was almost the same, almost 5.4 million too. And we were also almost accurate when we look at the population above 5 years. But the differences now come when we disaggregate by years, and then we look at 5 to 10 or 10 to 15 years. That's where our analysis was not compatible with what we discovered in countries. Similarly for Cameroon, as we could see down there. So I will just take you on a deep dive of what we found when we went to Guinea. So in Guinea, I'm sorry for this because this had to be cut to accommodate the slide, but I will explain. Next slide, sorry. Next slide. Next slide. Next slide. So in Guinea, so we went to this, and this is a snapshot of what we found when we went to Guinea. I will talk about the Bofa district in Guinea with a population of 348,499. And we found from the administrative data that there are about 156,000 children under 15 years. And among those 12,546 under 5. And we also got population movement into the town from the IOM, it's about 15,151. And from the administrative data that we got in the country, we found out that almost 5,000 actually zeroed those children, and that make up 30 to 40% of the population. So we either, if you look at either the administrative data or the DHS 2018 data. So when we applied our tool, so we found out. So I'll just show how we calculated this. So the number of under 5 and the number of under 5 is that were vaccinated is 54,261. The total number of people that received reactive vaccination is 169,036, and the total number of making the total number of 223,297. And if we now apply the 5% that doesn't seroconvert, that gives us 11,165. And that means 212,132 people actually protected against yellow fever in that district. And so if you deduct that from the total number of people that we have said is in that district, then we'll come down to 136,366 people, or about 36% immunity gap, which means that the immunity gap is high in this particular district. And when we apply that to all of the Guinean districts, we found out that this is the immunity gap map that we found in Guinea. The green areas being the areas that have significant coverage above 80%. Okay, above 80%. And then the orange areas are the areas of moderate gap, and the red areas are the areas of very significant immunity gap. So based on this, the Guinean authority were able to prioritize 10 districts as the district that have the highest immunity gap, and which they want to prioritize for intervention. But we didn't stop at this. We also apply the second part of the tool to this district. And as you can see, and this is what I want to talk about, because when I was talking about the tool, you will notice that the scores are now different from what we have here. Sorry, next slide. Oh my God. Next slide. Next slide. Next. Okay. Yeah. So we'll notice that the second part of the tool, it's the scoring is a bit different from what I showed earlier. And the reason is because the authorities in countries feel differently. about the relative importance of some of these factors. For example, in Guinea, they told us that the presence of displaced people, IDP, and nomads and immigrants constitute a bigger risk. So they will want to ascribe a score of 4 to it. And they didn't agree with us that some of the other scoring that we did. So we are able to use the second part of the tool to now further characterize the street. Next slide. Next slide. Yeah. Did you go back? Next slide, please. Next slide. Yes. So after the characterization of using the second part of the tool, we arrive at 4 districts that are the highest, most elevated priority, and those are the 4 districts on the screen. And the Guinean authorities have actually started talking to WHO and partners with regards to planning a catch-up vaccination to reach this district. Unfortunately, some new cases of yellow fever were discovered, and as a result of that, that has to be put on hold. And for that, now the focus is on reactive vaccination to this area of the epicenter of the outbreak. Next slide. Okay, so the next step for this tool is that we want to further refine the tool. We want to do this by comparing it to other tools. For example, we are talking to colleagues in the measles program who have a similar immunity gap analysis tool, and we believe that their tool has a better granularity with regards to disaggregating the age, and so we want to do that. And we also want to standardize some of the metrics, especially for those factors that I've mentioned as being responsible for driving low immunities in communities. We don't want different countries to have different matrices. And so these are some of it. And then we also want to continue piloting the tool. We want to go to Central African Republic soon to also pilot it and see what the outcome will be. And most importantly, we are going to subject the tool to external peer review. And we want to also consider and the fact how well it could be used with some of the other tools that are being developed as a targeted intervention for the control of yellow fever in countries, like the risk analysis, like the root cause analysis tool that was just discussed with us. So thank you very much for listening. Next slide. And I will take questions now if you have them. Thank you.
Thank you. Thank you so much, Dr. Kola, for taking us through this immunity gap analysis tools with some concrete example from Guinea. And we also understood that the tools is in a pilot phase, and it will also be piloted maybe in a car, I think so.
Yes.
So thank you once again for this presentation. And now I'm going to give the floor to Dr. Bisenge Placide for the last but not the least presentation on the resurgence of yellow fever outbreak and opportunities to address. His presentation will be focusing on Central Republic experience in protecting hard-to-reach population. Over to you, Dr. Bisenge. This presentation will be made in French. Over to you.
Merci, merci Dr. Mori. Bonjour à tout le monde. Je suis Dr. Roch Bisenge, directeur de la prévention par la vaccination pour la République centrafricaine. Et donc, cette occasion m'est offerte pour vous présenter, vous partager l'expérience de la République centrafricaine sur la vaccination des travailleurs à risque dans un district, notamment le district de Mbaïki, que compte parmi les 35 districts du pays. Diapo, s'il vous plaît.
Some technical issues.
Donc voilà, donc on va structurer notre présentation autour on va essayer de parler un peu du contexte, c'est ce qui nous a poussé, nous a amené à organiser cette campagne réactive. Nous allons vous présenter très rapidement les quelques districts en épidémie de fièvre jaune en RCA depuis 2021 jusqu'en 2023. Nous allons rappeler très brièvement également les objectifs de cette campagne que nous avons eu à tenir. Et nous allons mettre un accent particulier sur notre expérience sur la vaccination des travailleurs à risque dans ce district de Maïki. Et donc, pour cela, nous allons rappeler une petite introduction, parler de la situation de ces travailleurs à risque, le déroulé de la campagne, les résultats clés que nous avons obtenus, mais surtout partager avec vous les différents défis auxquels nous avons fait face avant de tirer une conclusion. Diapo, s'il vous plaît. Donc voilà, le district de Mbaïki, comme je disais, fait partie des 35 districts contre la RCA. Ce district a notifié en 2023 un cumul de 6 cas, excusez-moi, 6 cas probables avec IgM positif et 5 cas confirmés avec PNRT positif et 1 cas de décès. Et donc, suite à cela, avec les mécanismes ICG, nous avons pu mobiliser les ressources pour organiser une campagne réactive pendant la période qui couvre le 28 septembre jusqu'au 2 octobre 2023. Je voudrais que vous reteniez bien cette période parce que je pense que dans les leçons apprises, cette période nous aussi nous a permis comme de tirer certaines leçons. Et donc, pour cela, nous avons pour cible les populations de 9 mois à 60 ans qui comptent pour le district 231 213 personnes dont nous avons réparti selon les sexes également, où on a 115 838 femmes et 115 375 hommes. Et donc, parmi ces cibles, nous avons estimé à 26 740, soit 11,56% de travailleurs à risque et leurs familles. Et donc, pour cette campagne, nous avons eu à quand même faire 2 activités novatrices. Notamment, c'était l'utilisation expérimentale de la fiche de pointage qui tient compte du sexe. Voilà pourquoi est-ce que nous avons cette répartition par sexe qui vous a été présentée. Et également, un accent particulier qui a été mis sur la vaccination de ces travailleurs à risque. Et donc, pour notre partage aujourd'hui, on mettra juste l'accent sur cette vaccination de nos travailleurs à risque. Diapo, s'il vous plaît. Et donc, sur cette carte, je m'excuse du fait qu'il n'y ait pas de pointeur, mais un peu plus bas, vers le bas, vous avez le district de Mbaïki qui est juste à une centaine de kilomètres de la capitale, qui se trouve dans la région, selon le découpage administratif, c'est dans la région numéro 1 du pays. Le pays compte cette région. Et donc, vous avez là, en vert, des anciens districts qui ont connu des épidémies qui ont été vaccinés. Mais les districts qui sont aux alentours de Maïki sont des districts qui, jusqu'à aujourd'hui, on a recensé de nouveaux cas et qui sont sur le point aussi d'être vaccinés. Et donc, cet assemblage de districts-là sont dans les régions 1 et 2. Et donc, ces régions sont des régions pour nous où on a estimé qu'il y a de forts risques de transmission de fièvre jaune. Du fait que ce sont des régions forestières, des zones forestières, et où on a beaucoup de compagnies forestières et dont beaucoup de travailleurs saisonniers. Nous avons aussi dans ces districts plusieurs combinés d'or et de diamants et une forte mobilité de population vu la proximité avec les pays tels que le Cameroun et les 2 Congos. Et nous avons également dans ces mêmes régions une forte concentration des populations pygmées. Diapo, s'il vous plaît. Et donc, on s'était donné effectivement pour objectif là de protéger cette population de ce district en vaccinant les 231 213 personnes âgées de 9 mois à 60 ans, hommes, femmes confondus, afin d'augmenter l'immunité collective et plus spécifiquement de toucher quand même 90% des populations cibles, tenant compte de l'aspect genre, d'assurer la surveillance épidémiologique et la prise en charge des MAPI, de collecter et analyser les données de vaccination par sexe et par tranche d'âge, et surtout de sensibiliser et d'immuniser 75% et immuniser 90% des travailleurs à risque et leurs familles résidant temporairement ou définitivement dans ces districts selon les tranches d'âge que nous sommes fixées. Diapo. Voilà, donc là maintenant, concernant spécifiquement maintenant ces travailleurs à risque, diapo suivant s'il vous plaît. Donc là, bon, on rappelle que, comme ça a été présenté hier, l'objectif, quand même là, sinon la vision de la stratégie ACE est d'éliminer les épidémies de fièvre jaune déjà d'ici 2026. Et nous savons que l'un des objectifs est de prévenir la propagation internationale en protégeant ces travailleurs à haut risque, œuvrant dans les secteurs pétroliers, miniers, construction et forestiers, avec une forte mobilité de la population. Et les travailleurs à risque qui présentent un risque à la fois de développer des transmissions et de propager à l'échelle internationale la fièvre jaune. Donc, ces travailleurs à risque chez nous sont essentiellement constitués de ces travailleurs saisonniers, des pygmées, qui sont utilisés très souvent dans des travaux champêtres et donc sont presque tout le temps en contact avec le milieu forestier. Et en RCA, la dernière campagne préventive a eu lieu en 2010 et a eu une couverture de 77%. Donc, on a quand même recensé plusieurs facteurs qui favorisent les mouvements de la population, notamment les récents sites miniers qui se font découvrir pratiquement chaque année, je dirais. Et les frontières qui ne sont pas vraiment, comme on le dit, des frontières poreuses avec les autres pays voisins, notamment le Cameroun, les deux Congos, les activités agricoles et surtout pour les populations ACA, ce sont les périodes de cueillette de chenilles. Et donc, on s'est rendu compte que ces mouvements sont plus accentués courant les mois de mai et de novembre. Et ce qui nous donne, c'est-à-dire qui crée un climat, une situation assez favorable pour la transmission des maladies. Et j'avais dit tout à l'heure qu'il fallait que vous reteniez un peu la date, les périodes à laquelle nous on avait fait notre campagne, qui étaient des périodes de septembre et septembre à octobre, qui nous avons estimé que ces périodes-là sont aussi, si on le superpose à la saison, ce sont les saisons pluvieuses où les gens ils sont plus en mobilité, ils ne sont pas trop dans les activités habituelles, donc ce qui accentue vraiment la mobilité des populations, ces populations qui vont vers d'autres types d'activités selon le climat de la région. Diapo, s'il vous plaît. Diapo. Next slide. It's a video.
La connexion mauvaise. Just 1 second.
Okay. D'accord. Et donc, comme j'ai dit, nous maintenant pour cette campagne, on a pu catégoriser 3 grands groupes de travailleurs à risque, c'est-à-dire notamment les travailleurs saisonniers pour ce district, d'une société forestière, des miniers qui travaillent surtout dans le secteur informel et cette population de pygmées. Diapo suivant. Et donc, pour amorcer cette campagne, traditionnellement, nous avons effectivement commencé par une micro-planification qui nous a permis de recenser sur tous les sites dans lesquels on pouvait retrouver ces différents travailleurs saisonniers. Comme je l'avais dit tout à l'heure, avec le mécanisme ICG, nous avons pu mobiliser les ressources, démarrer les préparatifs mettre à jour les outils, notamment le DHIS2 sur lequel nous avons décidé, enfin utilisé pour collecter les données, et surtout la nouvelle fiche de pointage auquel il fallait déjà se familiariser. Et nous avons également, suivant les orientations de l'équipe A, nous avons pu faire ce découpage des cibles selon les tranches d'âge et par sexe. Nous avons ensuite revu les différentes stratégies de vaccination pour atteindre ces différents travailleurs identifiés. Nous avons formé les différents vaccinateurs, les enregistreurs. Et donc, nous avons commencé autant les séries de sensibilisation, de mobilisation, et dérouler la campagne qui s'est bien sûr cadrée dans un cadre de coordination, de suivi. Diapo. Alors là, nous avons les différentes données que nous avons de ce district concernant uniquement ces cibles de travailleurs à risque. Donc, nous avons, pour ce district, nous avons 6 aires de santé. Et donc, de ces 6 aires de santé, vous allez voir que de manière globale, nous avons pu atteindre que 74%. Vous allez voir que les districts qui n'ont pas, donc déjà la plupart des districts n'ont pas atteint les 90%, mais je dis les districts, la plupart des aires de santé n'ont pas atteint les 90%. Mais là où c'est vraiment faible, ce sont les zones où il y a de fortes activités forestières, mais que pour la période où on a mené les activités, c'était vraiment la saison de pluie, et dans la plupart de ces sociétés avaient baissé pratiquement l'intensité de leurs activités. Donc, avoir ces travailleurs saisonniers pendant cette période, et même dans les champs miniers, pendant les saisons de pluie, est très, très difficile. Parce que pour la plupart, ils sont en mouvement, c'est des gens qui sont perpétuellement en mouvement. Et donc, pour nous, ça a été aussi une leçon d'organiser une campagne pendant cette période. Le diapo suivant, s'il vous plaît. Et donc, ce que nous avons tiré surtout comme leçon, c'est que ça a été une campagne assez complexe, notamment l'atteinte de ces populations, de ces travailleurs à risque. Parce que déjà, premièrement, c'est des cibles qui ne sont pas des cibles du peuple ordinaire. Donc, tout l'aspect de la communication a été assez complexe, assez difficile à aborder. Et donc, pour cela, pour le futur, nous nous sommes dit qu'il fallait définir des stratégies de communication avec des canaux assez spécifiques, parce que les mêmes canaux qui sont utilisés, par exemple, pour les pygmées ne seront pas forcément les mêmes canaux qui seront utilisés pour les travailleurs dans des sociétés forestières ou dans les champs miniers. Donc, il fallait adapter, il fallait maintenant contextualiser et adapter des stratégies de communication en fonction de chaque groupe. L'autre défi, c'était l'aspect de la mobilisation des cibles. La mobilisation des cibles, pour nous, on s'est rendu compte que cela nécessite aussi une approche tant administrative et particulière et parfois très politique. Très politique, pourquoi? Parce que la plupart même de ces champs miniers, parfois, c'est des sites qui sont assez protégés par des militaires et autres. Donc, même pour avoir accès, il faut une certaine autorisation. On a même eu un cas de figure dans ce district où on a un camp de formation militaire, où on a des militaires en formation qui font des manœuvres dans la forêt, où on a eu de sérieuses difficultés pour pouvoir accéder à ce camp, pour les vacciner. Il a fallu toucher le plus haut niveau jusqu'au niveau de l'état-major pour pouvoir nous donner, par exemple, l'autorisation. Et donc, comme je dis, parfois c'est très politique. Et surtout, donc pour ça, on s'est dit qu'il fallait que dorénavant, c'est d'impliquer déjà dans tout ce processus-là déjà de micro-planification ces différents acteurs à différents niveaux. Et nous avons aussi, comme défi, eu les difficultés d'adaptation de stratégies et des équipes de vaccination. Et donc, pour cela, nous sommes avisés maintenant de de renforcer la capacité des équipes de district qui, eux, déjà devaient être en mesure eux-mêmes déjà de autant d'identifier, nous aider à développer des stratégies en fonction de leur contexte. Et aussi, on s'est rendu compte qu'il y a certaines sociétés ont des structures médicales, donc c'est de les impliquer déjà dans ce processus de vaccination de leur personnel. Et aussi, le défi majeur, vraiment, pour nous, c'est l'intempérie et les sites qui sont d'accès très difficiles par la route. Et donc, ça, on s'est dit pour nous, c'est vraiment d'éviter de vacciner en saison de pluie ou en saison de cueillette pour certaines populations. Diapo suivant, s'il vous plaît. Et donc, comme on dit très vite en conclusion, c'est que nous avons, ça a été une riche expérience pour nous, où on a pu tirer beaucoup de leçons pour recadrer nos activités, nos interventions pour les très prochaines fois. Et donc, on s'est vraiment rendu compte que pour atteindre ces populations, il faut des approches très spécifiques à chaque catégorie de population de travailleurs à risque, que ce soit le milieu formel ou le milieu informel, qu'il faut vraiment prendre en compte le mode de vie de chaque groupe de population dans les approches que nous aurons à adresser pour pouvoir les atteindre. L'implication à différents niveaux du processus, de tous les acteurs potentiels qui pourraient nous aider à atteindre ces populations, et surtout le renforcement des capacités de nos équipes cadres dans l'élaboration, selon la proposition de stratégies adaptées selon leur environnement. Diapo suivant. Alors, les 3 diapos suivants, c'est juste des images. Comme j'aime souvent le dire, c'est que derrière les chiffres, souvent qu'on s'assoit, on apprécie, il y a vraiment des efforts assez considérables qu'on oublie souvent d'évoquer, sinon d'apprécier, pour pouvoir atteindre ce type de population. Là, par exemple, vous avez des images ici pour des équipes qui descendent sur le terrain pour accéder à des camps de pique-nique. Et là, ils peuvent vous faire pratiquement des dizaines, sinon des vingtaines de kilomètres à pied dans la brousse, juste pour pouvoir atteindre ces camps de pique-nique. Et ces camps, ce n'est pas un camp, ce n'est pas un grand village. À chaque camp, il faut se déplacer encore des kilomètres pour pouvoir atteindre d'autres camps. Et ce qui rend quand même l'atteinte assez difficile. Diapo suivant. Ici, c'est la vaccination que nous avons eu à faire dans une compagnie forestière. Et comme vous savez, la plupart des compagnies forestières utilisent des gros camions avec, voilà, qui détruisent pratiquement les voies où nos véhicules à nous ne sont pas forcément adaptés pour pouvoir emprunter ces voies, pour pouvoir accéder. Et en plus, quand c'est en saison de pluie, ça rend l'accessibilité aussi particulièrement difficile. Et voilà, donc plus de défis pour l'équipe sur le terrain. Diapo suivant, le dernier. Le dernier, là, c'est un champ, le camp minier, dans lequel on a vacciné. Et les camps miniers, c'est aussi à des kilomètres dans les forêts, difficile d'accès. Et malheureusement, peut-être les images sont trop petites, mais vous allez voir que c'est toute une famille, par exemple, qui va se déplacer. C'est tout un village qui se déplace. Mari, femme et enfants. Et parfois, les gens se déplacent même avec les animaux domestiques parce qu'ils quittent pour longtemps. Ils ne savent pas quand est-ce qu'ils regardent leur village. Et donc, on a de sérieux problèmes déjà même pour avoir l'effectif exact de ces populations, vu que c'est tout le temps en changement. Dès qu'il y a assez d'ordre, dès qu'il y a assez de mines, c'est des gens qui quittent parfois d'autres districts, d'autres zones qui ne sont pas couvertes, qui viennent s'ajouter. Et cela a un impact important sur l'effectif à vacciner. Donc, voilà un peu très rapidement l'expérience de la RCA. Donc, Dr Maury, je me mets à vos dispositions s'il y a des préoccupations, des questions. Je vous remercie.
Thank you very much, Dr. Placide, for your presentation, for sharing this great experience from CAR. This experience can be also applied in other at-risk countries. Despite the challenges you mentioned, And I, honestly speaking, the picture are very impressive. So I'm now going to open the floor for Q&A, but we are still running behind the schedule, and maybe just a few questions for these two presentations for Dr. Kola and Dr. Placid. The floor is open. Question or comment? Apparently, can you check? Can you check online? Who is checking? Joao? Can you check if there is no question online? There is one hand raised there. Who is? Okay, please introduce yourself and ask your question.
Yeah, thank you. I'm Emmanuel Tenya from WHO Uganda. Just in reference to the first presentation, I just want to get a bit of guidance. Given that there is 5% non-seroconverters, what would be the best coverage to guide in terms of countries' target? And then next to that is, in case we want to do a catch-up, when can this be done? After how many years? If a country is underperforming, for instance, if you target at 80%, and then you have the 5% consideration of the non-converter, I would assume you would have a pool of susceptible every after 3 years, just like, for instance, the measles. In this analysis, or from the experience, what would be the best target just to guide the other countries? Thank you.
Thank you, Dr. Emmanuel, for your question, which is very well noted by Dr. Kola. Any other questions? So, if there is no more question, I think, yeah, Dr. Kola, I think you can. There is no question online? No? Okay, fine. The floor is yours.
Thank you very much, Dr. Emmanuel, for your question. So for the 5% people that do not seroconvert when vaccinated for yellow fever, like I said, I mean, we use this basically to be able to do our calculations on who are the susceptibles. Now, if you want to roll out a vaccination campaign, after you've done analysis of the susceptibles using the immunity gap analysis tool, then you set out to vaccinate actually 90 or more than 90% of everybody that you feel are susceptible in that location. Being confident that even with the 5% non-responder rate, you must have gotten more than 80% of coverage that is needed to keep outbreaks at bay. Secondly, like we've said several times, a catch-up vaccination campaign is not a substitute for routine immunization or PMVCs, which are still very viable tools in our hands to control yellow fever and eliminate outbreaks. So what it does is that it's just is another ancillary tool that we could use to get to arrive at our destination. So because of this, even when you've done a catch-up campaign, you are still expected to strengthen routine immunization and make sure that it keeps going. So once we have very strong RI, even the gains that we've made with catch-up vaccination and the gains that we made with PMVCs are likely to be sustained. Thank you.
Thank you, Dr. Kola, for this clear answer. So now, I think we are at the end of this first part regarding the presentation. The last session will be a panel discussion, which will be moderated by Lawrence. So I'm going to give the floor to Lawrence for the panel session. Over to you, Dr. Lawrence.
Yeah, thank you very much. So, yes, I will call, please calling the panelists to, you can stay around. So I'm calling Ado Bwaka to the table, please. Amadou Yakubu, Alvaro Wittenberry, please come with your nameplates, and Nestor Leno, whom we had the chance to hear speaking earlier today. Nestor, si vous voulez nous rejoindre. Marie-Ève, he should be here, so maybe I'll move. Because otherwise he won't be seen. Okay. So Nestor, you may sit here, and Maria will help with the translation. Just a note to the interpreters. I will be speaking in English when I address Dr. Nestor. I will repeat the question in French. And during his interventions, he will speak in French, and Marie-Ève Ragnaud, who's sitting next to him, will translate his responses in English. Is that the modus operandi? Is that modus operandi okay with everyone, including a translation or interpretation level? Yes. Okay. Seeing the nod. So thank you, first of all, to the panelists. Merci aux panélistes for providing your insights on the added values, pros and cons on catch-up interventions and the relationships vis-a-vis strengthening routine immunizations. You've seen in the panel is named catch-up interventions versus strengthening RI, and there were some interesting points made by Alvaro while we were preparing the panel on what this versus could or should mean. So I look forward to hearing from you about this. So I'm pleased to introduce this a varied group of panelists. We have Ado Bwaka from the IST West, representing the Afro regions, Amadou Yakubu from UNICEF headquarters, Cassandra Quintanilla from Gavi and the iVaccine Delivery Working Group, Alvaro Wittenberry from PAHO, and Nestor from Guinea. It's very interesting to have all those agencies and levels perspectives. And again, the vision is to have open discussions, getting closer to the realities and the feasibilities, etc. So we'll hear from the panelists on a set of questions. Obviously, this is also a very engaged session. We look forward to hearing from the room, hearing from the persons online, be it for comments or for questions. Santosh, also, we do want to rely on your expertise. Feel free to jump in as you want, and I will come on to you for comments as well. So we'll start with the questions. Nestor, est-ce que vous voulez que je... Oh, tout est bon, d'accord. So we'll start with Ado. Ado, could you please tell us about the regional perspectives on catch-up interventions and share some key examples about practices and lesson learned, especially in terms of opportunities for integration and if non-vaccination services are also offered. I have another question for you, but maybe I'll let you address this one first, unless you want me to go for the two at once.
This one. Okay, thank you, Lawrence, and thank you, my colleagues, panelists. I think from the presentation Lawrence made this morning, we understood and we saw that the I Secretariat has requested some guidance from the SAGE, from the RITAG, and last week there was actually a meeting, a RITAG meeting that focused on the yellow fever, among other agenda items. And as we know, WHO has developed in 2021 a guide on decision-making and planning for catch-up interventions. Though the guide does not have any specificities for yellow fever. So I will encourage all of us to go through that document. It's called Decision Making and Planning Consideration for Integrated Health Campaigns. For Afro, I think that we are going to take the recommendations from RITAG and try to internalize it and contextualize it to our situation. And then, secondly, I think with in collaboration with the ICE Secretariat and from the root cause analysis findings that is going on, and the risk assessment dynamics, we will need to provide some specific guidance to countries and maybe assist them in developing some simplified SOPs in implementing this guide that was developed, even in terms of clear definitions of what is catch-up. Because from the discussions yesterday, I think you could hear that there are still some discussions around what we call catch-up vaccination. I think we are also thinking of supporting countries to modify or adapt their vaccination policy. And this is basically, for example, for the Big Catch-Up Initiative. We have countries that have not yet recommended any vaccine above the age of 2 years. As we know, our routine vaccines are actually given to children to 2 years, basically, in most of the countries. So through through NITAGs that are established in countries, so our support is to provide guidance and support to NITAGs for them to advise Ministry of Health in adapting those policies in terms of the age of catch-up vaccination. We are also, of course, the guide that I made mention of was issued in December 2023. So we have not had time to very much disseminate it and build the capacity of countries in the use of this guide. So I think we will also make efforts to support countries in the dissemination of this guide and build their capacity in terms of the catch-up vaccination policy. I think we have also some opportunities that could be used to make sure that we vaccinate not only children, but also adults with yellow fever vaccine. And one of the opportunities is the Big Catch-Up Initiative that I've just mentioned. We have prioritized 14 countries in the region as high priority countries for Big Catch-Up. But as I said this morning, with the waiver that has been obtained from the Gavi board in December, we are also encouraging other countries beside these 14 countries to apply for the additional doses of vaccines to catch up children that were missed between 2019 and 2022, at least for the 2 years, 2024 and 2025. This is the period for which this waiver is applicable. So I think this catch-up opportunity will be at least an opportunity to catch up children up to the age of 5 years, and yellow fever is one of the vaccines that could be included in the initiative.
a final point? Maybe.
Okay, so there are some other opportunities. I think we have some other campaigns that we can integrate yellow fever vaccine with for countries that are going to do, for example, measles, rubella campaigns. We should use any other opportunities like school vaccination, reactive campaigns, and ensure that the life course platform, the second year of life vaccination is also encouraged in our countries. We have had some examples in the past where countries have integrated, for example, measles and yellow fever vaccination. So this could be also shared with other countries to use the same experience. Nigeria is one of the countries. Guinea, Sierra Leone have had this before. So I think countries can chat as well recently. So we could use those opportunities. So in short, I think we will also need a multi-sectoral and a multi-partners approach for us to be able to catch up children and adults with yellow fever vaccine. Thank you.
Thank you very much for this. I will pass on to you, Alvaro, and I will actually have similar questions, but from a PAHO perspective. So could you tell us about the regional recommendations on catch-up, the ongoing practices, and if you have some examples and lessons learned. I also want to come back to what you presented yesterday on Venezuela. You presented a clear example of a campaign. So in a country like Venezuela, how easy or difficult is it to find the proper complementarity between routine immunization strengthening and catch-up campaigns? Thanks.
Well, I hope I will remember the question properly. If not, just let me know if there is something there. I was thinking about what you said many times, that this I strategy is a living. It's a living strategy that it's continuously evolving, and this is what has happened with the response in the region to the yellow fever, because yellow fever has changed a lot. It started as a urban threat, as a urban disease, and then as the living conditions in the urban areas improved, then it became more a sylvatic disease. And nowadays, what we have is mainly a sylvatic transmission in the region. Therefore, our interventions to fight against the yellow fever has also been changing. And the recommendations from the TAG has also been evolving all through this year. So I was just checking on the recommendations that date back to 1990 something. And the first recommendations were oriented in order to vaccinate people living in endemic areas. And of course, the recommendation was to vaccinate everybody living over there. And then it started changing with vaccination or implemented vaccination in areas where migrant workers usually went to travel into these endemic areas. And then it evolved again, and the recommendation was to also vaccinate people living in areas where they may have some other risk factors for or that may facilitate introduction into urban settings of the disease. So in the end, what we have is a recommendation that clearly states that you should have a regular vaccination schedule against yellow fever in all the countries that are endemic. That means everyone at the national level should get the vaccine at 12 months of age. And then, of course, you should pay special attention to other age groups or to other people that may have left behind in the vaccination efforts. Because in order to avoid cases in our region, we need practically everybody to be vaccinated, because we don't know who is going to enter or not these zoonotic areas and may catch the disease, and therefore an outbreak may occur. So right now, the indication is to have a regular vaccination schedule that is not opposite to these catch-up vaccinations, but it is a complementary tactic in order to try to get as many people as possible to get vaccinated and immune against the yellow fever. So these are not opposite, but part of the same view in order to try to tackle this disease. There is not a clear time interval, at least at this time, to determine when to or not implement these catch-up vaccination campaigns, but more based on a risk analysis, or maybe more based on this immunity gaps analysis. So once you identify that you have many people or a huge gap there in immunity in certain areas, then you need to start vaccinating there, because you know you will start having cases. And also, if you identify some episodics, then you know that the people living around, or the people living in these corridors should also get vaccinated. It's not always easy. Sometimes it's very tricky. We were talking about how are we going to vaccinate some areas where usually healthcare workers have no access, or may not have access because illegal activity is going on there. So countries have been very creative in trying to identify different ways to approach them, including in sometimes even coordinating with local leaders for them to have access and vaccinating the populations. As these interesting photos we have seen also when you have been vaccinating in mining sites in Africa. So this is a very ongoing process, and it's a very living process too, that we are also learning, trying to identify what would be the best way in order to avoid reurbanization of the disease, and trying to avoid the presentation of cases too. In relation to Venezuela, the last campaign for yellow fever had been many, many years ago. So they were trying to, based on their analysis of immunity gaps, to identify when was the proper timing to get these vaccination campaigns implemented, because of the shortage of vaccines too. So one of the recommendations of the TAC is that each country must have these stockpiles of vaccines in order to respond, but mainly to outbreaks. So the response to outbreaks will not be these huge mass vaccination campaigns, but usually more focused vaccination campaigns in the higher risk population areas. So in order to implement these vaccination or catch-up vaccination campaigns, or preventive mass vaccination campaigns, then countries must plan ahead and to try to identify how many doses they will need, and will usually work in phases, or implement the vaccination in phases, because usually vaccine will not be available in the total amount they may need for the whole country at some specific time frame. So they decided to implement that in 3 phases in Venezuela, addressing first the higher risk areas, and the higher risk areas, of course, will be determined considering the presence of cases of yellow fever. Of course, due to the presence or not of non-human primates, and some other environmental and entomologic indicators. So they identified that first and try to tackle these high risk areas or higher risk areas first. Then they will move to moderate risk areas, and then to low risk areas too. And finally, they ended up vaccinating the whole country, because right now, with the problem we are having with Aedes aegypti and all these problems with the infestation we are having, then we think in most of our countries we will have this high risk of introduction, especially in urban areas too. So this is what they were thinking, and try to identify and plan ahead in order to implement. This year they will be doing the last phase, and they were able to get the vaccine in order to implement that. and other countries in the region are updating their plans also, including they're planning for new catch-up vaccination campaigns in order to diminish the number of susceptible people in order to try to protect them against the disease. I don't know if I answered.
Thank you. Thank you, Alvaro. And thank you also for insisting on the importance of countries' leadership, I think, in developing their plans and implementing the actions. We'll hear more about the immunity gap analysis that you mentioned in the afternoon's presentation. But thanks for your interventions. I will now call on to Amadou. And I think what would be interesting is the fact that you've worked on the maternal neonatal tetanus elimination and the associated efforts to reach the often neglected and remote rural communities that are neglected that don't have access to services. So for those communities, which as we also saw, are the ones affected predominantly by the resurgence of outbreaks of yellow fever, how efficient is it, in your view, to provide routine immunization? And will there be value to deliver vaccines and other services, as we mentioned, in some instances, be it immunization or non-immunization, through tailored interventions such as catch-ups? What would be the value add for you? Thanks.
Thank you so much, and good afternoon, colleagues. Basically, the issue of maternal and neonatal tetanus elimination had been used before the advent of zero dose as the indicator of inequity in access to services. And we know that when we link it to zero dose, it's issues of multiple deprivations. And if we look critically as to why we end up having neonatal tetanus cases, it's failures that we encounter at different levels. Failure of the immunization system to catch the woman early in life or the child early in life, because it's built up to the vaccinations that are started right from childhood. Either DTP containing or Penta vaccine is containing tetanus toxoid component. And the series that is given early in life, basically the body remembers, and it's just building up the 3 doses initially given, which basically counts as 2 doses of tetanus toxoid containing vaccine in terms of protection, because the interval between the second and the third doses given early in life is very minimal interval. And so the body basically remembers that it has received 2 doses of the vaccine. I'm saying this because I'm counting towards the protection. And during the second year of life, the booster dose given counts basically as the 3rd dose for tetanus. And at school entry, an additional dose is recommended by WHO to be given, and TD vaccine is recommended for that. So basically, meaning the 4th dose. And then early in adolescence. But just to tally it with the time when we give HPV vaccine, the recommendation is that at 9 years of age, another dose should be given. So basically, once the doses are given, first dose as first contact, second dose at least 4 weeks later, third dose at least 6 months after the second dose, fourth dose at least 1 year after the third dose, and the 5th dose at least 1 year after the 4th dose. So when you give in the sequence that I initially mentioned, it's more likely than not that the woman will already be protected for life, so that when she becomes pregnant, then the unborn child or the newborn child will be born protected. So it's failure of vaccination basically at this instance that leads to neonatal tetanus. That's one failure. Another failure is failure of the system to ensure that that woman who becomes pregnant attends antenatal care and is assessed if she is due for any dose of tetanus toxoid vaccine she's given, and to be advised also on clean delivery and clean care practices, because the other failure is
failures are those of the delivery itself that is not clean, that then leads to the infection that may occur during the delivery or during the cord care practice, so that substances are applied to the cord. In the same instance, we mentioned for yellow fever the issue of neglected populations. And so the neglect basically meaning they do not have access or the voice to seek for the service, or even to have that knowledge that they need to benefit from the services. As was mentioned in the Gavi introduction, the video earlier, the coverage was said to be around 44% at best. So which is really far below what will have been required. So basically the immunization system has failed to be able to reach all those eligible for the vaccination. And failure also in vector control that will have probably reduced the contact between the mosquitoes responsible for transmitting the virus and the population. So it's basically issues around addressing inequity in access to services that will be very helpful in this instance. In which case, the catch-up that we have been talking about is not just catching up those that missed vaccination. It includes catching up those that missed vaccination, but also restoring the system or levels of coverage to what we used to have pre-pandemic. Because even pre-pandemic, we had a number or large numbers of children or the population that were not being reached by services. And it was at that point that efforts were then made towards addressing inequity in access to services. Because if the focus is basically on coverage, you will be reaching the same population that you are reaching. You need some additional investment to really reach those that the 15% or 14%, because pre-pandemic, at least for DTP or DTP containing vaccines, we had 86% coverage. So the 14% that we were not reaching, the focus then at the time was on equity, which basically means additional investment, and which is basically what this catch-up is trying to tell us. So restoring to the pre-pandemic coverage levels, but not only that, strengthening the system to be able to deliver not only immunization services, but other primary healthcare services also. So basically meaning engaging with the community as much as possible to have a better understanding of their felt needs that need to be reflected when we deliver services, not only to be delivering immunization services when they may have some other basic needs that may require community health workers to be able to deliver those services, and also to provide that linkage. We have had situations where when you have community health workers, they are able to make your outreach services more efficient, because then they can serve as linkage between the health services and the community, so that the community members will be aware of when health workers will be coming for the outreach services, and then where the station will be, etc. We had one very interesting encounter in Uganda. I think that was probably 2005 or thereabout. We were out on field visit, and around almost 4:35 p.m., that was when women were going out for the immunization services. That basically indicates good linkage with the service itself. Otherwise, at that time, the health workers will not be there if there is no agreement with the community members that this is the best time to visit. The health workers will have likely visited in the morning when women might be either out in the field or in the markets or elsewhere. So if we are able to establish these linkages, it's more likely than not that we can be able to reach those that we are missing consistently with yellow fever, but not only yellow fever, but other vaccines also. So it's more of the so-called win-win situation once that level of engagement is made. Thank you.
Well, thank you very much also for highlighting the importance of the community health workers and working at the community level. We'll now pass on to Cassandra, who again is co-chairing the eye vaccine delivery working group. Thank you for this. So, from your perspective, steering this group, would you like to reflect on the complementarity between the catch-up interventions and routine immunization, and also how the catch-up interventions can be used as an opportunity to strengthen RI, and also possibly reflects on the importance of integration and synergies?
Laurence, sorry to interrupt. Just a polite request for all the speakers to slow down a little bit with their responses, just to assist the interpretation. Sorry to interrupt. Thank you.
No problem. I'll think while I speak. No, thanks, Laurence. I think as part of the vaccine delivery working group, we've all agreed routine immunization is the pillar to actually achieve the goals of the eye strategy. Now, all of the other type of catch-up interventions that have been mentioned so far, or that even we're discussing as part of the working group, are really meant to complement the routine immunization strategy, either on an ongoing basis or specific pulses or push in several moments. Now, like Ado mentioned, there has been a lot of debate just because there's some misunderstanding on what is it that we mean when we say catch-up interventions. I think for one side, we're looking at catch-up interventions that are very much linked with the delivery platform of routine immunization. And in those, we can imagine the big catch-up, we can imagine periods, and that are very much in tune with each country's own catch-up policies that can go, up to second year of life or even for under fives. And that these actually are designed to support the ongoing routine immunization efforts. So in that case, linkages have been made. Normally, that platform is already quite horizontal, so it's not necessarily just yellow fever. Now, I think it's important for all of us in this partnership with our yellow fever glasses and our yellow fever perspective to leverage all those interventions and to really advocate for yellow fever to be considered amongst those efforts. So, for example, on the big catch-up, Ado was mentioning there's a few countries that have already submitted an application. But even among those, I believe you said 14, 15 countries, there have only been 4 that have included in that request yellow fever. So far we have Cameroon, Chad, Burkina Faso, and Guinea. So clearly for all the other countries where yellow fever it's relevant, meaning that they have yellow fever in their routine and that they potentially have some backsliding on their coverage since the pandemic, that they could also include yellow fever on these big catch-up interventions. Now, there are other types of catch-up interventions that have been discussed as part of the vaccine delivery working group that are coming out of the discussion of the immunity gaps that our colleague Kola outlined already in the previous presentation. And that it's more in the perspective of catch-up campaigns. I think that is where it can become a bit more confusing. But I think unlike the other category where we're really looking at in under 2, under 5, little pulses of support that are ongoing for routine immunization. When we're talking about catch-up campaigns, we're really talking about a campaign modality in terms of delivery, about a one-off activity that it's with a larger target group, even though it's still meant to be a targeted implementation in terms of the selection of that target, it's definitely being considered above age 5. Now, for those types of interventions, just because it's a campaign modality, we normally tend to think of those as very much vertical approaches. And here is where the integration perspective is quite relevant, and how we can use campaigns in general and in specifically yellow fever campaigns to support the strengthening of the routine that we know it's quite a challenge for yellow fever in particular. Now, overall campaigns can be used to strengthen routine, starting with the identification and the reach of zero-dose children, like Amadou was mentioning. So already, for example, when zero-dose children have been identified, we can use that information to really target strategies in a campaign modality to reach those individuals and those children, and either refer them to health facilities, as has happened on some campaigns, or already deliver the antigens that are part of their routine scope. And that we've seen happen in, again, several campaigns, not just yellow fever. There's also another area, which is integration. And integration can be from co-delivery of different antigens. So Ado mentioned, we've seen very much a co-delivery of measles, yellow fever campaigns, measles, MenA, yellow fever campaigns. And there have been some successes in achieving those strategies. However, sometimes there's also some challenges, and sometimes co-delivery is not possible. So I think it's important that when we think of integration, we not only think of co-delivery, but really integration in the whole scope of that activity. Meaning, it can be integrated planning, or leveraging trainings that have happened for other activities, or leveraging either a mapping of zero-dose populations, or already some other tools and guidelines for monitoring the activities. So all that can really support for the more efficient and effective intervention for yellow fever in particular. I think this is particularly useful for countries that more and more are seeing competing priorities in their health scope. Thankfully, we have more and more vaccines now available for countries that are being considered in their menu of support and what they can include in their immunization strategy. But of course, the challenge then is how can we make sure that yellow fever remains still a priority among the other areas? And how can we make sure that then it's not lost in the noise, and we can continue working on it? And I think one of the responses is we don't look at it in silo. We need to really look at the complementarities of all the different programs. We need to look at how the linkages can be created between existing routine immunization and more one-off strategies or interventions in a campaign modality, in order to have a sustainable approach and improve this coverage that has been hurting for yellow fever. Also, part of the vaccine delivery working group analysis and areas of work has been to look indeed at the coverage of yellow fever. And even though in the majority of cases where the yellow fever coverage is it's less than ideal, or it's very low, we see it very much aligned with other antigens that are delivered in the same time point. And so that could indicate that it's actually more of a health system issue, and so that needs to be addressed with support to the health system. However, there's still a handful of countries whereby there is quite a disparity between yellow fever coverage and measles first dose coverage, for example, both delivered at 9 months in African countries. And so there is the analysis that we're trying to move ahead with, and really going more in depth to understand then, okay, if there is actually that gap of coverage, does that indicate then a yellow fever program specific issue? And if so, how can we as yellow fever partners support to address that yellow fever issue? And so we'll continue those conversations to try to strengthen routine, to try to make the linkages between catch-up interventions, more specifically catch-up campaigns that are now being discussed as potentially being integrated as part of the overall yellow fever strategy of implementation, in order to really have a comprehensive approach for the strategy.
Thank you, Cassandra, and this is a next segue to the discussions with the next panelist. I'll switch to French for my question and then say it in English again. Dr. Nestor, on va passer à vous. Vous avez clairement indiqué l'intérêt de la Guinée, représentation plutôt pour les campagnes de rattrapage, au-delà du Big Catch-up. Envisagez-vous de mettre en œuvre ces campagnes en combinaison avec d'autres services, vaccination ou autres? Et dans quelle mesure les interventions de rattrapage peuvent être utiles pour renforcer la vaccination de routine en Guinée? Et également, en lien avec la dernière intervention, quel type de soutien attendez-vous du partenariat AI? Si vous permettez, je vais traduire en anglais et puis ce sera à vous. Mais moi, je vais,
Okay.
non, il n'y a pas de. So the questions to our Guinea colleagues is as follows. So they clearly described Guinea's interest for catch-up vaccinations for yellow fever beyond the big catch-up. And my question was about the plan, whether a plan existed to combine these campaigns with other services, immunization or others. And to which extent, Dr. Nestor, think that the catch-up interventions can be used to strengthen routine immunization in Guinea? And then in link to the last points, the point made by Cassandra, what support do you expect from the AI partnership? Thank you.
Merci beaucoup, Laurence, pour la parole et merci également à nos collègues panélistes qui ont déjà dit beaucoup d'éléments, peut-être qui sont pris en compte dans notre plan de Big Catch-up que nous avons développé au pays. Bien sûr, je commencerai à dire oui par rapport à votre première question, quand vous avez demandé si nous sommes intéressés à mutualiser et intégrer des services de vaccination pour au-delà du Big Catch-up classique que nous avons l'habitude de faire. Je dirais oui. Et pourquoi aussi le Big Catch-up est important pour le renforcement du système de vaccination de routine. Et vous savez, la raison elle est très simple. C'est lié au contexte. La Guinée fait partie des pays où nous avons beaucoup d'enfants zéro dose. Et si nous avons des enfants zéro dose, c'est parce que cela aussi peut augmenter le risque de survenir des maladies évitables par la vaccination. Parce que le plus souvent, nous mettons l'accent sur les couvertures vaccinales pour apprécier la performance des programmes de vaccination. Mais moi, je vais au-delà. Le plus souvent, je dis, OK, si la vaccination elle est bonne, la couverture elle est bonne, ça veut dire qu'on ne doit pas avoir des maladies évitables par la vaccination. C'est pas si je continue bien, vous allez traduire cette première partie, je sais pas.
Sure, maybe I'll translate that. So he's thanking all the panelists, and yes, he's interested in integrating yellow fever to the big catch-up, and that it's important, he agrees, to strengthen the routine immunization, and that in Guinea there's a problem, and that's the main reason, is that there's a high number of zero-dose children. And then he went on to mention that they're using coverage rate to assess if the performance of the vaccination and to see if to assess the risk of outbreak in that age group. Je te laisse continuer.
Ok, merci beaucoup pour la traduction. J'entends très bien, mais pour des fois, j'ai des problèmes pour communiquer, quoi. Mais j'entends à 80% ce que les gens disent. Merci. Donc, je disais que pourquoi nous avons beaucoup d'enfants zéro dose, c'est parce qu'il y a des faiblesses au niveau de la vaccination de routine. L'une des premières faiblesses, c'est la discontinuité des services de vaccination. Des enfants qui bénéficient un certain nombre de vaccins, le plus souvent, il y a une déperdition pour compléter des doses de vaccination. Il y a également une faible utilisation des services de santé par la communauté. Ceci est lié au faible accès aux services de santé. Le plus souvent, il y a des centres de santé qui couvrent un grand nombre d'habitants. Ça fait plus de 10 ans, on n'a pas actualisé la carte sanitaire pour faire un découpage vraiment réaliste basé sur la population. C'est ce qui fait que le centre de santé ne peut pas couvrir à 100% la population cible de son aire de santé. Mais il y a aussi la faiblesse dans l'organisation des stratégies avancées. C'est on organise les stratégies avancées pour attraper. Mais vous savez, si les formations sanitaires ne sont pas utilisées, les services de santé ne peuvent pas faire des recettes pour organiser des stratégies avancées, parce que dans la gestion des soins de santé primaires, le plus souvent on dit que l'organisation des stratégies avancées fait partie des dépenses incompressibles. Mais si le centre de santé n'a pas les ressources pour organiser, ça va être un peu difficile parce que le service n'est pas utilisé comme il le faut. Et également, nous avons des problèmes de sous-estimation des cibles, parce que si les centres de santé se réfèrent aux estimations faites par l'Institut national de la statistique, basées sur le recensement qui a été fait en 2014. Donc, si on utilise ces données, c'est comme s'il n'y a aucun enfant à rattraper. Et pourtant, nous avons des cas d'épidémie dans la communauté. Et quand on fait des estimations, on fait des enquêtes, on se rend compte que les estimations ou bien les enquêtes donnent les couvertures qui sont vraiment au-dessous de les couvertures administratives.
Yeah, I'll just translate that. So just one, some of the reasons for this very weak routine immunization is the lack of geographical access, which is an important feature in Guinea, and actually not 100% of the population is covered by the different health facilities, and which means that there's, as a consequence, a problem with the advanced vaccination strategy because of lack of resources that the health facilities have, because of this lack of decreased frequency use of the health services. So it has an impact on the advanced vaccination strategy, which the health structures cannot afford to pay. And then there's also a problem with the denominator in Guinea. The last population census was in 2014, and so that's what they're using. And of course, we know there's population growth, and so that's also contributing to the weak routine immunization.
Okay. Merci beaucoup. Face à cette situation, nous avons proposé, il y a le Big Catch-up classique qui cible les enfants de moins de 5 ans, mais nous avons proposé dans notre approche d'aller au-delà des cibles de moins de 5 ans. Donc, il y a des approches classiques, c'est en termes de mutualisation des activités de routine que nous avons. Il y a les activités de vaccination intensifiées pour renforcer le PEV de routine. Ça, c'est pour tous les antigènes que nous utilisons dans le PEV de routine, y compris le TD pour les femmes enceintes. Donc, ça cible toutes les régions sanitaires du pays, les 38 districts sanitaires. Donc, au-delà des enfants de moins de 5 ans, nous voulons profiter de cette opportunité pour cibler des adultes dans les districts que nous considérons les districts à haut risque par rapport à la fièvre jaune. Mais aussi, vous savez aussi que nous avons une épidémie de diphtérie dans le pays, également toucher des districts, des adultes dans les districts où nous avons le nombre élevé de cas de diphtérie. Ça, c'est lors des ABI, mais aussi profiter des stratégies avancées pour toucher des adultes, pour la diphtérie, mais également pour la fièvre jaune. Et nous avons autre approche aussi d'intégration. J'ai fini ça et puis c'est reste d'autres approches d'intégration, c'est des campagnes de vaccination spécifiques. La campagne de vaccination contre la polio, nous intégrons aussi le rattrapage des enfants, surtout pour le Penta. Et nous voulons aussi voir pour des districts spécifiques si on peut aussi intégrer la vaccination contre la fièvre jaune pour des adultes et pour des enfants. Nous avons également en projection l'organisation de la campagne contre la rougeole. On va procéder de la même façon. Donc, globalement, c'est vraiment profiter de toutes les opportunités de renforcement du PEV de routine, toucher vraiment des cibles dans les localités à haut risque par rapport à la diphtérie, mais également à la fièvre jaune.
Yes, so the two strategies, one relates to the intensive vaccination activity, which targets all the districts of the country, the 38 districts, for the children. And so what they plan to do is include also adults for yellow fever and also the diphtheria in areas that are affected by the diphtheria outbreak. And for the yellow fever, they will focus on these districts that were highlighted to have a high immunity gap. For yellow fever. So that's one strategy that's planned. And then the other is related to the vaccination campaigns that they plan to do for polio and measles, again, targeting children, and where they would include the yellow fever antigen and also expand the target age group to include adults.
Merci beaucoup pour la traduction.
Laurence, we must call time soon on the panel. We must call time soon on the panel. Can you hear me? Thanks. Amadou has a half an hour presentation after this.
Yeah. So we don't have time for questions. Is that what you're saying?
Amadou has a 30-minute presentation after this. We are quite late.
All right, so I just maybe ask Tentosh for quick comments, and then we'll move on to Amadou, and I'll pass back to the chair of the session. Thank you.
Thank you, Lawrence. Very helpful insights from all the panel members. Just I wanted to bring in one perspective from the measles side is, I think routine immunization is the foundation, right? Like as Cassandra mentioned. And then I think at the strategic level, we say that countries who don't have an MCV coverage of more than 95%, we go for a nationwide non-selective campaigns, and then there is a catch-up campaign in the measles world, right? Like it's a one-time thing on a broader age range, and then we have follow-up campaigns. It's pretty well defined. But just to narrow this discussion down in terms of a targeted approach for measles, we are working on a guidance document which is more around tailored interventions for targeted approaches on age range and based on geography, but also defining selective versus non-selective, right? So that's somehow we are kind of shaping the missed communities in the measles for a targeted approach. So I just wanted to kind of bring that up so that we can have some synergies around the catch-up in the broader routine immunization context, but also with the measles antigen. Over.
And thank you. I think that's also an important point. It's integration also in the development of the guidance. We'll stop here. If there are questions for the panelists, you may put them in the chat or ask. We have a Zoom moderator for the morning. Who's the Zoom moderator for the morning? Or do pass them on to Raki and colleagues. We'll make sure that the panelists address those and respond to you either during the meeting or via emails. And now I want to pass on to Amadou for another example of collaborations among initiative and how to leverage existing mechanisms to advance the yellow fever agenda. But the chair is back. Sorry, I hadn't seen you, Maury. Over to you.
No, we have just agreed with Amadou to postpone his presentation after the launch. So if this is fine with everyone, we'll go for the launch. Then Amadou will present when you are back.
Thank you, and colleagues. Welcome back from lunch. We have left out one of the presentations from the last session, as we are aware. So we'll start from there and proceed with other planned agenda items. Basically, the presentation is on integrated outbreak response capacity building in countries, and with an example, basically on the issue of yellow fever in this instance. Because when you are talking about the interagency or international coordinating group, it's basically an interagency grouping that is responsible for managing the stockpiles for identified diseases. Next, please. So this is the outline of the presentation, basically looking at the ICG overview and the mechanism itself, and then zeroing down on yellow fever and the current challenges and the way forward. Next, please. And next. A number of us here are aware of the major meningitis outbreak we had in 1996. At the time, I was an epidemiologist in one of the states in Nigeria, and line listed cases in one state was over 15,000 cases and over 1,200 deaths. So it was really a major meningitis outbreak. And the challenge faced at that time was the issue of access to vaccines to respond to the outbreak. And this culminated into the need to establish a mechanism that can be managing outbreaks for diseases that where access to vaccines are really quite challenging, so to say. It's basically for the provision of emergency vaccine supplies and antibiotics. So it's beyond just vaccines, but the main focus is on vaccines. So this was established in 1997 with IFRC Médecins Sans Frontières, WHO, and UNICEF as members. Currently, the focus is on cholera, meningitis, yellow fever, Ebola, so basically 4 diseases. But there are ongoing discussions to expand the number of vaccines being managed by the ICG, but that has not happened yet. But we are likely going to have hepatitis E very soon, and dengue is also being considered. But at the moment, at least, we have 4 diseases that are being managed. It brings together partners to improve coordination and epidemic preparedness and response, basically, and works on forecasting licensed vaccine stocks. And this licensed vaccine stock issue is really very important, which is one of the reasons why other diseases for which vaccines might exist but they are not licensed have not been incorporated. And this also allows for negotiating prices through the networks that the partnership deals with. Next, please. So basically, on the need for vaccine stockpile, we have, first of all, an outbreak or that needs a response. And for some, there are unpredictable demands. It does not mean that once you have outbreak this year, it's likely that you will have next year. So the demand for vaccines may be very unpredictable. We have not had Ebola outbreaks for a number of months now. And you can imagine a stockpile being kept for that. And for other diseases also that are under the ICG mechanism. So there is an unpredictable demand because you can't predict when the outbreaks will happen. And looking also at reimagining pathogens, because you don't know which is the X outbreak or that we might end up having. And also borders around security or global health security issues and bioterrorism, and certainly the issue of supply shortages, which is actually why the stockpiling is done. If the quantities of the vaccines produced for the specific diseases were in large numbers, there wouldn't have been the need for the ICG mechanism. Next, please. So, as I mentioned, the ICG for meningitis started in 1997. Then yellow fever was added in 2001 and cholera in 2013. And the most recent being the Ebola virus disease with the Ebola vaccine in 2020 when the vaccine became available. And the stockpile is evaluated every year by the ICG mechanism based on utilization, trend in utilization over a number of years, and also what the focus is in terms of the likelihood for the need for the vaccines or the occurrence of the outbreaks. And based on the epidemiological data, number of outbreaks, vaccine demand forecasting, market shaping, and the stockpile then can be increased or decreased depending on the historical use. Next, please. So in terms of the mandate of the mechanism, the core mandate of the ICG is to make available and ensure equitable access to licensed vaccines for the 4 diseases that I mentioned, and seeks to ensure timely and targeted deployment of vaccines that can be used effectively in emergency settings where they are where they have the most need, so to say. And the mechanism also manages the global emergency vaccine stockpiles, and working with partners, donors, and manufacturers determines their size and composition. So basically, it's similar to what I mentioned earlier in terms of what quantities the stockpile should be. Next, please. In terms of objectives, it's basically to ensure rapid access to vaccines, and soon I've mentioned the number of days, and injection materials where they may be needed during emergencies. And not only vaccines, as I also mentioned earlier, but maybe some treatment drugs, as might be with the case of meningitis. Then to optimize the use of vaccines in emergencies when supply is limited, as we have seen with the frequent cholera outbreaks in a number of countries, but also the number of countries ending up having cholera outbreak in the midst of very limited supply. And then to coordinate interagency efforts in preparing for and responding to epidemics and other public health emergencies, such as humanitarian crisis. Next, please. In terms of guiding principles, is basically around equity, rapid, timely access, and interdependence, and independency also. Equity based on public health priorities. So it's basically that the distribution or allocation of the limited doses is based on evidence and need. And also, we have been mentioning about timely response to outbreaks since this meeting started yesterday. And so the arrival of vaccines within a defined time frame is very important once the approval processes are followed. Then effective outbreak response where it is most needed is also very necessary. In terms of the independency, decisions are made independent of political or economic influences. It's basically based on rational determinants, so to say, in terms of response to public health emergency. Next, please. Criteria for ICD membership, basically international public health agency or international non-governmental organization that is supporting countries on health-related matters irrespective of any other consideration, basically. Then active role in disease response. Basically, agencies and organizations that participate in disease response and control interventions. And commitment and daily availability. Basically, this is talking about membership especially. You can be consulted at any given time to support the mechanism. And respect of data ownership and confidentiality. Agencies must commit to respect the confidentiality of country data. And lack of conflict of interest as well. No involvement in the vaccine industry as a for consultancies or other related issues that can cause conflict of interest in terms of the size of the doses that will be required for the stockpiling or any other consideration that can influence the decision in terms of the work of the ICD. Next, please. There are 4 core members and one on observer status. And the core members are basically IFRC, Medicines Sans Frontières, UNICEF, and WHO, as mentioned earlier. And Gavi is part of the group as on observer status, and I'll mention more on that later. Next, please. So the ICD mechanism, next. Basically, looking at stock management and the forecasting that is done for whatever, for either of the 4 antigens that mentioned. Then there is the storage of the doses that are stockpiled. And initially there is an ICD request following an outbreak in a country. And this is probably the first line of that triggers the response mechanism within the ICD. And timely request is really, really very important. And as you saw in some of the earlier presentations today, sometimes it takes very long to confirm the outbreak or go through the detection process, and then it takes a number of days again to go through the application process. And this is really what we are trying to address as much as possible. There is the interagency partnership council of that is the Interagency Partnership Council, yes, of the IA 2030 that has set up a task team to look at why we are having delays in responding to outbreaks. And one of the areas is really the application submission, detection of the outbreak, and then the time it takes to submit the application. There are a number of buckets, and even after the approval, when the vaccines arrive in country, before the response activities are initiated, sometimes it takes long. Then once the
the Zoom has gone down, but do keep presenting, and we're trying to get your presentation back quickly.
Right. Then the issue of the decision making, which is basically the discussion within the ICG membership to sometimes request for additional information from countries before approval. And one way that has been employed of recent to address that is having a call with countries so that within that call, a lot of issues can be clarified. Then once approval is given, UNICEF goes through the procurement process and then the deployment of the vaccines to countries. And then financing is discussed in terms of how much funds will be made available to facilitate the response or operationalization of the doses that have been made available. Then the campaign implementation itself, and then monitoring and evaluation. So these are buckets that we go through in the response with the approvals for the ICG. Next, please. And the stock management is basically, next, please. It's preferable that the stockpiles are kept by the manufacturers rather than having a physical store to keep the doses. And that's because of the second bullet, which is makes it quicker for delivery from point of production to point of utilization, but also shelf life optimization, so that if the doses are about expiring and they have not been found any use, basically meaning no outbreak has been reported for that particular disease, then the manufacturers can sell off that stock and replace it so that there is no loss under the circumstances. And some injection materials are also kept in the Copenhagen supply division for use. Next, please. In terms of the criteria for release, basically, it is specific to each disease, mainly based on epidemiological situation, as mentioned earlier, and evidence of an ongoing outbreak, and laboratory confirmation of the responsible pathogen, basically. Then intervention strategy, there may be need for treatment, drugs, vector control, sanitation. So basically to say that it's looking at the full picture, not just focusing on the vaccine alone. And we know, especially for the sanitation issues with the cholera outbreaks, it's really a very important component of the response. Then it also looks at whether there are pre-existing vaccine stocks in country. And if that is the situation, then it enables knowledge in terms of, or assessment in terms of how much additional doses will be required to facilitate the response. But that also means that a response can be initiated as quickly as possible. Then feasibility of conducting a vaccination campaign, basically looking at the security, local coordination, and partners, implementing partners in the field, and especially in humanitarian settings. This is really very critical. Then the action plan that guides the response, and the issue of storage conditions and other resources that will be required for the response. Next, please. Then how can countries access the emergency stockpile? Basically, once an outbreak is established, the application should be done as quickly as possible. And the timeline for application development is within 7 days of the detection of the situation. And the request is basically circulated among the members, co-members of the ICG, but also with UNICEF supply division so that they can be prepared in case approval has been received, and so they can get in touch with the manufacturers or suppliers of the vaccine as quickly as possible, even before the approval process. Then sometimes additional information is requested from the country, and as I mentioned, this is of recent being supplemented with calls with countries so that the process is facilitated as quickly as possible. And this is something that should be done within 2 days maximum. Then vaccines and injection materials are delivered to the country, and this is done within 7 days of the approval. So basically the whole process takes about 10 days if things are done correctly. But we know that delays happen for various reasons, and some of the reasons have already been discussed earlier today. Next, please. There is the Governance and Oversight Committee of the ICG, which is basically a higher level leadership group that decides on the policies that guide the work of the ICG. And that was established in 2018, and it ensures its independence of the committee, or to ensure its independence, members are not directly involved in the work of the ICG. So it's basically high level management for the core and also the observer group, basically, including all the 5, including Gavi. The GOC basically ensures alignment of the mechanism with the ICG founding principles and advise linkages between activities and decisions in disease control initiatives as well. And the accountability framework sets out the context in which different ICG partners operate, because the ICG accountability framework that guides the work of the ICG as well. And the framework is reviewed or revised, and the latest revision happened earlier this year, at least. Next, please. There are some key performance indicators which I mentioned briefly in the previous slides. Basically, total number of days for the ICG request submission by the country should be 7 days from when the situation that needs to be to determine the request is detected and confirmed. And total number of days for the ICG request to be circulated to all members once it is submitted is within a day. That's why also earlier we said that members should be ready to be reached at all times or at any time, so because of the urgency. Then total number of days for the ICG decision within 2 days. Total number of days for vaccine to be delivered in country within 7 days. And total number of days for the campaign to start, ideally within 10 days. So this was what we have this on each of the members, but I just highlighted this for Gavi, which is basically the main funder of the vaccine stockpiles. So the funds are supplied by Gavi. And it also provides operational costs to support the implementation in Gavi eligible countries, and works with UNICEF Supply Division on vaccine demand forecasting and market shaping. And it is also an observer in the mechanism. So this has really facilitated the availability of the vaccines at all times. And even for in situations where the quantity of the vaccines is increased based on history, it's still Gavi that provides that support. Next, please. Then specifically coming down to yellow fever next. This is basically to give an idea of the number of applications or requests that have been received by the ICG. And you can see that the numbers are really rising compared to what it used to be previously. And it's understandable that we have very large numbers of requests for cholera due to the recent outbreaks. And what countries are encouraged to do is not to wait until large numbers of cases are compiled before making the request. So one country can make several requests within the same outbreak. So it's better to report quickly what the situation is so that the response can be initiated quickly. And what has always been stressed is the fact that an earlier response is better than a later, higher quality response. So it's better to start responding as quickly as possible. Otherwise, the spread becomes more difficult to manage. We have received 71 requests for yellow fever, 40 for meningitis, and understandably fewer for Ebola. But the number of requests for meningitis is also recently increasing. Within this year, we've already received 3 requests. So the numbers are more likely to rise. Next, please. This is just indicating the distribution of requests received by country. 16 country requests, but 47 requests approved. So basically, meaning countries have been requesting more than once, as you can see there. And you can see also the number of requests and the number of approvals. So it's not all requests sometimes that are approved based on the evidence that might be shared accordingly. Next, please. This is basically just distribution by country, and you can see that in 2016, we had large numbers due to the outbreak of yellow fever in Angola. And subsequently, also larger numbers between 2017 and 2018 because of the outbreak reported in Nigeria. Next, please. This is basically indicating the doses approved by year, with the largest number also understandably being the 2016 outbreaks with Angola. But it's worrying that we already have approvals of over 2 million doses in 2024. So hoping that the trend will not continue through the year. Next, please. So basically, this is to give an idea of the number of doses requested and shipped by year, with the requests and the approvals, and also the numbers shipped. Sometimes there are differences between the numbers approved and supplied based on what is available at the time in the stockpile. And it's always replenished as frequently as possible once the available stock is depleted. Next, please. In terms of current challenges and the way forward, next, it's really worrying that some of the countries where the issue is really where their priorities for yellow fever, routine coverage is really very low. So that it makes it very concerning, and also the resultant large and disruptive outbreaks that we have seen of recent. So all efforts should really be made to improve the routine delivery of the vaccine, not to wait until after the outbreaks result before responding. So routine immunization situation really needs to be taken into consideration. And as mentioned also in the earlier presentations, the coverage differentials between MCV1 and yellow fever, which are 2 vaccines given at the same time, is really worrying. And as mentioned, 26 out of 27 countries in the African region have lower yellow fever vaccine coverage compared to MCV1. So what are the likely reasons, and what can we do differently to ensure that the issues are addressed accordingly? Next, please. This is basically just to give an idea, and already approvals for 2024 are for Guinea, Cameroon, and South Sudan. And it's also noteworthy that the response for South Sudan was really, really very well done, and we should really appreciate that as much as possible. The application was submitted in good time compared to what other countries have been doing, And following the initial review, the ICG requested, or rather approved, for more counties, because the request was initially for 3 counties, but because of the risk to 2 neighboring counties, approval was given for 5 counties. But then the issue of challenge with target population, because just as the country was about to start implementing, they indicated that the available doses that were approved could not be adequate for more than 3 counties. So basically issues around baseline population that was used to estimate, to make the estimates in the initial submission. And the country had to request for additional doses, and that was also approved very quickly and dispatched. And so basically the campaign took place within a very good timeline, and at least 86% coverage was achieved in the response. And it's likely that it's actually more than 86% because of the issue with the baseline population between what was submitted initially and what was submitted later. So it's really something that other countries can learn from, and if South Sudan is able to do it, it's more likely that other countries can also be able to do it. And what we discourage as much as possible is delayed submission of the applications, as seen in the recent submission also from Cameroon, because some of the cases were reported as far back as March 2023, which is really not acceptable for outbreaks to happen that long, because then if you make the vaccines available, are you actually responding to that outbreak? Because the cases that could have been prevented would have occurred, and the death that could have been prevented if response had occurred in good time would have occurred as well. So this is basically to go through some of the suggestions or recommendations made in the Guinea presentation, following the root cause analysis, to just make sure that appropriate measures are taken and to ensure that applications are submitted in good time and that the response activities also take place in good time. Next, please. This is just to give you an idea of what happened in the last ICG annual meeting that took place in November 2023, with topics covered being an update on the yellow fever ICG requests, including late outbreak responses. And one worrying issue is also the fact that post-campaign coverage surveys are not being conducted as they should. And because then if you conduct it very long after the survey, then it might not have much value in terms of assessing the performance of the campaign itself. That may be part of the reasons why the preventive mass vaccination campaigns might be implemented in several countries, but then you still end up with having outbreaks in the locations after some few years. Then issues around innovative strategies were also discussed, and one of which is the sex disaggregated tally sheet. And if countries could share their experience with the use of the tally sheet, provide some feedback, that will be really very helpful. And issues around high-risk workers targeting also, that has also been discussed much today. Then findings from 3 evaluations conducted in Guinea in October 2023, which has also been presented today in the presentation from Guinea, and which vaccination response for situations of epidemic potential needs to be adopted. Next, please. And some of the outcomes include the need for support for more country-based pragmatic assessments to help identify locally adapted solutions, because it's not a kind of one size fits all. All responses should be contextualized to the specifics of countries, basically, and also need to better communicate with the Ministry of Health and partners on requirements following outbreaks and the key performance indicators, just similar to what I mentioned earlier, in terms of not to wait after the confirmation of an outbreak before submitting the application, and not to delay until more cases are reported before submitting the requests. More technical assistance needed in countries with weak routine immunization because it's likely that human resource capacity in such countries is also very limited. An agreement to approve requests for preemptive vaccination campaigns in situations, an example being in situations when one confirmed case is reported in a rural setting, because it's likely that coverage in such settings is really very, very low, and so the risk is high. Issue of ICG accountability framework that is to be revised in Q1 2024. Inputs have already been submitted for this, as well as for the revision of the selected key performance indicators. There was also mention for the need for the ICG Secretariat to schedule a follow-up meeting early in 2024 and to discuss longer-term integrated support for Guinea, Central African Republic, and Cameroon. Next, please. So basically to say this meeting took place last week, and where there were discussions on ways to enhance outbreak response capacity in Cameroon, Central African Republic, and Guinea, and also improved communication with ministries of health, WHO country offices around technical requirements and key performance indicators. Basically, the issue of not to wait to act as quickly as possible and respond accordingly. So hopefully this will ensure support for more pragmatic country-based assessments that help identify locally adapted solutions. As I said, it's not one size fits all. Responses need to be contextualized. This is just also the chart below is just looking at current experiences in terms of from in 2023 on onset, between onset of the outbreak to when notification takes place, basically notification submission to the submission of request to the ICG, and then how long it takes for the decision to be made. You can see that the decisions actually are made very quickly, but it's the time it takes before the submission of the request that really takes too long. Confirmation of the outbreak takes between 56 to 61 days, which is really too long. And the response itself takes over 180 days in some settings, which is really something that is difficult to understand and completely unacceptable. Next, please. This is a very important message, just to say that the ICG vaccines can be accessed by any country facing an epidemic anywhere in the world if vaccine requests is aligned with criteria for release. And it's easy to see the statement in light of Gavi eligible countries, but what of non-Gavi eligible middle income countries? They can also access the vaccines from the stockpile, but there has to be a confirmation that they will reimburse the funds for the vaccines. And there won't also be the supplementary funding that will support operationalization or implementation of the response. So this is basically to emphasize the fact that the ICG mechanism is available potentially to all countries. Next, please. In terms of the way forward, it's basically to sustain the gains achieved so far through the strengthening of the partnerships that is able to ensure that vaccines are available and countries can be supported as quickly as possible. Then it's on the side of countries then to play their roles in terms of, but countries and partners supporting them in terms of ensuring that the request is submitted as quickly as the outbreak or event of interest happens. Then to support tailored approaches for at-risk countries throughout the epidemic cycle of response, basically early detection, timely initiation of response, and quality vaccination campaigns. And continue to leverage the mechanism to advance the yellow fever agenda and the full implementation of the ICE strategy So basically looking at all possible opportunities, including the catch-up that we have discussed several times or mentioned several times this morning, and on-site support or technical assistance to at-risk countries. As I mentioned, some of the countries may not have that technical capacity to go through the application process and may also need some support during the implementation. So these are areas where we highly recommend that technical assistance could be given to such countries. And the current focus is on the 3 countries, as we already mentioned. Thank you. Yes, please.
Thank you for this presentation, Mr. Chair. It was very important, I think, for the countries to also understand the mechanisms of the ICG better. For me, it was also very interesting to see, as you presented, that the majority of the approved ICG requests have been in Guinea, Cameroon, and Central African Republic in the recent years. And as you showed, there are also the countries with chronic suboptimal coverages for yellow fever, and also all those points on the delays for the investigation. The decision making, I think, is a very important point that you made, but also challenges with campaigns implementation and evaluation. And I think it's, you know, as you said, is they are repeatedly hit by yellow fever outbreaks. They are also repeatedly hit by other outbreaks, and it's an important point that was brought up by our colleague Nestor earlier. And I really want to commend the ICG decision to ensure that there'll be dedicated in-country support to increase the outbreak response capacities for these outbreaks with a really integrated approach. And being both an ICG member and the leader, I myself, I want to really highlight how it's an opportunity to advance the yellow fever agenda through leveraging existing mechanisms. So it's thank you for bringing that to the I Forum. It's a very important example. Thank you.
I take 1 or 2 comments. Any? Okay, so thank you so much for the comments. And so we'll move into the next phase of our presentations. And we have the first presentation on outbreak detection, which basically fits into what can ensure timely response accordingly. And we'll have the public intelligence in the context of yellow fever outbreaks by Dr. Lydia Alexandrova, who is an epidemiologist and also works on health emergencies program, alert and response coordination, and public health intelligence unit of the World Health Organization. Over to you, Dr.
Lydia, are you online?
I am online. Can you hear me?
Yes, great. Go ahead. Thanks.
Thank you very much. And thank you very much, Chair. And thank you as well, colleagues from the iStrategy, for inviting us to this meeting and for the usual collaboration that we are having during these years. So I will start here. And if we can go to the next slide, please. I would like to start with the IHR, the International Health Regulation, referring to the public health intelligence as a WHO core activity. We can see that this approach is reflected and embedded in the IHR manual under the articles 5.4, 9.1, and 11. And just will mention as well that this is very important because this is the provision of information by WHO, and also it is our mandate to collect information regarding events through our surveillance activities and to assess their potential to cause international disease spread. If we can go to the next slide, please. Thank you. what is, I would like to ask you, what is the public health intelligence? And I know that most of you know what it is, but just for us here as well to mention that it's a core public health function responsible to identify, collect, analyze, and assess a wide range of information in order to detect events early, to enable rapidly control, and to flatten the curve of to reduce health impacts. In the context of the yellow fever outbreaks, this is translated into a collaborative surveillance, meaning the systematic strengthening of capacity and collaboration among diverse stakeholders, both within and beyond the health sector, with the ultimate goal of enhancing public health intelligence and improving evidence for decision-making. If we can go to the next slide. This is a very quick reminder about the international health regulations. So under those, you know that this is an all-hazard approach, and that the state parties are required to develop minimum core capacities for surveillance, and WHO is authorized as well to access and to use unofficial sources of surveillance information and to obtain verification from the member states. If we can go to the next slide, please. Here is the public health intelligence workflow summarized in the table with the 4 main boxes you can see displayed in the slide. Those boxes integrate 4 processes within the early warning system, which are the detection, the box on the top, verification, rapid risk assessment, and reporting and dissemination of the information. I will go briefly throughout each one of them in the next slides, but just wanted to mention that this workflow is producing a result of an average monthly status of around 60,000 pieces of information with 1,000 signals of relevance detected, and with more than 30 information products that are produced following this process. And of course, this is as well embedded through into the yellow fever context and the outbreaks that have been happening throughout the past years. So quickly, if we can go to the next slide, please. Thank you. This is a summary of the table that I have presented before. And as you may see, the first box that was mentioned previously, it was the detection part. So the detection part is what we are doing into the public health intelligence process is to integrate both the structured and the unstructured data originating from either well-defined, mostly health-based official sources, or from unofficial and official sources across sectors and levels. So what we find, usually the EIOS is the primary tool used by the PHI team to conduct event-based surveillance. We detect signals that are potential for acute risk to human health, and we verify those signals under the IHR. This is the main process of the detection that we are doing, and this is also included every day for the yellow fever signals that are detected through the event-based surveillance and our monitoring officers. If we can go to the next slide again. Thank you. So here, as soon as we have the signals, and as explained in the previous slide, what we do, we verify those signals. And once the signals is verified, it is considered an event. Now, not all the events are serious or require WHO follow-up, and it depends on the initial risk assessment that is performed between the public health intelligence team and here in the context of the yellow fever events, we can receive a verification for a confirmed yellow fever cases, for example, in one of the member states. However, this information needs to be analyzed on whether this could be of the potential public health concern. So what we do after this, after a verification and confirmation of an event, we go to the next step. And if we can move to the next slide, please. Thank you. What we perform is the WHO rapid risk assessment for acute public health events. And as you may know, in the context of the early warning system, the rapid risk assessment is a systematic and continuous process for gathering, assessing, and documenting the information that we have. And this guides us in orient the response by estimating the likelihood of spread and increasing the number of cases, recommending mitigation control measures, estimating the potential for public health, for political or media attention, and also estimating the potential consequences for travel and trade. And as well, the most important is that through this document, we are also defining the necessary communication products, including through the international health regulation, to be disseminated to the supranational organization and to the neighboring member states. If we can go to the next slide, here you can see an example of the WHO rapid risk assessment with the main components that are included within this. Okay, I will not enter into details because for us, what is important as well is the next slide, which is, if we can move to it, which is the information sharing principles and again, the international health regulation. So under the Article 11, it is mentioned that the WHO shall send to all state parties as soon as possible such type of information, which is necessary to enable states parties to respond to a public health risk. How it is done? So if we can go to the next slide, please. What we need are the IHR notification, and I would like to highlight this because here you have the summary of how the IHR notifications, and specifically for yellow fever, should be done, because as the state party has some information on this, this should be assessed within the 48 hours when the state party has this information, and should be notified within 24 hours to WHO under the Article 6. I will enter a little bit more in the next slide, maybe, but just to mention that there are four. Yeah, thank you very much. So there is one mean to communicate the information that is coming from the main member states, and this is through the event information site for the International Health Regulation national focal points. This is a secure WHO platform that is accessible only by the national focal points. That is, and also for selected WHO staff and stakeholders, and it facilitates the communication from WHO to the national focal points. The information that we are providing here is information in confidence, and also all the state parties, they get this information to prevent and to prepare to respond to public health events. And here we are referring as well to all the yellow fever events that have been published in the last years. Next slide, please. Again, here I would like to insist on the information that is published on the event information site, and insisting on the Annex 2 of the IHR, that all the events meeting 2 criteria of the Annex 2 of the IHR need to be shared by the event information site. So again, this is primarily, the primary objective is to allow timely and seamless information sharing from WHO to all the national focal points in order to prevent the public health events and to inform. Next slide, please. Finally, within this public health intelligence process, which was the detection, verification, risk assessment, and information product, we see here the last information product that is publicly available, and this is the disease outbreak news. So most of you might know already, but the disease outbreak news is our main product as well. And this is our external WHO information product. We are publishing this since 1996, and so far over 3,000 DONs have been published on the WHO website. It is the main communication product for the public on acute public health events. And we have a diverse audience so far that is looking on this product. There is a short summary, and here is also the web link for this. So you can see all the products, yellow fever products that have been published in the last years. Next slide, please. Here, I just would like to have a little overview of the yellow fever outbreaks for the last 5 years. So it's the period from 2018 to 2022. We are currently analyzing the 23 and 24 period, and it will come shortly. On the left side, you can see the rapid risk assessment that have been published for the period from 2018 to 2022. And what I would like to highlight here is that the yellow fever represented 9% among the 5 most common diseases or conditions for which rapid risk assessments reports were performed between 2018 and 22. That means that from the 270 rapid risk assessment performed, you can see here, 24 were for yellow fever. Also, I would like to highlight from this analysis here that there were 5 diseases that represented or resulted in 56% of all the RRA. And among the 3 diseases that were produced each year, yellow fever was always presented in the 5 years for the rapid risk assessment. If we go further with the analysis by WHO region, this is the right side of the presentation. So if we do the analysis by WHO region of condition or disease for which rapid risk assessment reports were published, we can see that the vector-borne diseases such as yellow fever in the region of the Americas or dengue fever in Southeast Asia were the leading condition resulting in the production also of the RRAs. This is in terms of one of the information product. And in the next slide, please, we can see the rest of the analysis of the public health intelligence product. On the left side, you have the event information site, bulletins, and on the right side is the disease outbreak news. So in terms of the event information site, yellow fever was also among the 5 most common infectious diseases for which an EIS bulletin was published. We had 6% of those, with 32 bulletins published for the time period reflected here. In terms of the DON, what I would like to say is that 40 different infectious diseases were reported in the DON in this 5 years period. And here, yellow fever represented 7% of the or 29 DONs that were published for the period of 2018-2022. In summary, in the last 5 years, there has been an overlap in infectious diseases for which the three main products were produced: rapid risk assessment, EAS bulletins, and DONTs. And yellow fever was among the 5 bulletins most published in for this. And my final slide, which is the next one here, thank you, is just to make some conclusions on what is I have presented here. It is that the public health intelligence is critical for early warning of international public health threats, enabling rapid response. For us, the key enabling factors are the relationships with the countries, the direct support to national authorities, collaboration within and outside WHO with the information, link to all of you and to all the stakeholders for the response actions, to data systems and support. And everything is in order to strengthen the capacity of early detection, verification, and assessment of the yellow fever events, and of course of the rest of the public health threats. Yes, I hope that this could be strengthened as well. On the right side, you have the Global Public Health Intelligence Report with all the data that I have presented so far. And again, thank you very much for inviting me, and happy to answer any further questions.
Thank you so much for that very clear presentation. Lots of things to take home on the public health intelligence component, and the notification by countries, which should ideally be timely, just in the same phase as the earlier discussions today that we've had on responding to outbreak situations. And it borders a lot on the global health security component also, because the earlier situations are detected, the earlier the response, and the information sharing can be as quickly as possible for countries to take necessary measures to prevent further escalation. Any questions, requests for clarification?
I'm checking in the chat. It's clear. No questions on the chat. No, I'm checking here. No.
There's a
Prof. Yeah. Thank you very much. Thank you for your presentation. It's shocking to me that I've spent 40 years of my life with WHO. I never heard of this global health intelligence. I'm just seeing it for the first time when you showed it. I've never seen it. I'm sure I wonder how many countries have also seen it. If I, working in WHO for 20 years, never saw a copy of this. Yeah, I mean.
So basically, the session has at least succeeded in sharing that information, and more of this should be encouraged as much as possible. Yeah. Any other?
Sorry,
okay, thank you so much. Oh, okay.
Yeah. I do receive the tone on daily basis, but I got to be included in the. In fact, I'm receiving it through another colleague. So my question here is to Dr. Lydia. How do we make sure that we are included in the mailing list for us to be receiving the daily signals? I don't know if I've made it clear. Amadou?
Yes, it's clear.
Okay, thank you.
Okay, yeah.
Thanks, Chair, and thanks, Lydia, for the clear presentation. I have a question related to the way your team consolidates the information, no? And I wanted to ask you what do you think is the most challenging issue when it comes to consolidate the information that you receive from countries, no, in terms of a final product? Thank you.
Thank you very much, Joao, and thank you, colleagues, as well for the comments. So the most challenging here is the triangulation of the information and the early receiving of further epidemiological details. If we go through the traditional versus not traditional surveillance, so we are monitoring on a daily basis these signals, and what is important is when we detect these signals and we need the verification, we triangulate the information with all of you. So we share it with the technical team across the 3 levels. We share it as well with our counterparts, and we are seeking further information on this. So the most challenge is to have further epidemiological details on the cases, the laboratory results that are performed. And what I would say as well is for us, it's also challenging, and we aim that the IHR notification should be done in a more rapid way. So this is what we are trying to strengthen here, and I think it is being done so far with thanks of all the stakeholders and all the colleagues and collaborating here. So something again that we need to see how we can improve and triangulate across the information to have the clear analysis of the information that then is shared with all of you. As you may see, the disease outbreak news that is on the public domain, and the other information products that are there, but it's the timeliness, and we need to be conscious of this. Thank you. Bye.
Thank you very much, Lydia. So the 2 key messages are timeliness of information and IHR notification. Correct. Thank you.
There was another question from Ado in terms of the circulation of the dawn. There was a question about how you can make it circulated to wider audience.
Thank you. Thank you very much, Chair, with this. So usually the dawn is published, so there is, so you can always check the WHO site, and I can share it here in the chat. So all the dons are communicated there. Usually there is no email saying this, just because practically during every week there are new events that are published, and it is maybe circulated among the WHO staff in the emergency program by mail, but so far for the rest of the colleagues that are outside of the organization, this is a public in the public domain in the WHO site, and I'm happy to share here the WHO link, so you can check it there. Thank you. Back to you.
Okay, thank you. Yes, please.
Thank you for the presentations, the both of you. Actually, again, a quick clarification on the dawn for those who receive the newsletter. Whatever is related to yellow fever is also published, so it's and relates to our yellow fever products, so it can help on the distribution as well.
Just a provocative question. Have you had situations where your surveillance system was able to detect a situation that the member state did not report as a signal, where there was no signal, but you were able to detect something, an event of public health importance?
Thank you, Chair. Yes, we have done it. I cannot mention here which, where and which country was, but indeed for yellow fever, there were signals that were initially detected, and through the verification process, it was confirmed through the IHR later on. We have several examples of this, and maybe we can discuss in another forum. This in the future would be interesting, and of course for other events that are for arboviruses as well. Under the arbovirus initiative also, it was there were events that were detected apart of all the others, that because we are doing a no hazard approach. But yeah, happy to talk about this in another occasion. Thank you. Back to you.
Thank you so much. I was not expecting a response, but I got one. Thanks a lot, really. We'll shift to the next presentation. Thank you for being with us.
Thank you.
Yeah. So, colleagues, we are supposed to have the panel discussion, but we have a slight adjustment of the program so that instead of the panel discussion, we'll have two presentations. One by Pedro, the second one by William Komakech. In terms of introduction, the first presentation will be on challenges and best practices on yellow fever surveillance, and by Dr. Pedro. Professor Pedro, I won't call the second name. He's a medical epidemiologist, Evandro Chagas Institute, Professor of Medicine, of Pathology, Para State University, International Fellow, American Society of Tropical Medicine and Hygiene, and member of the Brazilian Academy of Science. We are really honored to have you here. Go ahead, please.
Thank you, Mr. Chair. And first of all, I'd like to thank João and Laurence that asked me to do this presentation. And by surprise to me, but so we have a few time, and doing this is more comfortable to me to speak in Portuguese. So I make the presentation in Portuguese. Sorry for French, but I have it has translation.
Yeah.
Yes. Ok. Então esse foi o tema que me pediram. Próximo slide. Next, please. A little bit, um pouco sobre a epidemiologia nas Américas, começar falando sobre os ciclos de transmissão, é diferente na África. Próximo. Next, please. You have here, confuso. Nós temos então o ciclo nas Américas, somente a parte de cima, os dois ciclos, o urbano e o silvestre, é que tem possibilidade de ocorrer, sendo que o urbano, desde 1954, que nós não temos nenhuma transmissão assim confirmada e assumida de transmissão urbana, em que nós temos o Addis aegypti como transmissor, e o homem é o hospedeiro da doença, e a vítima também. Na África ocorre isso também, sendo que essa parte urbana ocorre também nas áreas da savana e periurbanas, né? E há transmissão vertical, por isso essa seta no meio do ciclo, há uma transmissão vertical, transovariana, e atualmente nas Américas nós temos apenas o ciclo silvestre, que nós temos o ciclo feito entre mosquitos e macacos, e o homem, quando adentra na mata não protegido contra a imunização, ele vai então se tornar infectado e pode levar então a várias cidades. Esse é o maior risco de urbanização que nós temos, e nós vivenciamos isso muito claramente nas Américas, particularmente no Brasil, durante a epidemia que começou no final de 2016 e se estendeu até parte de 2019, já envolvendo não só os estados da região sudeste, mas também estados da região sul. A transmissão na floresta se dá basicamente por hemagogos, né, nas Américas, e Aedes africanos na África, que ocorre também principalmente na chamada zona de transição, que foi detectada e demonstrada pelo grupo francês que estudou muito a epidemiologia na África. Na África, nós temos um ciclo silvestre que ocorre apenas lá, que é um ciclo que, digamos, seria mais rural, basicamente, e que envolve uma série de vetores Aedes africanos, sendo o principal, mas temos vários, luteocéfalos, Fucifer, Vittatus, Simpson, do complexo, que são várias espécies, e outros, todos do grupo do gênero Aedes. Next, please. E todos podem ter transmissão transovariana. Aqui nós temos o Aedes aegypti, o transmissor, nessa bela foto do Jean-Paul Hervy. A próxima. Next. O Hemagogos gantinomes, que é o principal transmissor da febre amarela silvestre nas Américas. A foto do Nicolas Degallier, que fez essa foto no Evandro Chagas, em Belém, e ele é do IRD francês. Next, please. O principal vetor está aí nesse mapa em verde, mostrando a distribuição que vai desde a América Central até grande parte da América do Sul, parte do Cone Sul, norte da Argentina, o Paraguai e parte do sul e sudeste do Brasil, nordeste também, e toda a região amazônica e centro-oeste, do Cerrado brasileiro, que corresponde à savana. Okay? Próximo. Next. E os primatas não humanos do Novo Mundo são todos suscetíveis ao vírus da febre amarela, alguns com maior suscetibilidade, como, por exemplo, o aluata, howler monkey, que aparece aí, esse mais escuro à direita, centro-direita do vídeo, e outros como os sebídeos, né, o capuchin monkeys, que são mais resistentes, embora também morram, mas em menor quantidade. O certo é que todos são suscetíveis, e isso é muito importante, porque sinaliza para a vigilância quando ocorre morte de macacos, que pode ser febre amarela. Lembrando que eles morrem por várias causas: toxoplasmose, herpes, raiva, e por outras causas, inclusive por envelhecimento. Próximo. Next. Next, please. Aí é uma foto do mapa, dizendo uma figura concedida pelo Otávio Oliva, que foi da Parlo, mostrando no Brasil Central a ocorrência em azul de episodias confirmadas e em estrelas vermelhas aos casos humanos, mostrando que sempre tem uma proximidade ou simultaneidade entre a ocorrência das episodias, que muitas vezes começa antes, e a ocorrência dos surtos em seguida. Next, please. Um pouco sobre a definição e resumo dos aspectos clínicos. Próximo. Fazer um overview para todo mundo aqui entende de febre amarela, apenas para relembrar, né, a febre amarela. Bom, a febre amarela é uma doença infecciosa, não contagiosa, e que ela tem um aspecto bem sucinto. Ele tem uma viremia curta, que dura no máximo 5 dias, em média 3 a 4. Depois há um período de remissão, e depois nós temos o período de intoxicação, em que se desenvolve sintoma mais grave. Na fase infecciosa, ela lembra qualquer outra doença infecciosa febril, como malária, a própria leptospirose, hepatites e outras doenças. Eu falei essas mais porque são vinculadas a um ecossistema mais ou menos próximo, semelhante à febre amarela. Na maioria dos casos da febre amarela, após esse período de infecção de 3 até no máximo 5 dias, ocorre um período de remissão e o paciente cura, a maioria cura, absolutamente 60%, 70%, até 80% dos casos das infecções curam nesse período. Porém, uma parcela pequena, mas significativa, e que leva a um quadro grave, eles têm essa diminuição da sintomatologia e depois emerge novamente os mesmos sintomas com maior gravidade e se agrega à insuficiência hepatorrenal, que nós vamos ter todas as alterações renais, como aumento das escórias nitrogenadas, principalmente creatinina, albuminúria, ou seja, perda de proteínas pela urina, a oligúria até chegar à anúria. E do lado hepática, nós temos a hemorragia, porque há um consumo dos fatores de coagulação. Lembrando que praticamente todos os fatores de coagulação são produzidos no fígado. Okay? E nessa fase, nós começamos a ter os anticorpos, porque na fase inicial nós não temos anticorpo, apenas a viremia e os sintomas febris, dor de cabeça, mialgia, que corresponde à viremia. E esse aumento dos anticorpos neutralizantes que ocorre na fase de intoxicação não impede, nos casos muito graves, do paciente falecer. Quer dizer, não depura o vírus, né? Não consegue fazer. Next. Então, esse quadro, que é o quadro que preocupa, que é o quadro que leva a óbito de uma doença que é 100% imunoprevenível, né? Que preocupa e é a razão dessa reunião, né, que nós estamos aqui, desse meeting. E aí, nesse slide que a gente publicou há mais de 20 anos atrás, em 2003, na revista da Sociedade Brasileira de Medicina Tropical, mostra justamente a estimativa de infecções assintomáticas, porque a febre amarela, como toda doença infecciosa, ela tem o quadro clássico, que está lá em cima em vermelho, com insuficiência hepatorrenal, que leva à morte, com sangramento, com febre, icterícia. Tem um quadro que é só febril com icterícia, um quadro febril que é muito difícil de diferenciar clinicamente, a não ser durante as epidemias, que nós temos o alerta para a ocorrência de casos mais leves, e as infecções assintomáticas que costumam ocorrer e que não são diagnosticadas, a não ser durante as epidemias. Next, please. E neste trabalho, que eu tive a honra e o prazer de publicar junto com a nossa colega Erin Staples e o Michael Johansson, do CDC, nós fizemos o levantamento de todos os casos diagnosticados nas Américas, durante um período de 1969 a 2011. E bate com aquela projeção, em torno de 13% de doença severa, mais de 50% dos casos assintomáticos são diagnosticados geralmente por inquéritos sorológicos, o quadro febril e a doença que leva à morte, as formas severas, que correspondem a 13%, sendo que a média de morte nesses casos severos dá em torno de 43%. Se a gente for transportar isso para o global, a letalidade cai para em torno de 5%, 6%, que é o que seria aceitável de modo geral. Mas a gente sabe que tem muita subnotificação, inclusive de óbitos. Next, please. Está repetido. Next, please. E nessa revisão do Tom Monath, ele mostra justamente os 3 períodos e o que costuma ocorrer. O período de infecção, em que ocorre o quadro infeccioso, mas não característico de febre amarela, né? Quando ocorre as alterações hepáticas, começam a ter as alterações hepáticas, começa a ter alterações da classe sanguínea e também começa a ter a leucopenia com neutropenia e com aumento de linfócitos. Depois inverte. Quando nós entramos na doença no quadro infeccioso, inverte. Nós temos um grande aumento das transaminases, das aminotransferases, ocorre o agravamento com hipotensão, insuficiência renal, as plaquetas caem muito e normalmente há uma inversão na fórmula leucocitária, com aumento já principalmente de neutrófilos, devido geralmente a infecção secundária associada. Próximo. Next, please. E isso é importante por causa do diagnóstico diferencial da febre amarela, que nós todos sabemos, nós temos uma série de doenças que são febres hemorrágicas, algumas, a maioria viral, mas outras não virais. Leptospirose, febre tifoide, forma grave, sepsis, malária, não são vírus, mas podem simular quadro, principalmente a malária por falciparum, né? E os virais, nós temos o dengue, os filovírus, né, Ebola, Marburg, e outras febres hemorrágicas virais, como arenavírus, Rift Valley, Crimeia Congo, hemorragic fever, e as hepatites fulminantes, inclusive causadas pela hepatite delta. Todas essas doenças podem simular a febre amarela. Então, aí é importante a história clínica, o alerta do médico e a epidemiologia, que tem que estar bem fortalecida para, pelo menos, pensar, suspeitar em febre amarela. Next, please. Também foi publicado no mesmo ano, 2003. Bom, a evolução da febre amarela, que mostra aqui, entre 2007 e 2023, a grande concentração de casos no Brasil, principalmente na região sudeste, um pouco também na região sul do Brasil, poucos casos na Amazônia e no centro-oeste, que são consideradas eram consideradas as chamadas áreas endêmicas no Brasil, né? E nós vemos aqui, ao longo próximo da Cordilheira dos Andes, os casos, não nas cordilheiras, por causa da altitude, mas assim, próximo da cordilheira, por exemplo, entrando não na costa do Pacífico, mas dentro, desde a norte da Argentina, o Paraguai, a Bolívia, o Peru, Colômbia, Venezuela e as Guianas, já na costa atlântica do Caribe, né? Próximo. Next, please. Next. Para mostrar a derrubada de matas, isso sou eu há muito tempo atrás fazendo investigação de febre amarela, para mostrar. Next, please. E essa é uma típica região em que ocorre febre amarela. Nós temos à direita, no painel A, uma área que está parte desmatada e parte conservada. Na parte conservada, se vocês verem bem embaixo, nós temos umas casas, e as pessoas trabalhavam na fazenda, e aqui também nessa área um pouco desmatada, também casas onde os vaqueiros, os agricultores, não eram vacinados e morreram. Mas antes deles morrerem, teve o alerta no painel B, que é o esqueleto de aluata, de howler monkeys, que morreram de febre amarela durante esse surto. Next, please. Então, a epidemiologia é importante. Next. A emergência no Brasil, rapidamente. Next, please. Isso foi o que ocorreu. Nesse período, principalmente entre 2016 e 2018, nós tivemos a concentração absoluta de casos na costa atlântica do Brasil, pegando os estados da região sudeste, Minas, Espírito Santo, São Paulo e Rio de Janeiro. Mais de 2.000 casos já foram notificados, todo mundo já viu. Mas isso, é importante, eu coloquei isso aí, não é para repetir o que foi apresentado ontem, é para lembrar que isso já ocorreu no passado. Next, please. E com certa frequência nessa região. Há uma tendência de vírus. Next, please. Aí, nós temos exemplo na década, isso aí é do Strode, essas duas, da direita, perdão, da esquerda do vídeo, é do Strode, a Bíblia da febre amarela, para aqueles que não conhecem. O Strode é um livro de 1951, mas tem tudo, a clínica, a epidemiologia não mudou, só piorou, né, com o tempo. E à direita aqui nós temos o trabalho do Fred Soper fazendo a descrição da febre amarela sem Aedes aegypti, porque naquela época não se conhecia, em 1930, não se conhecia. O artigo foi publicado em 33, descrevendo no Espírito Santo a primeiro surto de febre amarela sem Aedes aegypti. Next, please. Tem que ser mais rápido. Aí mostrando justamente em 1934, 41, em amarelo, e em preto nós temos de 1951, 53, na mesma região, pegando a coisa. Next, please. É apenas para mostrar que isso não é novo, a vigilância. Aqui nós temos, passando um pouco para a África, mostrando a incidência de febre amarela. Eu gravei aqui duas coisas, assinalei. A letalidade muito variável. Por exemplo, na República Democrática do Congo, a letalidade foi em torno de 10,24. Já na Nigéria, nessa região de Nazide, né, foi 85%, mostrando que há uma variação e provavelmente com diferença de incidência. Next, please. Em Angola, foi a grande epidemia que ocorreu mais recente aqui na África, lá na África, aqui em Angola, mostrando a incidência da doença. Next, please. A evolução na África, mostrando aqui os casos, comparando os casos confirmados e não confirmados, mostrando que tem um número muito grande de casos que são notificados não confirmados, né, que aparecem em azul, principalmente nos últimos anos. Tem muitos casos que foram notificados, que são prováveis casos que foram notificados como febre amarela. Next, please. Aqui, mostrando também, aqui eu gravei aqui, mostrando o número de casos confirmados em relação aos casos prováveis notificados, que dá um percentual muito pequeno, né, abaixo de 40%, e a letalidade está dentro do que se espera, 12%. Next, please. Next. Em relação à vigilância, já foi bastante falado, tem os objetivos que são importantes, basicamente tem que ser rápida para poder mitigar o perigo, o risco de disseminação, identificar as áreas vulneráveis das populações, ou seja, que não estejam vacinadas, que sejam vulneráveis a epidemias, e determinar as prioridades de intervenção e destino dos recursos, tá? E monitorar as medidas de impacto de controle e de prevenção. Next, please. Em relação a isso, é muito importante termos o diagnóstico laboratorial que vai, junto com a vigilância e com os aspectos clínicos, dar suporte para as ações imediatas. Next, please. Ok. Então, aí nós temos, na vigilância, basicamente, tem esse tripé. A investigação epidemiológica, né, a história de viagem, de vacinação, o quadro clínico, nós já falamos, e o diagnóstico sorológico, centrado, basicamente, nesses três métodos. A sorologia, que não dá um diagnóstico de certeza, apenas presuntivo, principalmente se não tem informação segura sobre vacinação. Uma IgM positivo não pode significar um caso de febre amarela diagnosticado como confirmado, é presuntivo. Tá? Mas nós temos o método molecular, que pode ser feito, inclusive, na fase aguda, e a imunistoquímica, no caso de óbitos, né? E o teste molecular é capaz de separar o que é o vírus selvagem os diferentes 5 genótipos africanos e da vacina. O próximo, por favor. Next, please. Isso já foi falado muito, a investigação do caso é importante. Next, please. Next. Diagnósticos já falamos, mas basicamente esse slide é para mostrar a importância. Porque como a viremia ela é curta, se você tem uma suspeita do caso, você tem que colher a amostra nessa fase, nos primeiros dias, que vai permitir o diagnóstico molecular e o isolamento viral por cultura de células, que nem todo laboratório tem, né? É mais complicado, tem a questão da biossegurança, etc. Mas a parte molecular é mais fácil hoje. E a sorologia que vai. E nos casos de óbito, lembrar da imunohistoquímica. Next, please.
Chair, Amadou, Chair, we will need to call time soon.
I'm concluding.
Thank you.
Next. Aí mostrando o diagnóstico molecular, que pode ser feito mostrando os 7 genótipos do sorotipo da febre amarela. 2 na América, que estão em verde, e os 5 africanos que estão em azul escuro. Próximo. Next. I'm finished. Métodos moleculares são fáceis. Next. As for serology. Next, please. Next. Eu vou passar para a conclusão. Isso é o mecanismo como ocorre do tom. Next. É importante que o que nós a necrose merizonal, que era patognomônica de febre amarela, e que no slide B aparece ali em cima os corpúsculos de cálcio, eles são, na verdade, hepatócitos em apoptose, né, que estão bem mostrados aqui embaixo, nesse painel, mostrando as alterações de diversas citocinas que ocorrem durante a tempestade citocínica nas formas graves, em C, o TGF-beta, e em D, a apoptose. Next, please. Essa é a mesma que nós publicamos mais recentemente, há 11 anos, mostrando a insuficiência hepatorrenal. Next. Next. A transferência de casos, já foi falado, de Angola para a China. No Brasil, no Rio de Janeiro, nós tivemos 21 casos, a maioria no Rio de Janeiro, na Ilha Grande, quando ocorreu essa epidemia de casos importados e de disseminação. Next. Para concluir. Em conclusão, nós dizemos que a epidemia que ocorreu no Brasil, ela, em áreas livres de febre amarela por décadas, mostra a dinâmica do processo, e os poucos casos foram notificados entre 2020 e 2023 na região sul e na Amazônia. A ocorrência em cidades grandes, urbanas, como Belo Horizonte, Rio de Janeiro, São Paulo, Vitória, né, é muito preocupante. O risco de urbanização continua alto, principalmente que nós estamos tendo uma grande epidemia de dengue, significando que tem muito Aedes aegypti. O monitoramento dos primatas não humanos da morte é importante, porque alerta para o risco de ser febre amarela e ativa a resposta de vacinação. Os casos de febre amarela têm ocorrido principalmente durante o período de chuvas fortes. Next. E a última. The last one. Tem que fazer análise da migração, porque os movimentos humanos eles facilitam o deslocamento de vírus de um lado para o outro, tanto na América do Sul, em particular no Brasil, e na África também. A reurbanização da febre amarela continua sendo de preocupação na América. O monitoramento do Aedes aegypti, e especialmente na África, é necessário, porque nós temos ainda a transmissão urbana, e o papel do Addis ao PIX precisa ser definido. O alto nível de cobertura vacinal em programas de rotina é essencial para proteger a população exposta, e a vacina ainda é o custo-efetivo muito eficaz. Lembrando que um caso de febre amarela no hospital custa talvez mais do que 100 mil doses de vacina, devido ao custo de uma dose de vacina que é menos de $1. E o preço de um dia na UTI de qualquer hospital, estou falando no Brasil, varia entre 5 e 10 mil dólares. Okay? E todas as epidemias que ocorreram, tanto na América do Sul quanto na África, ser devido à baixa cobertura vacinal. Era isso. Obrigado. Thank you.
Thank you so much. It's basically asking for a presentation for someone who has spent a lifetime on the disease, and it's really not easy to limit, except if the presentation is limited to a certain kind of area. But if you give an open presentation, then certainly it will take long. So we'll go for the coffee break, because otherwise, if we stay longer, then if we reach 4 without taking it, then it will be carted away. So please, we'll take some time off and then come back and continue. 10 minutes.
So as Dr. Morris said briefly this morning, that currently the WHO African Regional Office Emergency Preparedness and Response Cluster is implementing 3 flagship initiatives to make the support to member states fit for purpose. So there are 3 flagship initiatives. One is the TAS, which is Transforming African Surveillance Systems, which I'm going to introduce to you. And this is about strengthening the surveillance system to improve detection, verification, and reporting. And then there is the PROS flagship, which stands for Promoting Resilience of Systems for Emergencies, which is basically about strengthening preparedness and readiness. And then there is the SURGE flagship initiative, which is stands for Strengthening and Utilizing Response Groups for Emergencies. So as the name suggests, it's about strengthening response capacity in member states. Next slide, please. Yes, I want to follow from there. So just to give you the epidemiological context, every year, Afro handles more than 100 outbreaks, disease outbreaks and other health emergencies. And yet many of these outbreaks could actually be prevented, or they are preventable or controllable with proven public health interventions. So the TAS flagship aims to address this challenge and to strengthen capacity to detect and monitor outbreaks, and also address the need for effective disease surveillance systems. Next slide, please. Yeah, so the focus is on strengthening implementation of the integrated disease surveillance and response strategy. As you may know, in Afro, we have had over 2 decades of IDSR implementation since 1998. And now, along the line, there has been 2 revisions of the technical guideline. In 2019, the 3rd generation of the technical guideline was released. And we also note that IDSR implementation capacity varies from one country to another, with some relatively strong while others are weak. And also, since the inception of implementation of the strategy, the landscape has markedly evolved. We have learned from the Ebola outbreak, the big Ebola outbreak 2014 to 2016 in West Africa. Then, of course, the COVID-19 pandemic. And new tools have emerged, which we could leverage on to improve IDSR. Next slide, please. So again, to say that the member states in the region have recommitted themselves to strengthening IDSR through a resolution in 2019, AFR RC 696, with clear targets and milestones. And this strategy was reviewed in 2022, but it was found that there was minimal progress after COVID-19 pandemic. So the next review will be this year. So there's a report which will be prepared to the regional committee, and we want to see what the picture will be like. Next slide. So the TAS flagship initiative was actually developed, like I said, to strengthen public health surveillance and laboratory systems. So it's about reimagining IDSR to enable quicker detection of disease outbreaks and other emergencies, not only diseases. Next slide, please. So these are the objectives. To strengthen national capacities for implementation, scaling up of IDSR, and improving existing laboratory infrastructure and systems, to support countries to modernize data acquisition, analytics, and information technology systems for robust detection and quick action, to support countries to ensure surveillance systems have sufficient staff at all levels that are well trained, and to provide high-level advocacy and policy dialogue for increased financing and positioning of public health surveillance. All in all is to strengthen the national public health surveillance and response systems at all levels for quicker detection of public health threats. So these are the objectives. Next slide, please. So this slide actually is a synopsis of the different elements in TAS. We have the different surveillance systems that will all be brought together under TAS to achieve rapid detection, risk assessment, and event monitoring. And this will also facilitate what Lydia said earlier, production of different public health information products. Next slide, please. So in 2022, the implementation of TAS began, first with 10 countries, and this was later increased to 28. And the point to note here is that out of the 28 countries that are now implementing TAS, 18 of them are countries that are yellow fever high risk. And so far, about 14.7 million US dollars has been disbursed by Afro to these countries, out of which 9.8 million US dollars was to the yellow fever high risk countries. Next slide. So this one is just to show you an example of the country's work plans, because before the implementation of the flagship began, there were missions that were made to countries to introduce the flagships, the 3 flagships. And also that was the opportunity to get the support of the countries towards the implementation of the flagships and initiate the planning process. So countries develop their plans for implementation of the TAS flagship project, the PROS flagship project, and the SAGE flagship project. What I'm showing you here is an example of a plan from a country for accelerating implementation of the TAS flagship. And you can see that there are different objectives in this particular plan. One, supporting scaling up of IDSR implementation. So there are activities like training, IDSR training, mass production of IDSR materials, strengthening supervision, mapping entry points, mapping health units, etc. Then you have activities to strengthen data management and data analytics. So, and all these activities were budgeted, and it was on the basis of that that funds were disbursed to the countries. Next slide, please. Now, every quarter, countries send in their progress report to the implementation monitoring team in Afro to show the progress they have made, the activities that they had planned that have been completed, the ones that are in progress, and also challenges that they may face in the implementation of the project. Now, next slide. So these are some of the main interventions actually for strengthening IDSR. Perhaps I should also add that for yellow fever, the IDSR is actually the surveillance strategy. So by strengthening IDSR, we expect that we'll use the same opportunity to make sure that the component of yellow fever surveillance is strengthened, because IDSR is for all diseases and all threats. So there are areas like scaling up the 3rd edition of the technical guidelines to improve detection and reporting, deployment of new technologies, phone, internet-based systems for timely reporting, improving capacity for data analytics, interpretation and use, constitution and training of rapid response teams in member states for, alert verification, early investigation, and initiation of effective response, supporting sample collection, handling, packaging, shipment, to an operation of the testing laboratory, and also strengthening supportive supervision. So basically, these are some of the key areas that are being supported. And as you can see, these are some of the areas that we believe, if strengthened with a clear vision of improving yellow fever surveillance, we should see positive results. Next slide. So this slide summarizes the guiding principles for successful implementation of the TAS flagship initiative, which include deliberate and intentional quest for results, responsibility and accountability, strong leadership at all levels, sustainable domestic financing complemented by external funding, and then hands on deck at all times as surveillance capacity is always dynamic. We expect to see better planning and prioritization, frugality, transparency, accountability, effective implementation, and supervision of surveillance plans. Next slide. Now, these are some of the achievements that were reported by implementing countries in the first 18 months. At least there was training of trainers in IDSR. Then 6 countries conducted the trainings that had been cascaded to subnational level. Health workers had been trained. Different IDSR tools had been reproduced, and countries established a centralized IDSR management platform in DHIS2. And then some countries also established diagnostic and genomic sequencing capacities, improving data management and analytics, and monitoring and evaluation of performance and advocacy. So these are some of the achievements that came out of the quarterly reports of the countries that have initiated implementation of this flagship initiative. Next slide, please. Now, some other achievements that have been reported in terms of completeness and timeliness of reporting of surveillance data. If you look at the situation before implementation of TAS in May 2022 and after implementation, you can see that the number of countries reporting IDSR weekly increased from 10 to 35 after 12 months. The completeness of reporting increased from 21% to 74% in the same period, and also the timeliness of reporting. Sorry. This also increased from 11% to 63%, which is a big improvement. Next slide, please. Yeah, this is a graphical representation of the timeliness and completeness of reporting. On the extreme left, you have the situation before implementation of TAS comments. You can see that many countries were not submitting their surveillance weekly reports to the regional office. But over time, since the implementation and feedback began to the countries, there has been a tremendous improvement, although there are still areas of improvement. Next slide. So I want to end actually by challenging the countries that are here, because TAS is going to be implemented in all the 47 member states. And this is just the beginning. 28 countries have already commenced. So there are more countries that have initiated implementation than those that are yet to implement. And it will continue in 2024 and beyond. So the question is, how can we as countries, especially the yellow fever high-risk countries, leverage TAS to strengthen surveillance of yellow fever in particular? That's really the challenge that I want to leave with you today. Thank you very much.
Thank you so much for the presentation, which is highlighting the initiatives in the region to improve on surveillance. We've always been talking about integrated disease surveillance, but in practical terms, are they actually integrated? And at least efforts were taken in the course of time to improve the performance of the surveillance system. And TAS is one of the initiatives to try to see results in practical terms. Any comment from the two presentations? Okay. Go ahead.
Thank you very much, Komakech, for a very brilliant presentation. So I just need a bit of a clarification, but maybe it was better directed at the previous speaker. And I want to know, when do we go for a national or regional risk analysis? Is it when outbreak happens in multiple countries, and how many countries does it have to happen for us to take a decision that we are doing a regional risk analysis? Thank you.
Thank you. Mine is a question on the task. Do AFRO receive directly from the countries the surveillance data for yellow fever independently, or is it through the country WHO country office? If so, I remember regularly we report Addis our weekly surveillance report to WHO country office, and WHO country office receives all Addis data. So how could the yellow fever independently be incomplete from other diseases? Or are you looking for the laboratory-based or the case-based data other than the weekly DERO report? Thank you.
Thank you, Chair. Thanks for the presenters. I have two questions. The first one to Dr. Komakech, and I'll make this question in English. I think in one of your last slides, you mentioned that I think 10 countries did trainings, and 6 of these countries cascaded the trainings. And then we saw that it was like an increase in 50% in terms of completeness of the data. No, I think it was before 2022, it was 21%, and later with PASS around 40%, 34%. What do you think it's missing to make sure that this data is reported on a timely manner? And then I'll take advantage that we have Portuguese interpretation here, and I'll make the question to Professor Vasconcelos in English, in Portuguese, sorry. Primeiramente, agradecer ao professor Vasconcelos por ter, pela apresentação, pela discussão sobre febre amarela, que é importante revisitar a história natural da doença. Nós trabalhamos juntos na época que eu estive no Ministério da Saúde do Brasil, na epidemia de 2017, e eu queria saber a sua opinião com relação aos eventos sentinelas, né? Na região das Américas, nós temos as epizootias como um evento sentinela, e a transmissão da febre amarela no continente africano é diferente, nós não temos as epizootias. Em sua opinião, qual seria o evento sentinela na região no continente africano que possa levar o profissional de saúde a suspeitar de casos de febre amarela, ou de que pelo menos o vírus esteja circulando? Obrigado.
Joao, sorry, you'll have to put your question in English as well, because we haven't given people time to switch to the Portuguese channel.
Okay.
Would you mind summarizing?
I will
and then perhaps you can summarize Dr. Petro's response. Thank you.
So my question to Professor Vasconcelos was related to the sentinel events for yellow fever. In the African region, in the region of the Americas, we have the epizootics as a proxy for circulation of yellow fever in humans, and I would like to know what we should consider as a sentinel event for yellow fever virus circulation in the African region. Over.
Okay, no other question, please.
Okay, thank you. Thank you very much for your questions. I think let me start with the question about data being submitted to the WHO country office and not getting to the zero report, IDSR report being submitted, but not getting to the IDSR team in the regional office. So I need to cross-check this one, because what I'm presenting is the feedback that was generated by the Health Emergency Information and Risk Assessment team that ran the IDSR. So it means that if it is not included, it means somehow they don't get the zero reports, because you can see all the countries that submit indicated. So I need to cross-check with the team. I cannot directly respond to this as to why. Now, the next question is about the trainings that have been done, and what still needs to, what is missing, as it were, to improve timeliness of reporting. I think that what we are reporting here is actually the weekly zero reporting, which is based on suspected cases. So what we can tell from the data in the regional office is, for example, that this week, South Sudan, for example, reported 5 suspected cases of yellow fever. So we can be now waiting to get the result from the lab to know whether these were actually maybe serologically positive for yellow fever, or they were discarded. Of course, most of them end up being discarded. So once the results from the country lab comes out as IgM positive, some countries I know, like Nigeria, do PCR. So that sorts out the matter quickly. But if it has to go to the reference lab, sometimes there could be that delay between notification and confirmation. But within 1 week or so, we can tell that during this period, 5 suspected cases were reported in this particular country. So that's where we have reached so far. I think we need to improve on the speed of testing in the country labs, transporting to the reference lab, and getting the results. Now, the first question was on risk assessment, country versus regional risk assessment. You know, in the WHO emergency framework, once you have an outbreak, you have to do risk assessment. Or when you have an event, after the confirmation, there has to be a risk assessment, as Lydia explained, to determine so many things. So, but you have a situation where maybe several countries at the same time have reported the same outbreak. I'll give you an example. In 2021, we had 9 countries that within a short period of time reported cases of yellow fever across West and Central Africa. So the decision was taken by the regional emergency director that instead of every country doing its own risk assessment or whatever, there should be a sub-regional risk assessment covering all the countries in that sub-region. So the health information and risk assessment team conducted risk assessment in all the countries, asking them all those questions. And then, because that is always followed by grading to determine WHO's level of response. So at the time, it was graded as a grade 2 emergency. So again, recently, it was done across several countries. But in situations where you have maybe like one country, then another country, the risk assessment will be done on an individual country by country basis. Thank you.
Thank you, João, for your question. I will answer in English. you are right that in the Americas, all monkeys are susceptible to yellow fever. So that of a monkey is an alert for the possibility of episode of yellow fever. In many cases have been occurred like this. First of all, occurred the death of monkeys, and then occurred the human cases. So the monkeys, that's is opportunity to a quicker response of epidemiological sector. So it's very important. By the way, in the Africa, you don't have this tool, this possibility that the monkeys are resistant to the yellow fever. They can be infected. They have antibody response and they have viremia, although they don't develop disease. This difference probably is due in the timing of coevolution or put together the virus and the host in this case. In the Americas, this was since the slave trade, so less than 4th century, while in Africa probably is for millennium, this relation of coevolution. So this was the reason that the monkeys are not susceptible to die in case of the yellow fever in Africa. So what can be the signal to investigation possible episodes or possible outbreak of yellow fever here in Africa? I think that should be focused on the febrile icteric and febrile hemorrhagic cases. I think the physicians and the epidemiologists should be alert and with open mind to think about yellow fever, not only to malaria, hepatitis, and other hemorrhagic fevers or other hemorrhagic or icteric diseases. So this is important to that we have this feedback and in the remote areas where it occurred the cases of yellow fever. I think that this open a window to investigate and to give a quick response. So another important thing is that the physician and the epidemiologist should be focused to think yellow fever and collect samples to do PCR in serology, and in case of that, the viscerotomy to investigate to yellow fever in this case. I think it is different because while in Americas we can use the monkeys that as a sentinel event, I think in Africa you should have these two possibilities: febrile icteric disease and febrile icterhemorrhagic or just hemorrhagic fever cases that I think it should be hospitalized. So the people that will attend, the physicians and the epidemiological officials should be alert and think yellow fever as a possibility of this case. And of course, laboratory, quicker response to the laboratory to make the diagnosis, to report, and a quick response to control and preventive measures. I think it is. Thank you.
Thank you so much for the responses, but I'm seeing more hands up. Okay, very quick, please.
Can I?
Yes, please.
Yes, thank you very much, Mr. Chair. I just want to come back again a bit on what Komake just said about IDSR and case-based surveillance. I have to make the difference between the two. IDSR is just notification, while case-based surveillance is investigation plus sample collection that can lead to confirmation at the reference lab. But instead of focusing on the long delay in confirmatory process, let's look a bit on the process of collecting samples, shipping to the reference lab in adequate conditions, because it is recommended to ship sample in 3 days. But when you look at that performance, it's less than 40% in almost the whole region. So please, that should be one of our main focus. And also, if you collect samples at the convalescent phases, don't expect the lab to have results in a few days, because those samples will undergo serology testing, like blood neutralization test, which take like 14 days, and you cannot do otherwise. So it's not just the lab is delaying the result, but look back into the surveillance system and see how we can better improve to get quicker results from the lab. Thank you very much.
Thank you. Prof, quickly.
Yeah, quickly. Thank you very much. I think, first of all, since African monkeys are too smart to die from yellow fever, it is left for us who are dying from it to do something about it. And I think the issue is the surveillance. And when we see what has happened with IDSR in Africa, that started in 1998, and we see where we are, then we know where our problem is. Pedro gave a presentation in which he showed the differential diagnosis for yellow fever. It boils down to the lab. Because, I mean, see what happened with, in Nigeria, we report 8,000 cases of Lassa every year. We're only able to confirm 10% of that. The remaining 7,000, what are they? Until we improve our laboratory system and get the surveillance down to the community level. And since, as I said, the monkeys are not dying, it's left for us at the community level to improve our surveillance together with the lab people before we can get through to what we're talking about.
Thank you. So these are basically
so one more point. Do you remember what happened with polio? Polio diagnosis, what happened? There are a lot of the EPI team that went out in the field looking for AFP, and the lab is working. There was a system. Why are we not learning from that? Today, through that system, polio has been eradicated from Africa. What did they do? And remember, during COVID, virtually every country has a lab. What are we doing? Yellow fever lab, we have 2 or 3 regional laboratories or something. Why can't we do the same? What happened with COVID? Why can't we do the same for yellow fever?
Thank you. We run the risk of not getting interpretation by 5:50. So if we continue, except if we are going to accept not having interpretation in the sessions. But quickly.
Ok, merci. Je vais aller très vite. Juste pour, je voudrais aller dans le même sens que Maurice, en particulier pour le Cameroun où la surveillance, la CIM-R est gérée par un service différent du case-based qui est géré par le PEV. Et dans le fond, si on va regarder, le système le plus efficace, c'est le système du PEV, le système qui conduit à des décisions. Et donc, bon, si le TAS pouvait rentrer aussi dans ce cadre du PEV, ce serait intéressant. Nous bénéficions du TAS, mais sur d'autres aspects. Merci.
Merci beaucoup. So, thank you, colleagues. And it just basically emphasizes the need to improve on the surveillance performance accordingly. So we'll now move to the next presentation.
Thank
Since we're not having interpretations until 5:50, I think we should 5:50. 5:50, but maybe we should prioritize countries.
Let's do the countries first, and then
Okay.
you can
And then I can come.
Okay. So basically, because of the time limitation for the interpretations, we'll prioritize countries in the presentation. So the next one will be country experience of assessing the susceptibles.
No, we'll go to Ecuador first.
That is Ecuador.
Yeah, Alvaro is going to present it. Yeah.
Yes, Ecuador.
Sorry.
So we go to Ecuador Ministry of Health, and I will have a presentation from Christina Hacom, Director Immunization Program, Minister of Health, Ecuador. Over to you, please. Okay. Can you hear us? Christina, are you online?
Buenos días, sí.
Okay.
Buenos
Let's-
días.
Right.
Oh, buenas tardes.
Buenos
perdón.
días.
Muy buenos días. Gracias por la oportunidad que me dan de compartir información del trabajo que se viene realizando en Ecuador en virtud de el trabajo sobre fiebre amarilla. Bueno, nosotros hemos preparado esta información en donde vamos a presentar el objetivo de trabajo que tenemos, el histórico de casos de fiebre amarilla en el Ecuador, estratificación del riesgo. Vamos a mostrar información según los cantones, según el tipo de riesgo que se ha identificado en el país, e intervenciones en inmunizaciones, cálculo de susceptibles y plan de intervención. Siguiente, por favor. El objetivo es estimar el riesgo a través del cálculo de población de susceptibles para evitar posibles brotes de fiebre amarilla, realizando un plan de intervención de vacunación en todo el territorio nacional. Siguiente, por favor. Como ustedes pueden observar, el histórico de la situación de la fiebre amarilla en casos notificados en el país desde el periodo del 2000 hasta el año 2023, se han presentado únicamente 6 casos, siendo 2 casos en el año 2000, un caso en el año 2013 y 3 casos en el año 2017. Casos que fueron notificados en su debido momento y confirmados por laboratorio. Siguiente, por favor. Ahora ustedes pueden observar las coberturas de vacunación en el país desde el año 2010 al año 2023 en los niños de 12 a 23 meses de edad. Como ustedes pueden observar en este momento, hemos tenido coberturas de entre el 70 y el 96%, siendo los años más bajos los años post-pandemia del 2021 y 2022. Sin embargo, para el año 2023, hemos logrado recuperar un poco ya nuestra cobertura al 84%. Siguiente, por favor. En este momento ustedes están observando la caracterización de riesgo de Ecuador en el año 2024. El gráfico con el número 1 muestra los mapas de termotipos del país según las condiciones climáticas que pueden favorecer o limitar la transmisión de la fiebre amarilla. En el gráfico ustedes pueden observar en el color rojo toda la zona en donde realmente nosotros podemos encontrar potenciales casos de fiebre amarilla. En el gráfico número 2, ustedes pueden observar la distribución geográfica de primates no humanos en Ecuador. Esto según los datos epidemiológicos de casos de los primates humanos y no humanos en el país. Y como pueden observar, en las dos gráficas, las zonas que están en el gráfico 1 de rojo concuerdan con las zonas que están identificadas la presencia de este primate no humano en el país, así como también la circulación del virus. Tenemos adicional datos disponibles sobre la presencia de vectores Hemagogus, Sabetes y Aedes aegypti en el gráfico número 3. Datos epidemiológicos de casos de bovirosis, dengue, zika, chikungunya. Y tenemos, como mencionaba, nuestras coberturas que ustedes ya pudieron observar en el gráfico anterior y que esto hace que podamos identificar las zonas en donde tenemos que hacer también nuestros planes de intervención. Y estos son los cantones que tenemos nosotros en los bordes fronterizos con Perú, con Colombia y que sobre todo se encuentran en áreas de Amazonía. Siguiente, por favor. En este cuadro ustedes pueden observar al Ecuador en su totalidad y yo quiero indicarles para las personas que no saben dónde se encuentra el Ecuador, que el Ecuador está situado en la costa oeste de la América del Sur. Es un país que mantiene focos todavía de transmisión selvática en la mayor parte del territorio nacional, excepto en los cantones que están en la sierra. Como ustedes pueden ver en la caracterización de riesgo, se encuentra en rojo todas las zonas que se encuentran vigilando y tienen un alto riesgo de transmisión. Sin embargo, todo lo que se encuentra en verde es la región sierra, en donde nosotros tenemos un bajo riesgo. También es importante mencionar que el Ecuador tiene 221 cantones. De estos 221 cantones, 121 están identificados con un alto riesgo. 28 cantones se encuentran con un riesgo medio y 72 cantones, que son los que están identificados en color verde, que se encuentran en la zona de la sierra, tiene bajo riesgo. Siguiente, por favor. La identificación de la población objetivo en nuestro territorio se ha colocado en varias prioridades. Primero, la vacunación documentada en poblaciones susceptibles, residentes en zonas enzooticas y en municipios vecinos. Adicional, la vacunación en viajeros en zonas enzooticas y respuestas a brotes en caso de presentarse. Como prioridad 2, tenemos todo lo que menciona en prioridad 1, más la vacunación sistemática de los niños de 12 meses de edad. Y como prioridad 3, las dos anteriores y todas las personas que residen en el área donde se origina la migración estacional a áreas exóticas y que residen en áreas infestadas con Aedes aegypti. Siguiente, por favor. En el Ecuador se han implementado algunas acciones frente a la respuesta a la fiebre amarilla y se inició en el año 2005 con la campaña en la región de la Amazonía a todos los grupos de edad. En el año 2005 también en zonas de altos índices aédicos en la provincia de Esmeraldas y la provincia de Santo Domingo de los Áchilas. En el año 2005 también se realizó vacunación en zonas con altos riesgos aédicos en Manabí. En el 2007, vacunación en zonas tropicales, subtropicales de la Sierra Ecuatoriana. Vacunación para todos los emigrantes, turistas y trabajadores que van al oriente, a la zona de la Amazonía. En 2007 también, vacunación en zonas de altos riesgos aédicos en la provincia del Guayas, que queda en la costa ecuatoriana. Y en el año 2009 se incluye la vacuna de fiebre amarilla en el esquema regular de vacunación y se coloca a los niños a partir de los 12 meses de edad en todo el país. Y a pesar de esto, se continúa con campañas masivas de vacunación en la provincia de Los Ríos en el año 2009. En el año 2016, una campaña en zonas con altos riesgos aédicos en la provincia del Oro, que es provincia fronteriza con el Perú. Y en el año 2017 se hace una campaña por el brote que hubo de los 3 casos de 3 adultos no vacunados en la provincia de Sucumbíos y se hace esta campaña. Sin embargo, a partir del 2017 nosotros hemos mantenido nuestra vacunación en el esquema regular. Por favor, siguiente. Una vez dicho esto, se ha realizado la estimación de población susceptible en el país con todos los datos históricos disponibles. Se ha hecho un análisis por grupo y por corte de edad mediante la hoja de cálculo que ustedes pueden observar, donde se registraron datos de todas las personas vacunadas por año, por grupo de edad, para estimar el número de personas menores de 60 años no vacunadas. Y posteriormente se ha estimado el número de personas susceptibles, incluyendo el número de personas no vacunadas, así como se ha tomado en cuenta el 5% de personas vacunadas que posiblemente no han desarrollado inmunización. Siguiente, por favor. En este contexto, tenemos nosotros acá la estimación de susceptibles de la población por grupos de edad. Como ustedes pueden observar, tenemos un total de 2.534.910 personas susceptibles. Y al momento se requeriría una vacuna de fiebre amarilla para 2.788.401 dosis. Siguiente, por favor. Frente a esta información y a estos datos y el acúmulo de susceptibles que ha identificado el Ecuador, se ha planteado para el 2024 hacer una intervención en las provincias priorizadas que ustedes pueden observar que están pintadas de color rojo en la Semana de Vacunación de las Américas. Si bien el país ha planteado que en la Semana de la Vacunación de las Américas, en todo el territorio nacional va a trabajar con la vacuna VPH, sin embargo, en estas provincias priorizadas se va a hacer la intervención y eso está planificado, la vacuna ya llegó para poder intervenir en las provincias de Sucumbíos, Napo, Orellana, Pastaza, Morona Santiago y Zamora Chinchipe. Así también para nosotros tenemos nuestro cálculo de nuestra población que le corresponde la vacuna por esquema regular, que son 270.049 niños, pero nosotros como país tenemos una particularidad y es que en el Ecuador la vacuna de fiebre amarilla se oferta gratuitamente. El certificado de vacunación internacional también se lo entrega sin ninguna, sin ningún requisito migratorio y eso ha hecho que nuestro grupo de población en movilidad humana se acerque hacia el Ecuador para ser vacunado y nuestra proyección anual de migrantes es de 210.000 migrantes. Entonces, nosotros hemos planteado un plan de intervención. Este plan de intervención está planificado intervenir hasta el año 2030. Sin embargo, nuestro acúmulo de susceptibles lo tenemos hasta el 2026, la intervención. Esto es lo que quería compartir con ustedes. Y para finalizar, el país, una vez identificado estos problemas, también incluso teníamos un registro antes nominal, pero en papel, ahora tenemos un registro nominal digital y el país entrega ahora un certificado de vacunación digital con código QR para facilitar el acceso y que pueda ser entregado en cualquier momento, ya no solamente en un centro específico de vacunación. Muchas gracias.
Thank you so much for the presentation and very resourceful as well. We'll go to the next presentation, which is from the Peru Ministry of Health, to be presented by Martha Calderon, Center for Disease Prevention and Control, Ministry of Health, Peru. Over to you, please.
Buenos días. Buenos días, Jorge Uchuya, Ministerio de Salud de Perú. Si me da acceso a la pantalla,
Jorge.
por favor.
Okay, Jorge, go ahead.
Ask for the slide presentation.
Hi, sorry, we haven't been provided any slides for this presentation. Okay, great.
So please go ahead and show your slides.
Okay.
Okay.
Can you please authorize him to share the
Bien,
presentation?
buenos
Ya
días.
les- Jorge, ya les van a dar acceso. Un momentito, por favor, para que presenten. Gracias.
No puedo compartir pantalla.
Jorge, si nos escuchas, cambio.
If you can just
le escucho,
stop
pero
sharing.
no puedo compartir pantalla.
van a darles acceso. Un momentito, por favor. Gracias, Jorge.
Gracias. Espero. Bien. Bien, buenos días acá, buenas tardes allá. Je suis George Chuya. Je suis médecin, epidemiologiste du Perú. La presentación la voy a hacer en castellano.
Jorge, ¿nos puedes
Bien.
confirmar que presentas? Perfecto. Gracias.
Buenos días. El Perú está ubicado en Sudamérica, tiene 3 regiones naturales. Costa en amarillo, Andes, montañas en marrón, y en verde, jungla o selva. En el Perú no tenemos fiebre amarilla urbana hace 80 años. Tenemos fiebre amarilla selvática. Esta fiebre amarilla selvática se ubica en zona de selva alta, entre 400 y 1000 metros. No tenemos casos por encima de 1000 metros. Básicamente se da en bosques húmedos, ¿ya? Y hace 80 años no la tenemos en el desierto de la costa. Dentro de la localización de la selva, de 400 a 1000 metros, tenemos 12 valles endemoexóticos. El valle 1, 2, 3, 4 y 5 son los más activos. Entonces, es en Rupa Rupa donde tenemos estos casos. En selva. El país realizó una campaña de control acelerado entre el año 2004 y 2007. Éramos 28 millones de peruanos. Se vacunó a 11.2 millones. La vacunación abarcó a personas de 2 a 59 años. Incluyó zonas de selva y zona de montaña. A población a zonas expulsoras de población y a zonas receptoras de población. No, no vacunamos la costa, el desierto. En cuanto a la situación, vamos a repasar la situación, la vigilancia de casos, la vigilancia de episodios, la vacunación de rutina en migrantes y las campañas que tenemos en adelante. Esto es algo que el Perú ya ha demostrado. Se puede hacer un efectivo proceso de control, en especial si el control es acelerado y abarca grandes grupos de poblaciones. En el año 94 teníamos 100 fallecidos y 400 casos. Este año tenemos un fallecido y 3 casos a lo que va del primer trimestre. El riesgo ha disminuido 16 veces. Entonces, hemos tenido del 2000, en los últimos 24 años, hemos tenido 3 periodos epidémicos. La incidencia después de la vacunación del 2004 al 2007 ha ido cayendo. Antes teníamos brotes cada 10 años. Cada vez esos brotes son más pequeños. Ya no vemos epidemias. Y últimamente estamos viendo solo casos aislados. En cuanto a las defunciones, también han caído. Se incrementan durante los brotes y cada vez es menor en cuanto a cada uno de los brotes. La tasa de mortalidad ha caído y todavía tenemos algo que mejorar en cuanto a letalidad en los primeros casos del brote. El programa de vacunación era muy débil, no llegaba al 25% hasta antes del 2004. Comenzó a mejorar en la campaña del 2004 a 2007. Luego de ello, hemos tenido años con dificultades de abastecimiento y actualmente estamos haciendo el análisis de corte para programar una siguiente campaña. La cobertura máxima fue 91%, la mínima 51%, ¿ya? Y la incidencia ha caído entre 16 y 18 veces. Después de la campaña de vacunación entre 2004 y 2007 para el control acelerado, dejamos de vacunar en epidemias. Luego hemos comenzado a vacunar a la demanda a personas de 2 a 59 años que ingresan a zonas de riesgo. Y desde el 2008 se instaló la vacuna en todo el país. Anteriormente solo se daba en zonas de brote. Tuvimos brote el 2016. La campaña fue en casi toda la región de Junín. Hemos tenido brotes en el 2023. La campaña ha sido en una pequeña porción de la región de Ayacucho. Cada vez son más pequeñas las campañas. Cada vez son más rápidas. Esto es como hemos ido en cuanto a casos en los últimos 24 años. Problemas en el 2023, 2003, 2004, 2005 y 2006, con epidemias, alta tasa de mortalidad y letalidad. Justo cuando estábamos haciendo la campaña. Los otros años con pico han sido el 15, 16, 17. El 19 ha sido un brote pequeño con casos, básicamente casos aislados. Y el 23 ha sido un brote pequeño. Si vemos cómo eran los mapas de mortalidad en el 2002, 2003, estaban en negro las zonas de Cusco, Ayacucho, Junín, San Martín. Ahora vemos que en los últimos años ya no tenemos fallecidos, o al menos más de 2 o 3 fallecidos en estas zonas. Los mapas del 2000 al 2023, al 2019, perdón, han cambiado en relación a lo que tenemos ahora. El territorio que notifica casos es mejor. El territorio que muestra incidencia es menor. Y el territorio que muestra defunciones es mucho mejor. Eh, Tuve la oportunidad de estar en África, en la reunión donde se cambiaron definiciones de caso en el 2010. Y vemos de que ha mejorado bastante todo lo que es el sistema de vigilancia. Y con ella está mejorando muy bien lo que es la parte del abordaje de vacunación para quienes invirtamos en control acelerado. Vamos a tener este camino. El primer y segundo trimestre del año se reciben más notificaciones de casos. Los meses de febrero, abril, mayo y diciembre, por actividades de cosecha, se reciben más casos. Tenemos cultivos como cacao, café, que son 2 veces al año, pero tenemos otros cultivos en estas zonas que es de hoja de coca, que son 4 a 5 veces las cosechas al año. Ello marca la irregularidad en comportamiento de la notificación. Regiones del norte y del centro son las que más notifican. Selva norte, selva centro. El grupo de edad más afectado, de 20 a 39 años. La edad, 26.5 años en promedio. La altura promedio en que se ocurren los casos, 628 metros. Y ocurre en comunidades entre 0 y 100 habitantes. Comunidades muy pequeñas en la parte periférica de las grandes ciudades, lejos de los ríos. El varón es el más afectado, de 15 a 44 años. Las pirámides tienen comportamientos diferentes durante los episodios de brote en relación a los periodos interepidémicos. Para el fortalecimiento de la vigilancia y la respuesta a brotes, vemos de que hemos ido cambiando. En el 94 se atendió cerca de 400 casos con 100 fallecidos. En la primera década de este siglo tuvimos un brote con 100 casos y 12 fallecidos. Todavía teníamos grandes brotes. Los brotes fueron pequeños en el 2016. En el 2019 hemos tenido casos aislados en entornos intermedios cerca a las ciudades, vector Sabetes. Y en el 2024 hemos tenido un cambio. Ya hay brotes muy pequeños y casos aislados, pero que está afectando ya no a migrantes, está afectando a residentes. Ha disminuido en 5 años la mediana de la edad. Se ha incrementado la afectación de mujeres. Y el vector está a menos de 1 kilómetro de la comunidad o está en la comunidad. Sabetes. En función de ello, el 2025 se va a hacer una campaña de cierre de brechas y para el 2026 en adelante se está viendo una campaña masiva de vacunación. Estos eran los brotes del 2005, 10 o 14 horas de camino, perdón, días de camino. El abordaje era bastante difícil. Incluso hubieron poblaciones indígenas completamente afectadas. Esta es la secuencia acumulativa del 2005, del 2003 al 2007. 2005, 2006 y 2007. Periodo epidémico. Tuvimos fallecidos, más de 12 en una comunidad con más de 100 afectados. Comunidad indígena. El otro periodo epidémico es 15, 16 y 17. El acumulativo es el siguiente, 15, 16 y 17. Afectó el centro del país, selva centro del país. En el año 2019 tuvimos casos aislados. Fue algo diferente para nosotros, dado de que estas personas decían no haber salido de la localidad, pero vivían prácticamente en la periferia de la ciudad, cerca a bosque primario. El 18 y 19 fue muy escaso, pero marcó la diferencia los casos aislados en entornos periurbanos. Tuvimos 7 casos. Para todos ellos se hace la investigación y se construye la línea de tiempo. Este es el entorno donde se dio los casos aislados. Tuvimos adolescentes que recién salían de la escuela y niños fallecidos. En todos ellos obtuvimos muestras de hígado, incluso en los domicilios de los fallecidos. Se hizo una investigación entomológica en la zona. No teníamos vigilancia de epizotia. y se capacitó y se recibió apoyo por parte de Brasil para implementar la vigilancia de episodios. Ya en el 2023, en un valle de 180 kilómetros de largo, tuvimos el único brote que hemos tenido en el país. 28 casos, 16 fallecidos. Las investigaciones a esta altura las hace el nivel nacional con el nivel regional en el nivel local. En función de que tenemos ya pocos brotes y gente nueva después de pandemia que era necesario capacitar. En cada comunidad se realiza el censo, el mapeo y la ubicación de niños pequeños no vacunados, de adultos no vacunados, de migrantes ya que estuviesen en esas fechas en comunidad. Para cada caso se elabora la línea de tiempo para ver los periodos de exposición-contagio, periodo de transmisibilidad, seguimiento de colaterales y las actividades de intervención. El año 2023 se focalizó en la frontera entre las regiones de Cusco, Ayacucho y Junín, zonas que tienen problemas de violencia social y narcotráfico. ¿Qué provocó el brote del 2023? ¿Qué ha cambiado? Mucha gente de los lugares afectados.
Please, sorry, we are running out of
No
time.
solo
Can
estaban en
you round
cosecha de
up?
cacao y café, estaban en cosecha de hoja.
Hello, Jorge.
Este
Can you
brote
please
tuvo
round up?
alta letalidad. Ok. El análisis que se hace en el periodo prebrote no solo tiene que ver con coberturas, tiene que ver con la efectividad de la vacunación para el seguimiento de vacunados. Ello se mide por tasa de deserción, tiene que ver con el acúmulo de susceptibles no vacunados del último quinquenio. Y cuando no hay recursos, se prioriza los escenarios de intervención en función de los dos mapas anteriores. Manejamos indicadores de prevención en el prebrote.
Jorge, ¿me
incluyendo el
escuchas?
monitoreo rápido.
Estamos ya fuera de tiempo, Jorgito, si por
Se
favor
hace un
puedes ya
análisis
terminar.
de una matriz intercuartílica para ver quién tiene más riesgo y menos efectividad en la vacunación. Y según los escenarios de intervención, se plantean las estrategias a priorizar durante periodos que podemos carecer de vacuna, personal para la intervención. Todo se hace en un aplicativo, tenemos un aplicativo Lo puede
Jorge, ¿sí
hacer
me
el
escuchas?
país, lo puede hacer la región o lo puede hacer el nivel local.
Creo que está sin audio. ¿Los intérpretes me escuchan?
Durante prebrote también vemos la encuesta de procedencia.
Creo que los intérpretes me escuchan.
Durante el brote, la notificación negativa diaria. Y los análisis de indicadores en el periodo epidémico están relacionados a morbilidad, mortalidad, letalidad, línea de tiempo, cadena de transmisión y las actividades de vacunación, de bloqueo. Finalmente, la búsqueda activa institucional busca entre fallecidos y entre hospitalizados posibles casos que se hayan escapado en función del CIE-10. Tenemos una lista de diagnósticos diferenciales con las cuales revisamos las historias para la posibilidad de otros casos, de encontrar otros casos. Bien, entonces básicamente estas son las actividades de investigación durante el brote, aparte del censo de colaterales, el seguimiento, la clasificación de casos y los indicadores, así como el monitoreo rápido después de la intervención de un brote. Muchas gracias.
Thank you so much. Muito obrigado. I think we should stand up just to stretch. Otherwise, a number of us have been dozing. Okay, next presentation is from the Ministry of Health, South Sudan. Agri, please restrict yourself to 15 minutes for the presentation. Thank you so much. And congratulations for the good response to your outbreak. Over to you. Agri. Can you hear us?
I can hear you.
Okay, thank you.
Good evening, colleagues. I'm presenting on behalf of the Minister of Health. I'm not working for the Minister of Health. The Minister of Health person was to come here. Unfortunately, he had to attend another East African community meeting. So this is the presentation for South Sudan. So South Sudan, we all know that lies in the yellow fever belt, has reported around 187 cases, including 27 deaths in the 3 separate outbreaks in 2003, 2018, and 2020. I don't mention the current one. So in November 2018, there was Sakure Payam, Nzara County. 3 labs confirmed, and there was no death that was reported. In May 2003, Imatong region, Torit County, a total of 178 cases with 27 deaths were reported. And again, in March 2020, in Kajokeji County, Central Equatorial State, cases were reported there as well. Next. Yeah, looking at the map, the far left is the cases that were reported in 2018. And then on the far right is the cases that were reported in 2008. And further south, cases that were reported in March 2020. And these all are in the southern part of South Sudan. Yellow fever surveillance in South Sudan. So the surveillance system implemented at both facility and community levels under integrated disease surveillance and response. South Sudan is adopting third edition, focusing on community-based surveillance, electronic IDSR, EWAS, and others, including DHIS2. EWAS component include indicator-based, that is based on the health facility, and event-based, that is a community-based system. Starting from the community prepare the reports and submit the reports to the health facility upload in electronically, or if there's no communication, they move to the county surveillance officer, and the county surveillance officer upload in the system. Alert verification, county surveillance officer confirms and follows up all alerts from the community or from the facility. In South Sudan, every day we are receiving per each state 3 alerts. That makes around 30 alerts, different alerts, not only yellow fever, and makes in a month around 900 alerts, which is quite a lot of those alerts that are coming. And we are verifying around 70% of those alerts that wherever they come. And samples are collected from all over the country and sent to the National Public Health Laboratory by flights. So samples are tested at National Public Health Laboratory using either PCR or serology, and then also are sent for quality assurance at the collaborating center. Different collaborating centers are available. Now, I talked about surveillance. This map was just is presented to show you. If you look at the the below map, you might see it's green. That is topically, you might think that surveillance is working extra well. Yes, surveillance is working extra well in terms of timeliness and in terms of completeness. However, we have quite a big number of the health facilities that are not functioning. And then looking at the maps above, so you see a lot of red. Those red is the health facilities not functioning, and hence they can't be reporting. Now, what we do in those areas, we are strengthening community-based surveillance following Boma Health initiatives by training and providing them recording and reporting tools, and also motivating them to ensure that we continue receiving a surveillance report. The system is the same, as I said, from the community to the nearest health facility or to the county surveillance officer. Next. So I will discuss about the case study of the recent outbreak in South Sudan. This alert was received in December 21st, 2023, and it started that there was a case of viral hemorrhagic fever, which was involving a 24-year-old male from Kangura village, Gangura Payam in Nyambio County. In the other map you saw on the southern western part of the country, and that's where this case was reported. Symptoms onset were on December 7th. This included the body weaknesses, headache, stomach discomfort, fever, and vomiting. Initially, it was misdiagnosed as a typhoid, but later that's when it was suspected to be viral hemorrhagic fever. And the case was attended the hospital, and then that's when a county surveillance officer was informed, and then informed the WHO, and that's when actions started taking place. As the patient was a viral hemorrhagic fever, the patient was isolated, and all APC procedures were followed, and the blood sample was collected and sent to the National Public Health Laboratory. At the National Public Health Laboratory, these samples were negative for Ebola, Marburg, as well as for malaria, and then was tested for yellow fever with the real-time PCR, and they were and the sample was positive. Further, the sample was sent to Uganda Viral VRI for quality control, and then it was as well in Uganda positive. Later, we received other 2 more samples, which were tested negative at National Public Health Laboratory in South Sudan, and these 2 samples were sent to Uganda, UVRI, and they were serologically were tested positive. This map shows the cases were first. The first case was in Yambio, but with that first case, as you can remember, it was 24th. 21st, 24th was laboratory confirmed that it was reported it was yellow fever, and then we wanted to send the team on same 24th rapid response team, but there was no flights because it was Christmas time. So the team was able to be sent there on 27th December. And when the team arrived, expanded and enhanced surveillance to other contiguous counties. And then by expanding and enhancing surveillance, that's where other cases were identified in those areas. So in summary, 87 total cases, 84 suspected and 3 were confirmed. There were 6 days, case fatality rate was 6.9%. And in those areas, Yambio, where the first case was reported, 48 cases, and then other counties as well reported cases. Age distribution, 78% was 15 years and above, 12% 1 to 4 years. Now, this particular areas, you are looking at the map. At that particular time, we were still again continuing responding to measles outbreak, and that area again had reported an outbreak of viral vaccine-derived polio. So all of these were going within the same area investigation and preparation for response. Outbreak response, as we all know that the major part of yellow fever response is vaccination and vector control. So in addition to case to reduce morbidity and mortality. So immediately we requested an ICG request was placed, requesting over 600,000 doses of vaccine, and which were approved and shipped. And the campaign was done in Yambio, Nzara, Tambura, and which was followed up with the mop-up, and was completed on 2nd March. And then the yellow fever vaccine for Iba and Ezo, these are 2 other counties, already has arrived, around over 200,000 doses. The vaccination is ongoing. Other response activities, WHO supported the Ministry of Health to continue strengthening, enhancing surveillance in other contiguous counties that had not yet reported. And health workers were, sensitization was raised in order to raise their suspicious index, and also in terms of case management, and taking samples and sending the samples to the National Public Health Laboratory. Active case search were as well initiated and then enhanced wherever it was already started. And another success, we engaged partners. Most of health services in South Sudan are provided by NGOs, not by the government. So it was prudent and imperative to involve those partners and to coordinate partners in order to support the activities. And then partners continue to conduct case management and in the designated health facilities in the affected areas. So this is the vaccination coverage. If you see coverage in Yambio, it was 86%, which is completed, and in Zara, it was 92%, and then in Tambura, it was 86%. In Ezo and Iba, it is ongoing. Challenges. As I've mentioned from the first map of health facilities not functioning and the different, the government currently is a transition government, so hasn't taken root. The government investment in health is less than 1% of the national current budget. So, and South Sudan is quite vast. So, putting these challenges in terms of geographical obstacles, there's remote areas, so where there's no access in terms of infrastructure, roads as well as communication means. And then South Sudan has been experiencing a flooding. 2022, half of the country was under floods. So definitely floods affects infrastructure, make the population, force the population movement, and currently in the country there's around 3 million internally displaced population. And then with this flooding and geographically influences the mosquito breeding ground. Socioeconomic factors. There's limited public health infrastructure, as I've mentioned. There's an ongoing conflict in different hotspots in the country, which affecting health service delivery, but also affecting access to those areas. And then the population displacement hinders outbreak tracking. And again, the major challenge, there's a challenge with vector control. Political and security challenges, there's impact of political instability on health initiatives, like those, as I said, the government provide less or allocates less than 1% of the national budget for health. So most of the health intervention are depending on NGOs. And also there's this security concern. There's a multiple and repeated conflicts in different hotspots in the country. Cultural and education barriers. Despite that, when the first case was reported, following it up, people were very unwilling to come to the health facilities for treatment, and also even allowing you to take samples. There was one incident of Minister of Health staff who went, and the villagers were almost attacking them when they wanted to take samples. Health system challenges. I've mentioned the insufficient workforce trained in yellow fever management. There's limited diagnostic capacities. As I mentioned, that it's only one laboratory that all samples have to be taken there. Yes, there's already a good system for timely collecting, storage, and transportation of the samples to our National Public Health Laboratory, as well as also for sending samples outside the country. Now, I mentioned we were facing this in the area 3 outbreaks: measles outbreak, vaccine-derived polio, And then yellow fever. We had a big challenge in vaccine storage capacity in that when everything was happening in that state. So that was again a big challenge during that time. Lessons learned and best practices. Increased reporting performance using
1 minute. 1 minute.
Yes, I'm done. Increase reporting performance using electronic EWAS at the health facility level. Investment in a rapid response team. Remember, when outbreak began, a rapid response team from the state was sent to respond, and also rapid response team from the central government was sent there. And we operate WHO together with the government because the government depends on the support from WHO for transportation and as well as for upkeeping as they go for response. Investment in the laboratory, although it's only one laboratory working, but there have been quite a lot of investment to ensure that it has a relatively performance of the critical test that needs to be done. Public Health Emergency Operating Center is working, and then it has strong in coordinating these multiple partners and multiple emergencies that are in the country. Preventive and preemptive vaccination campaigns have abated the occurrence of the major outbreaks. Launching of the NAPS and multi-sector coordination mechanism led to increased donor support for IDSR. So really donor supporting IDSR, and we have adopted the 3rd edition IDSR, but currently we are analyzing in order to plan new operationalization mechanism for the IDSR, especially to those red areas where you saw they are challenging how to reach far and inaccessible area. And then we engaged health cluster in order to bring partners together to work and collaboration with different partners on the ground. Next steps. South Sudan lies in the yellow fever, as we have mentioned. We need to continue strengthening surveillance through collaboration with the communities and health partners. Continue to strengthen yellow fever surveillance through the IDSR. Advocate for yellow fever vaccine to be part of routine immunization. This has delayed because we did not have NITAG. Now NITAG has been established. We will initiate the discussion and continue with the discussion. Rolling out of the state emergency risk profiling to all state and development of state-specific multi-hazards, at least in 8 states by December 2024. We started in November, and we are continuing rolling out this multi-hazard plans for each of those targeted states. Develop disease-specific country-level plans in at least 12 counties. These are targeted counties that are at-risk counties. Development of a 5-year IDSR strategy. As I mentioned, we are currently doing analysis of the IDSR in order to come up with an operational strategy. Improve diagnostic capacity for yellow fever at the National Public Health Lab, and more investment in vector control. Thank you.
Thank you so much. And congratulations once again for the timely response. The next presentation will be from the Laboratory Technical Working Group on their updates from Jean-François Lemaire.
Thank you very much, Chair, and thanks everyone. It's been a long day, but I hope that you still have some energy to keep focused. There's a lot of progress that has been happening over the course of the last year and in the last 2 or 3 years. And it's really my pleasure to on behalf of the lab working group to present here. So I'm going to be as fast as I can concerning that we have already accumulated some data. So, as you know, there are 3 strategic objectives of the I strategy, and really everything that links to laboratory testing goes into the third one, which is to contain outbreaks rapidly, and everything linked to detection. Next. So there was a lot of numbers already presented by Lawrence and others yesterday, but just wanted to highlight that over the last years and since the inception of the I strategy, we have, over the years been able to detect more and more outbreaks, and that's, in part through the contribution of strengthening laboratories. Next. Okay, just as a reminder, we have 4 different working groups that are really kind of pillars within the I governance structure. And just to continue with my image, if the working groups are the pillars, the foundations are really the support from the regional offices, as well as the country themselves, the member states, which are really at the delivery part of it. So in the countries, I'm including all the laboratory members of GIFLAN, the Global Yellow Fever Laboratory Network, which I have the pleasure to coordinate along with my regional counterparts. Next. So as part of the priorities that we have within the Laboratory Technical Working Group, we're really looking at strengthening laboratory network capacity and really advising member states on the best practices. We do have a very well coordinated network, which is a tier network, which has strong contribution from regional reference laboratories, which are key in the confirmation of cases and also support differential testing. We do help in monitoring, identifying and resolve some performance challenges that we observe within the network, and really we aim to assess the network capacity through different type of activities, including EQA, so that we are always very well aware of where we are in terms of the performance. There are other activities just to support overall surveillance efforts on a day-to-day basis, as well as keeping in mind some landscape on research and development front. Next. All right, so we really need high-quality laboratory diagnostics. I mean, several speakers have mentioned, the biphasic progression of the disease, with, really the first phase of the infection, where we have the viremic phase, where we're able to detect the virus itself, and then we have only later on the rise of IgM levels, where we can actually have serological detection. So that really complexifies a little bit our work on the laboratory side, because that means that we need to have a compound testing and the algorithm, and we really need a critical information on the date of symptom onset to inform which test should be performed on the clinical specimens received by the lab. Reliable, timely, and complete surveillance data is critical to really inform the practices within the laboratory. Next. Okay, I won't read all of this slide, but just to say that we are really working within the lab working group on 4 central themes: scientific and operational support, capacity and sustainability, research and development, as well as advocacy. There's a lot of text, but there's even more work behind each of those checks that you have there. And over the last few years, we've been really adhering to those 4 central themes, having close to 40 work package of activities responding to all of those as part of our annual work plan. Next. So really just here, I won't read all of the names that are on this slide, but we do have an incredibly engaged lab working group with members, individual members that are expert in their fields and are representing different institutes around the world, including in the Americas, in Africa, in Europe, in the US, etc. and really a tremendous support as well from our regional coordinator within WHO, but also through UNICEF Supply Division and under Gavi support. We do have also some technical advisors that directly support WHO in some key technical components. Next. Okay, so this is a slide of where we've been against our 2023 work plan. So we have had a number of challenges in 2023, including significant HR constraints, which really delayed a number of activities that were supposed to happen in 2023, which are now planned for this year. So some of the components that are lagging the most behind are to be implemented this year. But overall, next, that is to say that even if it's only at 59%, we have produced as a working group a tremendous number of high-level products. Here on this side is several different products where we have performed, WHO has performed the kit performance evaluation on 3 different commercial assays, 1 molecular assay and 2 commercial serological assays, and the expert consultation with many of the members of the Laboratory Technical Working Group has been fundamental in helping producing those documents. Next. We have also produced a very key guidance, which is the second version of the laboratory manual for yellow fever. This comes 20 years after the first version and includes updated testing algorithm to account for the compound testing, front-loading molecular testing, taking into account the number of days post symptom onset, etc., and also accounting for the landscape in terms of availability of commercial assays. Next. To accompany the manual, which is a kind of a long-lasting guidance document, we have produced a more succinct document to help member states in implementing what is within the manual, and that's an operational guidance on the use of yellow fever assays. And this document goes a little bit more in detail of specific commercial assays that were recently recommended by WHO, and in particular, when it comes to the IgM serological testing part of the testing algorithm, where we are recommending the serial use of 2 commercial assays with maximizing the performance of each, but also rationalizing the resources. Next. Okay, so we have also, as a working group, developed a very big number of training videos and job aids, and that includes a key component of the upcoming open WHO course on yellow fever, where there will be a module 4 on diagnostic pathways, which includes 3 subsections, which have already been produced and recorded and will be a part of the overall course. We have also developed recorded videos specifically targeting lab focal points on how to use the updated national level testing algorithm, as well as another training of targeting the regional reference laboratories on the confirmatory testing algorithm. And those will be uploaded very soon. We have developed some job aid, as I mentioned, on assay verification. There's been also through some of the key partners, namely CDC, which are part of the working group, but also our global specialized laboratory, and has developed some recorded training videos on the use of the new MAC HD with the new commercial assays, as well as some troubleshooting on MAC HD assays and MAC ELISA assays in general. Next. All right, all of that to say that we have also produced a website specifically dedicated to laboratory aspect of yellow fever, and we call it the iLabs website. And on the right side, there's several subsections, which includes a lot of resources, where we encourage all of you to have a look and disseminate. Next. Okay, so we have also worked on assessing the laboratory performance of the network. So we have in 2022 run the first serology EQA exercise across the global network, including in the Americas and in Africa, and we have the public report that is published on the TechNet iLabs website. We have also updated our checklist for laboratory assessment, and recently we have, through a formal request for proposal, we have been able to select a bidder, which is an ISO 15189 accreditor, an expert biologist that have been identified to support us in performing up to 6 in-person lab assessment per year, and from the second year onwards, 6 remote assessment in addition to that. Next. So what's coming up this year? We do have some regional training workshop to introduce the new technologies that I mentioned, and that's coming up in next month and in June. We are going to transition from in-house serology assay to those quality assured commercial assays, at least in Africa. We're going to be ramping up as well the routine use of molecular testing by national laboratories, which will allow some in-country confirmation of some of the cases, at least, because PCR allows that. We're going to also, in 2024, launch our first molecular EQA program, and we're going to prepare for the 2025 serology EQA program. We're going to look at long-term biobanking of some of key vaccine specimens, and then develop more training videos. We're going to have also some coordination with the WHO Lyon office on some webinars around quality assurance. We're going to update our target project profile to keep the manufacturer alerted on what is needed in the network, and also to keep a healthy commercial landscape. We are going to have a second round of kit performance evaluation for molecular assays. So there are 3 assays that are undergoing performance evaluation as we speak. So we hope that we'll be able to have a good conclusion from those evaluations, so member states have even more choice in terms of selection of the options that they have for commercial PCR assays. We're also going to develop some members-only sections within the iLabs website. We're going to support the update of the WHO surveillance standards on yellow fever, as well as some new specimen collection for an antigen-based assay kit performance evaluation. Next. All right, so this part of the presentation is really around supporting the network itself, because the lab working group really advised the strategy, but it is always very tightly coordinated with the needs of the network. Next. So just quickly, just to say that the current progress within the network is that we have, now 89% of yellow fever cases that are investigated 2 weeks of symptom onset, and that's a major progress from where we were at the beginning of the strategy. We have latest data showing that in average, all of the samples transported to national labs are done within 14 days. 78% of the IgM results are reported within 7 days from sample collection. And we do have 81% of the samples that are transported outside of the country, the regional reference labs that are reaching within 5 days, and thanks to the IOPS mechanism. And then we have 91% of the confirmatory testing that are being returned within 28 days. Next. So really, as I mentioned, the lab network is a tiered network where we do have, in some countries, some national laboratories under the leadership of the national laboratories, and those are all involved in doing the primary testing, when available through PCR testing, and always of course, through IgM serology testing. And then we have the regional reference laboratories and WHO accredited centers that are involved in more specialized testing, namely for confirmatory testing. And then we do have the global specialized laboratory, namely CDC Fort Collins, that are really there to provide technical support, some research and training, facilitating, and then ad hoc requests for specialized tested needs. Next, please. All right, so very briefly, the network has existed since 2005, and it is basically, we are trying to have standardized approach in terms of laboratory protocols, validation of novel methods, and capacity building. This really helps to have a good resilience within a network. So if one lab cannot do the testing, we can quickly turn around and rely on other members of the network. Next. Okay, so basically the lab working group is really trying to address the challenges that are seen within the network, namely, it has been reported before that some of the laboratories were underperforming. So how can we help them better? How can we provide technical support that is adapted to the needs? Some high-risk countries didn't have yellow fever laboratory testing capacity. How can we support in establishing that capacity? We need to ensure sustainability on the financial, human resources, as well as the laboratory staff capacity, which includes not only being able to respond to the number of tests needed, but also on the technical skills side of things. The timely provision of laboratory supply is absolutely key, and that's where our partner UNICEF is. We're very closely collaborating in that, and then we need to make sure that we have good quality around the network, and then we have consistent training so that we have the standardized approach of testing. Next. So I'll just name some key of the challenges that has been reported over the years, and we're a little bit struggling to address just the lab folks alone. We really need support from the surveillance team, the EP team, etc. We are suffering from poor quality and quantity of specimen that reach the lab, and sometimes even impeding the full confirmatory testing and differential testing. So there's so much the lab can do when the specimen is in insufficient volume or is hemolyzed, for example. We also suffering from incomplete case investigation form, where immunization status is not informed, where the date of symptom onset is not informed, or sometimes the case investigation form is just missing. So we're a little bit blind as to know whether a PCR testing is eligible, whether a positive IgM result, what does it mean if we don't know the vaccination status, etc. So I won't go through all of the items, but overall, these are the two key components that will really, if we can vehiculate that as being something that we need to address urgently, that would be really important. We'll continue to strengthen our linkage between the surveillance and laboratory teams, and also trying to keep yellow fever eye up on the agenda in terms of priority, despite other diseases also competing with priorities. Next, please. So I just want to highlight some key successes that we have had over the last year. We really had a multi-year support agreement that has been signed with all of the 3 regional reference laboratories. So that's really, really important, because that's the regional reference laboratories are key for the confirmation of cases. So to have them under an agreement, a financial agreement, ensures that they can actually operate, and then we don't have a rupture in terms of our capacity to provide those services. We also had a PRNT workshop that was hosted by UVRI in Uganda, and this is a extremely high technical workshop that we have brought a number of the different RLs to harmonize our practices and to build capacity for that highly specialized testing. We have had increased collaboration, coordination, and support among and between the RL. So we highly value the South-to-South collaboration. We have had some labs receiving lab members from other RLs and vice versa. So this is really, really great. We have shown that we have a strong network resilience in terms of ensuring the ability to test, no matter different challenge that we may, or one specific lab may may have. We have improved percentage of concordance between the IGN results obtained at the national level and those obtained at the regional reference level. And that's really important to highlight, because that means that the capacity of national labs to perform correctly and having accurate results for serology has improved over the years. So that's really paying off on all of the efforts, and in particular through our regional lab coordinators really working day and night with each of the national lab to help them improve the overall quality. We have excellent progress in reestablishing guarantee capacity at CPC, and we're hopefully able to resume that very, very soon. We have 81% of all samples transported to the regional reference lab reaching less than 5 days, as I mentioned, thanks to the IOPS, and we have 91% of confirmatory results returned within 21 days. PRNT takes time, and confirmatory and differential testing test time, so we are happy that we are within our KPI. Next. Okay, so I just wanted to highlight again this slide, and I've put the link there. So there's the new laboratory manual for yellow fever. It is currently online in English version. We're hoping to have in a week or two published the Portuguese, Spanish, and French edition of the lab manual. It's finalized. We're just waiting for validation to put it on the web. The operational guidance on the use of yellow fever assays has been published in the 4 languages that I mentioned. And just want to highlight as well the iLabs website resource that is there, which has a number of other resources that are listed there. And next, finally, I just want to acknowledge a large number of people that are behind the work of the Lab Technical Working Group, all of the efforts that have been done as well for our colleagues in the surveillance team in revising the testing algorithms. We really went out of our way to come with a global testing algorithm which tried to incorporate all of the regional particularities, including also in the lab manual some key elements that are more relevant to countries in the Emerald region, for example. So really a big effort across various members within WHO, outside WHO, etc. So on that, I really want to thank everyone. And we do have a Q&A section only on labs tomorrow. Thank you.
Thank you so much, Jean-François. And the lab confirmation is really a very critical step in the chain of events to the response, understandably. And thanking our interpreters ahead of time. So can we put our hands together for them, please?